have to go by the end.
Sit in order, please.
All right, good morning, everyone. So we're going to have all the speakers come up to the stage. So hi, everyone. Welcome to day 2 of this conference. So today we're going to get started with a neuroimaging session. And so my name is Patrick Lau, and I'll be chairing with
Catherine Koenig.
All right, and so today our first speaker is Brian Gordon, and he'll be talking about the comparisons of tau PET imaging in Down syndrome and autosomal dominant AD.
Okay, thank you guys this morning for coming out for what I'm sure for many of you was a very late night. So it's always, I appreciate it when you wake up for an 8 a.m. session. And today I'm going to be talking about tau PET in both Down syndrome and ADAD. And to start off with the disclosures, it's really more than anything more my pleasure to be able to give this talk because it's pooling data from 2 large consortiums and it represents a huge amount of work. Mostly you have to thank the participants from these 2 large consortiums. So this is work coming from ABCDS, which was coming from both the ADDS and the NIAID that were merged, and through a marriage to ABCDS, which is this large consortium within the US looking at Down syndrome. And then for me, I come from the DIAN side where I work. I'm a core leader and a project leader for both the DIAN observational study and the DIAN TU. And that this work is a product of a series of publications led by Beau Ances, who's also going to speak this session and was the co-senior author on this work with me. This is the 3rd paper in that series, which we'll talk about a little bit. And then Julie Wish, who was the senior scientist, who was the first author in this paper. So again, I'm very happy to present on behalf of these groups and these individuals. And a lot of this goes back to, kind of why we're here, and fundamentally this idea proposed by Juan several years ago that there's very similarities between the temporal cascade of these biomarkers between both Down syndrome and ADAD. And I'm coming again from the ADAD side, but many of you, this is very highly familiar for you. And again, I think there's a lot of similarities, and we talk about this kind of qualitatively, and this series of papers that we've been working on has been trying to test this empirically. How similar are the temporal cascades between these 2 genetic forms of AD? And one of the papers that we did this before the tau PET, the most recent one, and to kind of call back to some topics that we had yesterday. So first, what does amyloid accumulation look like in both Down syndrome and ADAD? So here in these 2 lines, in this kind of purple line, you have ADAD mutation carriers. In this case, we're going to use this estimated years to onset. For ADAD, this is based upon familial mutations, information we know. For Down syndrome, it's an imperfect measure. We're using an average age of onset, which is why we're also, for some of the analyses today, we're going to use amyloid as the x-axis rather than EYO. But for a conceptual metric, this works. And what you can see is amyloid accumulation begins about 23 years in ADAD before individuals become impaired, and a little bit less, a little bit downstream in Down syndrome. But an important topic which was briefly touched upon is the idea that we talk about ADAD sometimes as a homogeneous construct, but within it we actually have these different point mutations that can be grouped into based upon codon 200 or based upon where in this case often the pre-signaling mutation is. And so again, consider that there's a lot of heterogeneity within these trajectories, which we've discussed a little bit but bears further consideration. This work was done in Beau's lab by Anna Boerwinkle. Okay, and then from my side, I've been doing a lot of work with tau PET in both sporadic and familial AD. This was a paper that I put out a couple years ago, and something that was a striking feature was that 2 things. First, familial AD has much more tau pathology at the point of impairment than you get in sporadic AD, and then phenotypically you also get a spatial shift in the pathology. So in late onset, the hallmark is pathology that is primarily in the lateral temporal lobes with a little bit in the medial parietal. Versus in familial AD, what you get is the largest and the most salient feature is in this medial and lateral parietal, although you do also get substantial pathology in the temporal lobe. And again, same pattern, just a little bit shift in the locus. This is very similar to what you see in amnestic early onset, where you get a more cortical presentation. And then in parallel, Matt Zamet, when he's looking at Down syndrome, is seeing a very similar effect, where as you go through these Brock stages, which I would argue Brock actually does not work particularly well for either of these forms of the disease. It's just not the spatial propagation of tauopathy that you get. Why we get this spatial shift, we don't really understand. I have some working theories, but as a field, we don't really have a good consensus for why you're getting this spatial shift. And again, we get a similar thing in Down syndrome where, again, you have this temporal pathology that's prominent, but you also have this equally prominent parietal pathology. So qualitatively, there's some similarities, but in this project, we wanted to explicitly say how similar are they. So again, this is the goal. So we've pooled individuals from both ABCDS and Diane. We've reprocessed all the data so that it's completely harmonized. A limitation, we have to use the same tracers, so we're down to PIB and AB45. The numbers of individuals we have is modest, but I still think is a worthwhile examination. And these are the three main questions we're going to look at. What's the overall spatial pattern is kind of what we're seeing in the separate analysis recapitulated in this harmonized analysis. What's the temporal progression of these patterns? And then what's the relationship both in time between amyloid and tau? What's that amyloid and tau relationship? So visually, this is an image made by my staff scientist, Diana Hobbs. On the top, individuals with Down syndrome. On the bottom, individuals with ADAD. And what you can see is, again, this characteristic medial and lateral parietal pathology. You also have some occipital pathology, and again, this prominent medial temporal. So similar to what we already saw in these separate publications, very clear qualitative similarity between these pathologies with a greater medial parietal and lateral parietal presentation. This is just another rendering, a surface rendering. For this cohort, you can see the Diane people have a little bit higher pathology when it auto-scaled, but again, there's a small number, so we're going to look at this as a function of amyloid to understand who gets greater levels of tau pathology, ADAD versus DS. But again, you can see this very prominent medial and lateral parietal presentation of tau pathology in both forms of the disease. Okay, so then to do this temporal ordering, we're going to describe people as being positive or negative in every single ROI. We're going to do this using a Gaussian mixture modeling with two components. Individuals that fall into the upper Gaussian, we're going to call elevated. Those in the lower, we'll call normal. We're going to do this for every single region. And then what you can do is basically count what percentage of your population demonstrates abnormal pathology in a particular region. The higher frequency of abnormality, we're going to infer that's an earlier temporal stage with the idea that that's where the first seed was, and then it's going to spread out. So we're just going to order the regions by the percent of individuals that are abnormal, and then from that, we're going to do this temporal staging. So in this case, we're going to roughly break it into quarters, and we're going to put those into stage 1, 2, 3, and 4, and color code it by that. And we're going to do this ordering separately for both ADAD and DS so that you can just visually pick out the stages. Okay, so for Down syndrome, something that's very prominent that pops up to draw your attention to is that there's very, very early subcortical in both the basal ganglia and then with the entorhinal and the amygdala. There's lots of tau pathology that occurs very early there. And then again, you also see in this case, this would be in the precuneus, and then the lateral parietal regions pops very early. Downstream of that, you have more pathology in the temporal lobe and then also throughout the parietal cortex. So again, very, very prominent subcortical in the temporal lobe, and this lateral parietal is what's earliest. And then again, you have this prominent temporal pathology that comes along as well. The pattern in ADAD, very similar, slightly shifted. You have less of the subcortical pathology, both in the basal ganglia and in the temporal lobe. And it's a little bit popping more strongly in this medial and lateral parietal regions. But overall, very similar with the difference that you have a little bit more early pathology and kind of what I would consider more of a classical late onset pattern, this more of an emphasis on the temporal lobe, which is a little bit less so in ADAD. Okay, so what about that relationship against amyloid? So here we have EYO. So we will often do something, we will determine the EYO point where the mutation carriers, or in this case, individuals with Down syndrome, differ relative to familial controls. So for Down syndrome, what we tend to see in these temporal lobe regions is that, so this is for entorhinal cortex, you have the two different lines. This is the difference between the individuals with Down syndrome and the familial controls with the confidence intervals around here. When the confidence intervals of the difference no longer overlap 0, we're going to say that's the point where they're different. For the entorhinal cortex, what we see is there's a very short gap. Basically, abnormality in amyloid and in tau are occurring very close in time. We can now, so in that same region for autosomal dominant AD, what we actually see is there tends to be a temporal lag of about 7 years between when amyloid shows up and when tau shows up. And this is a consistent phenomenon across many of the regions. that this lag between early amyloid and tau is shorter in Down syndrome relative to ADAD. So here's a number of regions: entorhinal cortex, precuneus, fusiform. All regions that have these two regions are very prominent. This is a region that's a little bit later in both. And what you can see just by looking at the gap between the black lines for ADAD on the bottom and Down syndrome on the top is that consistently across all the regions, the lag between initial amyloidosis and the presentation of tau is shorter in Down syndrome. So this goes back to the idea that is it showing up as a more kind of aggressive phenotype relative to something like ADAD, which is already more aggressive relative to load. Okay, so that's the timing. So what about the relative amounts of pathology? So again, here's amyloid now in centilloids rather than EYO. This is tau on the y-axis. And what you can see is for a given level of amyloid, individuals with Down syndrome tend to have more pathology. This is entorhinal, which is one of those areas that pops early for Down syndrome, but not for ADAD. Here are other regions that are abnormal for both. And while they start at about a similar relationship, the Down syndrome tends to outstrip ADAD, and for a given level of amyloid has more pathology. So as a takeaway, what do we see? So the patterns are similar, but they're not identical. Again, we have more of a temporal lobe and a subcortical presentation in Down syndrome. The other big thing to note is that the tau accumulation appears to be much more aggressive. So there's a shorter lag and there's more pathology that occurs in Down syndrome, which has clear implications for when you need to intervene with anti-amyloid drugs, and also potentially questions about the dosages that you would need to accumulate. That window for effectively altering the curve is probably reduced in Down syndrome relative to something like ADAD. And again, these are much more aggressive than we typically see even for sporadic. Why is this occurring? We're not quite sure. It could be that, as we've talked about, there's other things on chromosome 21 that are coming into play. Also, this idea that, although we do have individuals that have APP triplications, that's the vast minority of individuals in DIAN. The majority are PSIN1, and then even within PSIN1, there's lots of heterogeneity. So they're similar but not identical. There could be differences in comorbidities. We're not sure. And that this paper is accepted currently at Lancet Neurology and comes out next week. And then taking off my hat as a researcher and more as an administrator for DIAN, I want to advocate all the data that I'm presenting on can be requested. This is at least a small subsample of the data that exists: imaging, CSF, genetics, proteomics. If you have questions about this data, I would love nothing more as a leader of the imaging corps and a member of DIAN to make sure that this data is shared widely, which is kind of, again, why we're here today. So again, making this offer that if you have interest in this data, I can run you through the data request process, or you can ask me questions about the data. And that's it.
Okay, our next speaker is Patrick Lau from Columbia. He's going to be speaking on longitudinal changes in neuroimaging biomarkers of small vessel disease by sex and APOE genotype.
All right, great. So thanks for that introduction, and thank you for the opportunity to speak today. All right, so I'll be talking about some of the ABCDS data that Brian just mentioned. And so as we kind of talked about throughout this whole conference, what we can do is use the fact that there's a very consistent age of onset in adults with Down syndrome and adults with autosomal dominant AD in order to use temporal information to kind of understand what's going on with the disease process. And so with autosomal dominant AD, we can use that estimated years of onset. And then with Down syndrome, what we can do is we can also use chronological age, because that overproduction of amyloid occurs from birth. And so a lot of these models have really focused on amyloid and tau as kind of the pathologies of Alzheimer's disease, as well as the neurodegenerative and cognitive consequences. And so today I'm going to try to show some data about cerebrovascular disease biomarkers and how they might fit into this to kind of mirror what we've heard yesterday about kind of blood-brain barrier dysfunction, vascular disease, and sort of these inflammatory pathways. So here are the 4 MRI-based biomarkers of cerebrovascular disease that we look at. And so here's a quick schematic of how cerebrovascular disease, which is kind of encompasses a bunch of different things, might converge on Alzheimer's disease pathology. So first, we look at white matter hyperintensities on T2 flares, and this might represent small vessel disease or microvascular hypoperfusion. And so this could directly lead to synaptic dysfunction, neurodegeneration, and cognitive impairment, but it might also converge on tau phosphorylation. We also look at enlarged perivascular spaces, which could be related to toxin clearance, microbleeds on susceptibility-weighted imaging, which could represent amyloid beta accumulation in the vessels, particularly in like the occipital lobe, as well as infarcts, which represent large vessel disease. And it's a little bit less clear where infarcts would fit in the schematic, but likely from kind of the strategic infarct literature, it might just kind of converge on neurodegeneration. And what we can do is, in the absence of kind of causal models, so in adults with Down syndrome who do not have a high prevalence of these vascular risk factors, we can kind of use the temporal ordering to understand kind of what's happening, the temporal ordering kind of going from top to bottom here. So what we did is we had participants across these 4 different diagnostic groups, from cognitively stable to MCI Down syndrome to possible AD dementia and definite AD dementia. And I'm basically showing the 4 biomarkers here, so hyperintensities, enlarged perivascular spaces, microbleeds, and infarcts. And so for each of these biomarkers, we can see that there's sort of this monotonic increase across these different diagnostic groups. This was not significant for the microbleeds, and this might be because the susceptibility-weighted images that we use are just kind of more susceptible to motion. And basically, we had no microbleeds in this possible AD dementia group, but missingness for the SWI was related to older age, and older age is related to kind of these diagnostic groups. And so these 3 biomarkers were significant across diagnostic group, but the only one that survives age adjustment is white matter hyperintensities. And so when we break hyperintensities down into different lobes, what we see is that it's basically most prominent in the parietal lobe. And there's a little bit of evidence for the occipital lobe as well, and this is sort of this posterior distribution that we see in autosomal dominant AD as well. And so what we did next, so something to point out is that in this cognitively stable group, the values were non-zero. And so this was a subset of older participants, older than 40 years old. So even though they were cognitively stable, they still had hyperintensity. So what we wanted to do is we wanted to figure out at what age that these hyperintensities emerged. And so we used ABC-DS data, where we have participants as young as 25. And what we did is we just tried to model this against age. So we used a piecewise regression and tried to estimate an inflection point at which the slope became non-zero. And so for each of these biomarkers, they're starting to emerge sort of in the 30s. And again, when we break down the hyperintensities by lobe, there is some regional variability, but we kind of lose that posterior effect here. And then I think what's important is we can also do the same thing with amyloid, tau in early Brock stages, tau in middle Brock stages, and tau in late Brock stages, to kind of anchor these inflection points with kind of what we expect in the Alzheimer's disease progression. And so here I'm showing the schematic again, and I'm just going to order temporality from top to bottom here. So we saw the inflection points were earliest for infarcts and enlarged perivascular spaces, and those preceded the inflection points for amyloid deposition in both the vessels and the parenchyma. Kind of like what Brian showed earlier, this was kind of at the same time as early Brock stage tau, and also white matter hyperintensities. And then these were followed by the inflection points in middle and later Brock regions. All right, so that's all kind of using cross-sectional data, right? So the next step would be to kind of look at longitudinal data within participants. And so to do this, we had a subset of the ADDS data. So again, these are the older adults with Down syndrome. The average age was about 50. So follow-up time between scans was about 1.2 years, and this is kind of the breakdown of their diagnostic group at each visit. So Most participants were cognitively stable at baseline and follow-up. About 10% converted from cognitively stable to MCIDS, and so on. And no one really reverted kind of backwards in that progression. All right, so again, I'm just kind of showing this by lobe. I guess a few things to point out are that the rate of hyperintensity development. So first, let's focus on the box plots with the single asterisks. And so the reference group here was the cognitively stable group. And so essentially the rate of hyperintensity development was greater in kind of later stages, like this AD stable group, or potentially the MCI to AD group, across the different lobes. And when we adjusted for different vascular risk factors like hypertension or hyperlipidemia, all these results stayed there. If anything, they kind of shifted a little earlier. So those double asterisks are a little bit earlier than these single asterisks. And then when we split this by sex, men are shown in blue and women are shown in red. And so the difference was really apparent in kind of that later stage, the AD stable group, where women had a greater rate of white matter hyperintensity development compared to men. That might have been a little bit more apparent earlier on, but it really just becomes significant at the later stages. And then when we do the same by APOE4 carriership, what we see is that APOE4 carriers have a faster rate of hyperintensity development compared to non-carriers, and that was significant in the MCI stable group. Again, there might be some evidence of it happening earlier, but it becomes significant at that stage. I do need to point out that there was some groups where APOE4 carriers had a slower rate of hyperintensity development, and so I think that might just be something due to sample size, and we just need to dig into that further. But also important is to point out that in the non-carriers alone, we still saw this increase of hyperintensity rate across disease groups. All right, so in conclusion, the rate of hyperintensity development was greater kind of in these later stages compared to the cognitively stable group. This was independent of vascular risk factors, which has been shown in late onset AD as well. We saw that it was greater in women at later stages, and this has also been shown in late onset AD, although the mechanisms are still kind of unclear at the moment. And then what's interesting is we saw that the rate was greater in APOE4 carriers, again at earlier stages, and that kind of mirrors what APOE4 does in amyloid burden and its, I guess, age of onset. What I found interesting is that we don't necessarily see a main effect of APOE4 on hyperintensity volume, yet here we were seeing an effect of APOE4 on the rate of hyperintensity development. So we know that APOE4 has an effect on amyloid and its accumulation, so it might be affecting CAA, which in turn CAA can be a partial mediator of these hyperintensity volumes. So it might be kind of going through that pathway, but we'll need to kind of dig into that further. But even in the absence of the APOE4, this was happening a faster rate of hyperintensity accumulation across disease groups. Yeah, so with that, so thanks to the participants and their families for their time and commitment. Thanks to the ABCDS team and the labs of Adam Brickman, Liz Head, and Donna Wilcock. And thank you for your attention.
Okay, our next speaker is José Enrique Arriola Infante, and he'll be talking about pattern of brain metabolism in individuals with Down syndrome and the association with sociodemographic variables and Alzheimer's disease stages.
Well, good morning. Thank you for the introductions, and also thanks to the organizers for inviting me to present here our work. In the model of Alzheimer's disease, hypometabolism assessed by FDG-PET is altered following the development of amyloid and tau pathologies, but before the onset of cognitive decline. The typical pattern observed in sporadic AD includes mainly the lateral and parietal structures as you can see here. And also FDG-PET is useful for distinguishing MCI due to Alzheimer's disease from other possible etiologies. As all of you know, people with Down syndrome, due to the extra copy of the APP gene, are at ultra high risk of developing Alzheimer's disease dementia through their lifetimes. And what do we know about FDG-PET and Down syndrome? Different studies have assessed the association between age and metabolism in Down syndrome in different regions as posterior cingulate or Landau regions, and also voxel-wise, as in this work from Lau. The different authors have reported a negative association between age and brain metabolism in this population. Also, the hypometabolism is greater in Down syndrome individuals with dementia in many areas, mainly in temporal and parietal regions, as was reported by Juan Fortea in this work. So less is known about the exact pattern of metabolism across the different stages of Alzheimer's disease, and also about the relationship with other Alzheimer's disease biomarkers. Our objectives were to assess in a large cohort the effect of age and other demographic variables on brain metabolism in Down syndrome, to explore the pattern of metabolism across different clinical stages of Alzheimer's disease in Down, and also to study the associations between these metabolisms and Alzheimer's disease fluid biomarkers. For that purpose, we included participants with Down syndrome from the DAPNI core at our center that were classified regarding the clinical stage in asymptomatic, prodromal, and demented. Also, CSF biomarkers were assessed, including the Aβ 42/40 ratio, p-tau, and neurofilaments, and cognitively unimpaired healthy controls from the SPIN cohort at our center were used as control group. The FDG-PET images were acquired in two different scans following the international recommendations. The 2-1 images were processed in CAT12 and co-registered with each subject's FDG-PET image. All of the images were put into a common space, and intensity normalization was applied using the PONS as a reference region. Finally, smoothing was applied, and these final images were used for voxel-wise analysis conducted in SPN12. We used t-test to assess the effect of sex and to do group comparisons, ANOVA for study the effect of intellectual disability, and by regression we studied the effect of age and the associations with the different CSF biomarkers. So finally, we included 72 healthy controls and 100 individuals with Down syndrome. Within them, 63 were asymptomatic, 13 were prodromal, and 24 had dementia. The asymptomatic Down syndrome participants were younger than the other three groups, and as you can see, there were no difference between groups by sex, intellectual disability, or APOE status. So first of all, as we expected, in healthy controls, age was associated with a loss of metabolism in more anterior regions, mainly in lateral and especially medial prefrontal areas, as you can see. In contrast, the pattern observed in Down syndrome was much more extensive, affecting also more posterior regions, mainly the temporal and parietal structures. Indeed, when we statistically studied the interaction, the negative effect of age was greater in the Down syndrome individuals in these lateral and temporal temporal and parietal structures, as you can see, and in a small cluster in the left frontal. We did not find an effect of sex in brain metabolism of Down syndrome individuals, and also we did not see any difference when considering the 3 clinical stages separately. We also did not see an impact of intellectual disability in this brain metabolism in Down syndrome individuals. Regarding group comparisons, first of all, when we compared the prodromal individuals with the asymptomatic ones, we observed a pattern of hypometabolism in medial parietal structures, mainly the posterior cingulate, and in 2 small clusters in the right angular and inferior temporal areas. In contrast, when we compared the individuals with dementia with these asymptomatic ones, the pattern was much more extensive, affecting predominantly these medial parietal areas and these lateral temporoparietal structures, as you can see here. At the end, we compared the individuals with dementia with the prodromal ones, and we did not see any difference, but as we were using a very restrictive threshold, we repeated the analysis using a more liberal approach, and some difference were seen in this right posterior parietal and inferior temporal regions. Finally, regarding the association with CSF biomarkers, who were assessed in a subsample of 79 individuals with Down syndrome, we saw a great and positive association with the A-beta 42/40 ratio, negative and even stronger with the p-tau, as you can see here, and still greater with the neurofilaments, as you can see at right. Secondly, we repeated the analysis, putting all the 3 biomarkers together in the same model, and as you can see, while almost all the effect disappeared in the case of the ratio and the p-tau, it was maintained in a greater proportion, in the case of neurofilaments. So, in summary, the age-related hypometabolism in Down syndrome is greater than in healthy controls, mainly in these areas, in the temporal and parietal regions, and most likely is due to the Alzheimer's disease pathological process. We did not see an effect of intellectual disability or sex, in line with this previous work conducted at our team, where the authors did not see an effect of sex in brain metabolism and also in other Alzheimer's disease biomarker. In individuals with Down syndrome and dementia, the pattern was this, mainly in the medial parietal and lateral temporoparietal structures, and it closely mirrors the pattern that has been reported in several studies in sporadic Alzheimer's disease dementia. Regarding the hypometabolism in medial parietal regions, it was the pattern that we observed at the prodromal stage in Down syndrome. This medial parietal area has also shown to be the first region affected in carriers of autosomal dominant AD mutations, as was reported by Gordon and colleagues, and also these medial parietal areas are ones of the affected in mild cognitive impairment due to Alzheimer's disease, to sporadic Alzheimer's disease. So hypometabolism in medial parietal regions appears to emerge early in both sporadic and genetic forms of Alzheimer's disease. Finally, as you know, we saw the strongest association with neurofilaments, as was expected, since neurofilaments are a biomarker of axonal loss, and this is consistent with previous works, as this one from Moscoso and colleagues, where they find a similar association using, in this case, plasma neurofilaments in accord of sporadic Alzheimer's disease dementia. So FDG-PET seems to be a sensitive biomarker to detect Alzheimer's disease-related neurodegeneration in early stages in Down syndrome population. Thank you very much. Thank you to the rest of my team, especially to my supervisor, Dr. Bejanan, and also to the patients and their families for all this help. Thank you.
All right. So for our next talk, we have Dr. Alejandra Morcillo-Nieto, and she'll be speaking about medial temporal lobe volumes as biomarkers for early Alzheimer's detection in Down syndrome.
Hi everyone, thanks for the introduction, and also thanks to the organizer for giving me the opportunity to present this result here in this oral presentation about the medial temporal lobe atrophy in Down syndrome. Well, as all of you know, the tau neurofibrillary tangles are one of the hallmarks of the Alzheimer's disease, and it initially starts in the medial temporal lobe. Specifically, follows the Bragg stage. At first, is deposited in the transentorhinal cortex, then followed by the entorhinal cortex and the, the hippocampus subfield, and finally progress to the neocortical areas at later stages of the disease. It is therefore that, not surprisingly, that the atrophy in the medial temporal lobe is one of the core features in the Alzheimer's disease and is an early event in the disease course, emerging even years before on the symptom onset. Moreover, you know that the hippocampal atrophy is an established biomarker for neurodegeneration in the ATN research framework. So, the medial temporal lobe in Down syndrome is also a common finding, and we can see in this study from our group, using a visual rating scale, how the atrophy increased across the AD clinical stages. Also, there are few studies that assess specific regions of this medial temporal lobe, for instance, the hippocampus and the entorhinal cortex, and we can also observe this decrease in the volumes metrics. Other studies also assess the association with age and reported an decreased atrophy with age in some region or some structure of the medial temporal lobe, such as the hippocampus and the posterior parahippocampus gyrus. Finally, it has also reported that the atrophy in the medial temporal lobe is greater in Down syndrome than in autosomal dominant AD. However, little is known about the specific sequential atrophy in these medial temporal regions and its association with fluid biomarkers in AD. So, therefore, for this reason, we aim in this study to first assess the effect of the AD clinical stage on volume or thickness of the medial temporal lobe regions in Down syndrome. We also aim to evaluate the relationship between these regions with fluid AD biomarkers, and finally to determine which medial temporal lobe regions are most suitable to predict the AD symptom onset. In our study, we include 248 adults with Down syndrome from the LATNI cohort and 128 euploid cognitively unimpaired participants from the SPIN cohort. So we can see as in Down syndrome, the average age is around the 47 and significantly young, and they are significantly younger than the healthy group. 40% of the subjects were female, and most of them were at asymptomatic stage. We have 142 asymptomatic at the asymptomatic stage, 39 at the prodromal, and 67 at the dementia stage. All the participants underwent neurological and neuropsychological evaluation, and to the diagnosis of the AD symptoms, in a consensus meeting, were classified into this asymptomatic, prodromal, or AD dementia. We also use to assess the global cognition, the CANCOG test. most of the participants had a CSF biomarker for amyloid beta 4240, phosphorylated tau, and neurofilament proteins, and all of them underwent an MRI protocol, including a high-resolution T1 scans. So the medial temporal lobe segmentation was performed using the automatic segmentation of hippocampal subfields, ASH, developed by UPenn. We use a T1 atlas, including the gray matter and the white matter, to improve the segmentation of these specific regions. And also we use a newly developed script from Paul Juszkiewicz to extract the cortical areas to some specific regions. So here we have an example. This is a T1 from a Down syndrome subject, and below we have the segmentation of the ASH. So this pipeline allows us to extract the volume for the hippocampus, divided into anterior and posterior, and also extract the thickness for entorhinal cortex, parahippocampal cortex, and also the perineal cortex, divided into Brodmann area 35 and Brodmann area 36. These values were transformed to WR score to adjust for confounding variables. So briefly, for each region of the medial temporal lobe, we performed a regression model using the euploid controls as the reference group to assess the effect of this variable, the age, the MRI protocol, and when we work with the hippocampal volumes, we also use for the total intracranial volume. Then the parameters of this model were applied to predict the values for the Down syndrome individuals, and with these values we compute the W score. The idea is the W score represents the deviation of one Down syndrome subject with respect to the healthy group, taking into account this covariate. So now, going to the result, first we aim to assess the effect of the AD clinical stage on these different medial temporal lobe regions, and we use the Kruskal-Wallis Atum test as the statistical analysis. So here we can see the anterior and posterior hippocampus, the entorhinal and parahippocampal cortex, and the Brodmann area 35 and 36. The x-axis represents the clinical diagnosis. We have in gray the healthy controls, in blue the Down syndrome individuals at asymptomatic stage, in red prodromal, and in green AD dementia. The y-axis represents this W score, and you can see that the average values of this group is around 0, because it's the reference group that we take to compute these values. So if we focus first in the difference between the control group and the asymptomatic stage in the Down syndrome, we can see a decreased volume in the anterior and posterior hippocampus, while the entorhinal cortex, parahippocampal cortex, and the Brodmann area 35 present a higher cortical thickness in this region at the asymptomatic stage. So now, looking within the Down syndrome population, we can see a progressive pattern of atrophy across the AD continuum, with at the dementia stage significantly greater atrophy with respect to the other to the asymptomatic and prodromal stages, and we also found only the posterior hippocampus to differentiate between the asymptomatic and the prodromal. We also aim to evaluate the association of these regions with the estimated years of onset. So to compute the estimated years of onset, to compute these trajectories, we use the lowest model for each different regions, and for the estimated years of onset, we take as mean age the 53.8 that has been previously reported in a meta-analysis from our group. So we compute the different for the different regions an inflection point to define the moment in which these trajectories change. So we can see that the first region is the entorhinal cortex with a decline around 16 years before the symptom onset. This is followed by the posterior and the Brodmann area 35, 3 years after, then the anterior hippocampus, and finally the parahippocampal cortex and the Brodmann area 36, around 10 years before the symptoms onset. We also can see that these regions that we previously saw in the box plot for the parahippocampal, entorhinal cortex, and Brodmann area 35 presented initial values greater than the haploid population. Also, we show that these trajectories are not linear and they present an increase in thickness before this decreasing after the inflection point that we identify. So our next step was to evaluate the relationship between the CSF biomarkers with these medial temporal lobe regions, and we found significant association with the posterior and anterior hippocampus and the Brodmann area 36 with the ratio of amyloid beta 40 to 40, phosphorylated tau 181, and also with neurofilaments. And we also found an association between the entorhinal cortex and the phosphorylated tau. The strongest association was presented by the anterior hippocampus. And finally, we aim to determine which of the medial temporal lobe regions could detect the prodromal AD state. So to do this, we perform a statistical model using all the different medial temporal lobe regions, and we include some demographic and clinical variables such as age, sex, APOE status, intellectual disability, and also the score of the Hancock test. We use the Badward statewide regression to compute the best model that is able to predict the prodromal AD state, which include the posterior hippocampus and age. So in these rough curves, we can see the different performance of the medial temporal lobe regions to differentiate this asymptomatic to the prodromal state, and the best region were the posterior hippocampus, but the area under the curve is not very high. However, we can see that our model, including the age, has a better performance. So in summary, our main findings were the sequential atrophy of the medial temporal lobe regions, which seems to start in the entorhinal cortex 16 years before the dementia onset, followed by the entorhinal cortex, followed by the posterior hippocampus and the Brodmann area 35. These results demonstrate that in Down syndrome, the atrophy of the medial temporal lobe is an early event. We also found nonlinear age-related trajectories of some regions. In particular, we found that parahippocampal cortex, entorhinal cortex, and Brodmann area 35 in Down had a higher, thicker in Down syndrome at earliest stage around the 20s. Also, we found that this region presents an initial increase at earliest stages until the 40 years. So actually, looking to the literature, as these areas we work with thickness, we also want to assess this analysis using volume, and we got the same result. So looking for the literature, we found that the parahippocampal gyrus in Down syndrome present higher volume with respect to the haploid population, and in this study we expand this region to the entorhinal cortex and the Brodmann area. However, we don't know the exact reason to this increase. So a possible explanation could be that it reflects some developmental specificities in Down syndrome, and it's also possible that this increase in thickness is a reaction to the early deposition of amyloid plaque that we previously found in our group in other AD forms. So we should be further explore this analysis. And thanks for the attention. Sorry. And I don't.
Okay. So finally, we have Beau Ances from Washington University talking about cortical thickness along the AD continuum in Downs.
So it's great to be here, and I just wanted to thank our organizers, Dr. Fortea and Raquel and others, and everybody else who's been really doing an amazing job here today and yesterday for this great conference. And then all of our other groups, and including a number of our industry colleagues who are here today, it's really a pleasure to be presenting. I'm going to be talking and nicely complementing two of the previous studies that you've just been seeing with either FDG-PET or with even looking at the medial temporal lobe. And we'll be talking about brain structural changes in Down syndrome, and then we'll be comparing it as what Dr. Gordon was also talking about and comparing it to autosomal dominant Alzheimer's disease. Just to go back, this is just me being a mouthpiece. It's really James Kennedy, if you can see in the bottom right-hand corner, that's been really doing a lot of this exciting work. This is the funding, and first, being here and being here with Juan and others here, you've already seen that there are both cortical and subcortical changes, and some of that was just already highlighted earlier in the disease, earlier in the talks. In particular, you can see this atrophy that is seen throughout the brain, but there is a large amount of cortical involvement. And if you can see in the middle sides of these figures, you can see that these are earlier changes within individuals, and then you've seen many of these curves that have already been presented over the last 2 days. A lot of the work has been focusing on that yellow area, the hippocampal volume, and you heard a really nice talk just before of looking at these different structures of the hippocampal volume. We've been really interested in trying to say, yes, there are hippocampal changes, but what are those kinds of cortical changes? And what you can see with Down syndrome is that multiple regions are affected within these individuals. Now, within autosomal dominant Alzheimer's disease, Dr. Gordon and others and colleagues of ours have been really trying to compare that with late onset Alzheimer's disease. On the left-hand side of this figure, what you can see is those areas that are primarily seen in autosomal dominant. Those that are seen in blue are with LODE or late onset Alzheimer's disease, and those that are in both, you can see that there is some overlap, but there also are some differences, and particularly in autosomal dominant, there's a lot more of this posterior dominance that's present. And what's also different is that in LODE, there seems to be a lot more of a temporal involvement compared to what we see in autosomal dominant. So similarities and differences. And then on the right-hand side, you can see that based off of Randy Bateman's work and others and Diane, again, a focus on the hippocampal volume with potentially, as you just heard before, maybe somewhat of an increase before then a decrease that's seen in these individuals. So again, comparing and contrasting these two disorders. So our aims were really defining the optimal cortical signatures and looking at thickness and then looking at some of these subcortical volumes. And then what is important to us is that, yes, the hippocampus is very important and it can be important for diagnosis, but are there other areas that can also improve our sensitivity to detect these early changes? And so we did ROC curves for defining these different stages, similar to what you just saw presented before. We either looked at cognitively stable individuals who are amyloid negative, cognitively stable individuals but amyloid positive, so this would be a preclinical kinds of stages, and then those that have impairment, either MCI or dementia, who are also amyloid positive, so impaired amyloid A beta positive. And then we're going to compare and contrast on the third part of this, what are the signatures that we're deriving here compared to what we see in autosomal dominant Alzheimer's disease. So we really based a lot of this work on a previous paper by Eileen Dinser and others that compared load and autosomal dominant. We used the ABCDS, the full spectrum of our preliminary baseline data from ABCDS. And then we looked at group differences. We used free surfer at the vertex level, and you can see how we defined amyloid positivity. And then we did holdouts. So 20% of the cognitively stable A-beta negative group were withheld to avoid biasing. And then we couldn't do this because we have much smaller numbers of individuals who are either cognitively stable A-beta positive or impaired A-beta positive. We're then going to look at the vertex level analysis, correcting for age and sex, and then we're going to look at different kinds of conservative thresholding, and you can see the different thresholds that we did. And then we're also looking at different cluster sizes based on multiple comparisons. So with regards to determining the cortical and subcortical maps, for our cortical regions, we use the optimal cortical maps from those six statistical thresholds. The subcortical, we also looked at from correcting with intracranial volume, which we already heard about before. And then we did Cohen's d's, effect sizes for differences between the groups. And then we looked at these spatial correlations between the various groups, as well as then between also in our last part with autosomal dominant. And for our autosomal dominant, we already used images and calculations that have been done in the Dinser paper and compared it and thresholded it to the same thresholds that were done with that paper. And you can see the effect size maps were thresholded at about a 0.2 millimeter thinning. And then we did these spatial correlations. So we're comparing the same apples to apples in these kinds of comparisons and these different kinds of groups. So here's our different demographics. You can see we're heavily weighted to cognitively stable, A-beta negative, and then we have some individuals are A-beta positive and then some that are impaired. You can see as there are those that are more impaired, that are older in age, they have a higher amount of course, amyloid and centhaloids, as you can see, and then the presence of APOE, much higher presence, a higher presence in those that are impaired. And then if you can see with also the centhaloids, much higher centhaloids, even in those that are cognitively stable and A-beta positive. As you can see, this is a disease of amyloid, and then as you heard before, Dr. Gordon, there's also the disease of tau as well with Down syndrome. So when we first looked at this, and here are those three different kinds of comparisons. Here are cognitively stable A-beta negative versus A-beta positive, or cognitively stable A-beta positive versus impaired, and then the greatest difference is those that are cognitively stable A-beta negative versus those that are impaired A-beta positive. You can see these kinds of maps that are present, so those areas that are red are higher, those areas that are blue are lost, and you can start to see there, there is a little bit of a hint that's more in this posterior regions, and then as you start to see more and more differences between these two groups, and then the greatest differences, you start to see that the parietal lobe is starting to kind of come out. Now, it did not come out in significance in these kinds of first pass analysis, and then we didn't see a relationship between the patterns of where changes were. And in fact, if you actually look at the frontal areas, you can see actually almost a flip that's occurring between these different stages, is that there looks like there are a loss here, but then there's maybe a little bit of an increase that's going on. So the answer is that there are probably some regions that are more involved in this, and we wanted to do further analysis to kind of look at that. So we drove down and drilled down into the parietal region, and we looked at those changes with amyloid and then differences with cognitive impairment. And what you can see is that here are our greatest difference, or different groups, so our cognitively stable A-beta negative versus our impaired, or our cognitively stable A-beta positive versus impaired, and then looking at those areas where there is overlap. You quickly notice that parietal region, the precuneus in particular, seems to be heavily involved. And then if we go to different thresholdings, you can start to see that even at very stringent thresholds, those regions seem to be, that parietal region seems to be consistently affected. So again, a parietal involvement seems to be a good marker for discriminating this both with amyloid as well as then with impairment as well. So we can then kind of make those kinds of comparisons, and you saw some of these nice curves from before of looking at these three groups. So the cognitively stable A-beta negative, so these are our reference region or reference group, and then cognitively stable A beta positive, and then if there's a drop, and then that's our idea of amyloid changes, and then if a cognitively stable A beta positive to impaired A beta positive, that's our changes that are associated with impairment. And what you can see when we use different regions, so we either use the hemisphere, like the right hemisphere, which showed to be differences, and you can see that either in here or our combined regions of both hemispheres. What you can see is a stepwise decrease that's kind of present. So when you become A beta positive, there's a drop, and then there's a further drop with impairment. Now, in these subcortical regions, they don't seem to always be following that same kind of principle. So in particular in the accumbens, what you see is that there is this drop with A beta positivity, but there's not more of not a further drop with impairment. Other areas like the putamen, again, there is no real drop with A beta positive, but there seems to be more of a drop that's more with or consistent with impairment. So what this starts to tell us is that certain cortical regions may be more sensitive to either impairment, or certain cortical regions may be more sensitive to amyloid accumulation. And the same thing within these deeper subcortical regions, some may be more associated with either amyloid or with impairment. And then we did these ROC curves, and you saw some of this other kinds of work, this ability to discriminate in these individuals. And what you can see is that within these different regions, some regions, again, have much higher ROC curves for particular stepwise changes. And so in the right cortical, right hemisphere or combined regions, you can see that it's pretty good in differentiating cognitively stable A beta positive versus A beta negative. It does well even with impairment, and then does even very well with the two greatest extremes. In contrast with the accumbens, it seemed to be better with amyloid accumulation, and then the putamen seems to be better with more with impairment. And so when we look at these ROC values or the AUCs for these ROCs, you can see pretty good ability to discriminate in the 0.8s, 0.9s, and then very good in discriminating those two greatest groups. Those are cognitively stable A beta negative versus those that are impaired. That's much better than what we usually see with the ROCs or the AUCs for autosomal dominant Alzheimer's disease, where you can see it's about at chance. So really these areas are very good in discriminating either impairment or with amyloid accumulation. Then we looked at the spatial overlap, so those spatial areas that are there, again, using that greatest differences between our cognitively stable A beta negative versus impaired for these two kinds of groups with that kind of thresholding. And again, you can see this parietal region seems to be involved. And then when we use these different maps, the autosomal dominant is in red, Down syndrome AD is in green, areas that are overlapping. What you see is that Down syndrome is a much more diffuse process compared to autosomal dominant. Again, this parietal regions, the precuneus areas seem to be overlapping regions within these individuals. So there's also more overlap within the right hemisphere between these two groups, and that there seems to be a more symmetrical loss with autosomal dominant compared to Down syndrome. So if we take this all into a kind of account, Down syndrome is associated with cortical thinning in multiple different regions. The thinning is associated with amyloid accumulation and cognitive impairment. Different regions seem to be more sensitive to the amyloid or to cognitive impairment, and that there's also some of these same kinds of changes that we see with subcortical based regions as well, and that these MRI-based measures have a good discrimination ability for Down syndrome, and that you can see these are the different regions that are sensitive to this, and that Down syndrome thinning patterns were similar to autosomal dominant, again, nicely comparing to our previous work in either amyloid or tau, but that it was more diffuse in Down syndrome than autosomal dominant, and you can see much higher AUCs for this. And then why this is going to be important is that these cortical signatures, as you've seen from our previous talks that are even highlighted here, is that it's going to be important for detecting these early changes. We're also going to be facing this conundrum, and you've been hearing about anti-amyloid therapies, and you're going to be hearing later on with Mike about talking about this. We do see this idea with these anti-amyloid therapies of actually a volume reduction. And so we're going to need to use these kinds of imaging techniques to separate out how much is due to the volume from just the natural disease process versus how much is it due to these anti-amyloid therapies. And so I do think that volume is going to be a very important marker for following these kinds of therapies. So this is the group that I'm so fortunate enough, again, and great work that James Kennedy has been doing. And if you're interested in following us or other kinds of stuff, we're looking for collaborations, just as Brian was saying. So thank you so much for having me.
All right, so these talks are open for questions.
They're getting the microphones.
So there's a question up here at the front. Thank you.
So thank you for all the talks. They've been great. And I think we've been talking about the overlap and the parietal lobe. And first of all, I want to say that there is an equally important overlap that is between the ABC and the Dayan, and that is an overlap in St. Louis. And I think that I really want to thank you, because I think the work that you are doing comparing the Dayan and the ABC consortium is incredible. I think it's advancing a lot. So thank you, Ryan. Thank you, Beau. I think it's beautiful data. And my comment was on this increase in the tau burden that you showed in this last neurology paper that is about to be published. I think it's great. And just a comment, because we have to share the data that we have with Nicolas Barthelemy, again it was you, that we had in a collaboration with Johannes Levin. We could send our CSF samples, and we also saw, and he told us that we see higher occupancy of phospho-tau217, even higher than in the Dayan samples in Down syndrome. So I think it's very concordant that it seems that there is something in DS that is favoring this hyperphosphorylation of tau even beyond autosomal dominant AD. And I think it was Marie-Claude Poitier yesterday signaling that maybe it's other genes, DIRC1A or whatever. So I was throwing this back to you. This thing is DIRC1A, the other genes, or to the audience, Marie-Claude. I think it's really interesting, these tau results that you are showing. So thank you.
Just to go on that, I do think, and as Brian was showing, and as you're seeing with even the volumetric changes, that probably large amount of tau that's also occurring is then leading to earlier neurodegenerative changes. And so it is really a compressed process. You also see that clinically, as many of us who are taking care of adults with Down syndrome, that this process is compressed. And so why is it? It could be from DIRC1A or other chromosomal. It could be other inflammatory. And so you guys have done, and there's a lot of work that's already being presented, that there is also this thickening. Could it be due to inflammation, due to something else? But there is an accelerated process that is going on. And this is not just a disease of amyloid. This is a disease of tau as well. And that really needs to be thought about, and when we're thinking of interventions. And so when we would give a certain therapy, as you were hearing from Brian, and if you need to do a combined therapy in these individuals, or you do adjunctive therapies at different times for these individuals. So staging them, and then when that therapy is going to be appropriate for them is going to be very, very important.
Yeah, for sure. There's definitely more, and then I think very consistent across all the analyses, you see that more prominent role of the entorhinal cortex in Down syndrome seems to be a consistent pattern, whether you're looking at hypometabolism or structure. I really don't understand, in some ways, Down syndrome seems to be like a merging of late onset and the autosomal dominant, where you're getting kind of the worst of both conditions occurring simultaneously, and it seems like it's occurring earlier in the disease point where you're starting to see that atrophy. That could be just a little bit harder to stage based upon cognition in Down syndrome. Why I think it's important for some of these, you need to put it in relationship to amyloid as the x-axis rather than cognition, just to put a little bit more apples to apples. But even when you do that, it's very clear that the Down syndrome has more pathology, and it's earlier, and it's in a slightly different pattern. And again, like your questions about why that's occurring, it's so fascinating. And I have no answer. Other than maybe, we think about Down syndrome also having more maybe neurodevelopmental effects. And I think that's a missing question for the autosomal dominant. We tend to shy away for studying children of autosomal dominant, which I totally understand. You don't want to think about your child inheriting this devastating mutation. But that is a kind of a missing piece to understand. Is that what it is? Is it just on the developmental side that's happening in DS and not in ADAD? We don't know.
Yeah, just a few points to discuss further. I have a question regarding you all. Have you ever seen any tau pathology in Down syndrome, even before, positive amyloid PET?
Well,
So for you guys,
go ahead.
For ADAD, it's rare. Yep. You tend to, it basically never happens in ADAD. You always have amyloid so early in them. We also tend to not see very much tau pathology before they're impaired. It was very consistent with what Nico shows for the MTBR, where you have this huge spike right when they become impaired, but we never see tau first patterns in ADAD. I don't know on the DS side.
We haven't seen that much, but it does depend upon your threshold that you're using. And so, the amyloid positivity is at around 18 centiloids for that. We're applying standards, and then you also heard this from the regions that we're using with Brock and Brock. They may not be the most appropriate, and even Annie was talking about this yesterday, about some of these ideas, is that there may need to be more specific regions that we use as a summary value for Down syndrome, but that has not been really developed. And so I think that is important for the field. So it may depend if you use different regions.
The second comment is whether you, I know it's a difficult region to study, the locus coeruleus, but do you see anything happening or occurring very early in the locus coeruleus? Because at some point there was this hypothesis that tau pathology could occur first in the locus coeruleus and then propagate.
This is something Heidi Jacobs talks about a lot, but we've never really looked at it within ours. It's very difficult. The MR protocol they're using to get the locus coeruleus is very finicky, and it's very difficult to do. I think it's very impractical to do at the multi-site study. I think that would be really hard to do.
Mm-hmm.
And there may be more movement effects and other things that you may need to be considering. So I would say it would be a great area to do. And if you had also could tolerate in a 7T and doing that, it would be wonderful. But I think practically it may not be the first or easiest way to look at. Mm-hmm. That you guys are seeing enter around on subfields and able to do that, that's like really amazing work, right? To get to that resolution, so.
And the last comment regarding the remark of Juan concerning DIRC1A, there was a paper published recently in Nature Communication by the group of Kai Bleno with this new p-tau212 biomarker, which is in fact a phosphorylation site of DIRC1A. And I think it would be quite interesting to look in. So in the study, they studied the AD cohorts, but it will be interesting to look in Down syndrome because it might be, a phosphorylation site that seems to predict very well AD. And that could occur before the other phosphorylation site. That could be due to the overexpression of DIRC1A.
Thank you for that suggestion.
So, question for Alejandra. This is a known lifelong atrophy of the hippocampus in Down syndrome. And there was a paper published a few years ago looking at atrophy of the hippocampus in children who are APOE4 homozygotes. And trying to put these two together, have you looked at APOE4 effects on rates of atrophy? Yeah. And do you think that similar to the lack of APOE4 effects in Down syndrome and other modalities such as amyloid and cognitive decline, do you think that there's also a diminished effect of APOE4 on hippocampal atrophy in Down syndrome simply because of this massive overproduction of beta amyloid and its relationship to atrophy?
Yeah, well, thanks for the question. It's a good point, and not, we didn't assess this effect of APOE in our analysis, but it would be nice to further explore. And to be honest, I don't have a strong hypothesis in this topic.
Hi, I can maybe just jump in very quickly. We didn't look at the specific effect of the APOE4 in the different medial temporal lobe subregion, but we did publish 2 years ago a paper in JAMA Neurology looking at the effect of the APOE4 in the context of Down syndrome. And we were able to see an effect on most biomarker, actually on tau, measure with CSF, on amyloid, and we did see a small change on the hippocampal trajectory.
Thank you.
In some work that I did, I didn't have much of a sample to look specifically at differences in the subfield sides, but I will say that there was a trend for the APO4 positive to have smaller subfields, but
yeah.
again, it's a really small
And
sample.
Patrick showed some data with your AD sample, the AD stable category, and that seemed to have quite a bit of variability. And one question I had was whether that was just because of a small sample size in that category, but you found some APOE4 effects also. And I think my question is really, is that paper has, there are other papers that go in the other direction, so there's some controversy about that.
Yeah.
And I'm just trying to put it all together. Is there an APOE4 effect in at least one biomarker that's robust enough that we can say, yes, it does seem to act the same way as in other forms of AD?
Mm-hmm. Yeah, I think that'll be a really important question to address. And I think APOE sort of has this different sort of effect than what we're used to. For like amyloid, it's kind of just like an earlier age as opposed to kind of like more amyloid. And so I think it might appear more or less in different types of analyses, and we just kind of have to figure that out. And yeah, I haven't actually compared the effect of APOE in what we're seeing in Down syndrome compared to kind of like the same sort of models otherwise. And so I think that would be important to kind of get an estimate of the effect size differences.
Absolutely.
Yeah. Mm-hmm.
I mean, less a biomarker, but ARIA, right? So that's a clear one with APOE effect. It's playing out in the genetic forms very consistently. So maybe you would expect for some of the vascular pathologies tied to CAA to see the most consistent APOE effect. We don't see almost any APOE effect outside of ARIA for the Diane study.
I just had a quick follow-on question to that. In thinking about APOE and Patrick, your data in particular, when you saw both the APOE effect, but also then the sex, biological sex effect, you know, there's some literature about that intersection of APOE and biological sex. And so just wondering if you've looked at that at all, or if anybody's looked at that at all within the Down syndrome population as well.
Mm-hmm. No, we haven't done that two-way interaction yet, but that's a really good idea. And I think a lot of the literature, at least for the sex by APOE effect, has shown that in women with the APOE4 allele, they have greater tau burden, especially in like kind of like their early Brock regions for the same level of amyloid. So it'll be interesting to see what an APOE by sex effect is doing on kind of these vascular biomarkers. And we can extend that beyond just the hyperintensities for sure, yeah. Mm-hmm.
Changing of topic, I had a question for you, Brian.
Sure.
So we saw that your pattern of tau PET deposition in Down syndrome was involving maybe more of medial temporal lobe in Down syndrome. And so now we have this kind of three different patterns, if we think in the typical form of sporadic AD, where maybe Down syndrome look like a bit intermediary, as you were mentioning. So how do you make sense of this topographical difference, and what is your hypothesis in terms of spreading? You mentioned that you have some Brack staging theory. I will be curious to know.
Yeah, you know, so this goes back to we have such a poor understanding. So another thing I think that is important to talk about, which came up yesterday, is the atypical presentations seem to be incredibly rare in the genetic forms. And the only one, at least for ADAD, that I can think of is an escapee from the Colombian kindred, has kind of a PCA-like where they have it confined to the temporal lobe. So why do we not see atypical origination of seeds in the genetic forms? So is there something from these by having these mutations or having Down syndrome that it's just putting you into a very, very specific lane and inferring very specific early regional vulnerabilities, which again goes back to the idea it could be the additional mutations that are coming up on the chromosome or something that I think that's happening maybe developmentally that's just leading to this inherent vulnerability so that when you have that pressure of amyloid that comes on, it's just popping up whatever was already in the brain from early life is manifesting. So at least that's my thought, that this is actually a reflection of early neurodevelopmental differences in the brain, which is playing out more so in the temporal lobe and Down syndrome than in autosomal dominant. So I don't know. I actually tried at one point to look to see if there were good published maps for cortical expansion in children and adolescents in Down syndrome to see if there was something happening, particularly in the medial temporal lobe, and I couldn't find that. So I don't know if there's good maps of that to test it or not. I'm actually trying to do that with late onset now, to look at maps of neurodevelopment to see does that predict patterns where we see kind of typical tau to try to push this developmental angle. And so if anyone on the Down syndrome side does have developmental maps, I think that would be great to see if we could match up development to the tau that we see later on. But you guys are definitely the expert on that.
I would just jump in is that there's also important things that we do see a lot of similarities in what is being shown in autosomal dominant and in Down syndrome, and I think is pretty well established in the field is that, and Patrick is really one of the people who's done a lot of the work on this, is that there's a lot more of subcortical involvement, and it's much earlier on in the disease process. So there is something that's important there, even though they don't show the clinical manifestations of it. And so why are certain areas more vulnerable to this? I don't know if we have an answer as to why it is, but this is definitely different than what we see with late onset, you know, and typical patterns and typical spread. So how that relates and why, that's still open for debate. And if you have ideas or others have ideas here, I think that's an important question for us to understand, because if we can also affect those areas or modulate those areas, that'll be very, very important for therapies as well, too.
It could also tie to the genetic expression. So a lot of the PSIN1 expression, if you actually look at the mRNA expression from something like the Allen Human Brain Atlas, it tends to have more of a parietal predominant mRNA expression in the brain. So it could also just be tied to kind of where's the local influence of these genes, is just inferring a different spatial pattern in ADAD. I don't know. It's a super important question. If we could figure that out, I think it probably opens up questions about therapy and approaches there.
Yeah, and I think if we're thinking about these approaches, like if you want to look at sort of the impact of neurodevelopment, I think we can probably move beyond just like cortical thickness and volumes and kind of look at the gyrification as well to see these different aspects of how the brain is developing and how amyloid might be kind of populating like a brain at different stages.
Yeah.
And then just sort of like rule out some of the non-biological effects of what we're seeing, like for example, like the early striatal uptake in amyloid PET. Does anyone have dynamic PET data in these populations? And can we kind of estimate the K2 parameter and kind of look at if it's more just tracer delivery compared to kind of like something pathological?
Yeah, so for Diane, we use, when possible, full dynamic PIB scans. Mm-hmm. So you can do that. And you did bring up the striatal dominant. So something that we don't talk about enough with the ADAD is actually, so when we show the average maps, there's clearly striatal, but it tends to actually track the different subtypes. And what we actually tend to see is a striatal predominant subtype and then a cortical predominant. So that striatal pathology is not common on all ADAD. It's only common on a subset. But for sure, if you want full dynamic PET, we have that for the vast majority of Diane for the PIB.
Mm-hmm. I enjoy to have the micro. Just for one question for Patrick. Thank you for this very nice presentation. I was wondering, do you fit the vascular change in relation to Alzheimer's disease? Do you see them more as a consequence, as a cause, or like, or do you conceptualize it?
Mm-hmm. Yeah. So based on the literature, I think it could be both. So I think it's pretty heavy in the literature that Wallerian degeneration exists, and these white matter hyperintensities, which could just be, it's just a radiological signal, so of lower white matter, so like demyelination, which could be a result of axonal dieback from tau. But when we can look at it in sort of this like temporal way, we see that they're kind of emerging at the same time. And it would be really cool if we could identify which hyperintensities were emerging before the tau pathology was emerging to try to draw some inference. But as of now, it's probably both, and we need to do a better job about teasing it apart. Yeah, that's, I guess, how I would conceptualize it.
I just wanted to go back to something that Brian said a minute ago about the need for these atlases developmentally. And I think one thing that often gets lost when we start talking about the AD biomarkers and the PET imaging is that we know very little about the way the brain ages in developmental disabilities. And so, really thinking about moving towards a lifespan perspective of looking at brain structure and function in these areas before we even get to the point where we're measuring AD biomarkers, I think is something we really should be doing, and perhaps even in the autosomal dominant carriers as well.
It's a little bit tougher on the AD side because they can't, for testing wise, but for DS, there is that opportunity.
Yeah, that is a really excellent point and brings us right into the next session very nicely, modeling. Yeah, needing to understand kind of just the natural history of everything before we can determine what's, a change due to disease. Yeah.
Thank you.
Yeah, I was thinking about, the kind of
We should be.
quedo con esto por si tengo que preguntar preguntas.
Okay, I think, can you hear me? Hello? Hello? Yeah, okay, perfect. So let's kick off the next session after a very good start in this day on the modeling, natural history models, and I think most of you have Netflix, so I can say our next speaker needs no introduction.
So thank you all for being here. It's my pleasure. And I hope this is not a provocation. No? We have a gathering for DSAD, ADAD, and I kind of speak about APOE. No? But I hope I convince you that this can be a new member to our families, and new members are usually a cause for joy. So I hope I convince you that this is a cause for celebration. So basically, these are my disclosures. And I'll just summarize some of some ideas. No, that I think that AD involves both rare and common genetic variants, and APOE is considered that's involved the most significant genetic risk factor for AD. We're talking about the mutations that lead to early onset AD, but I think that this reconceptualization of DSAD as a genetic as a form of AD it was based mainly on these three ideas of near full penetrance, a predictable age of symptom onset, and a predictable sequence of biomarker changes. And these are the kind of the three cornerstone of this reconceptualization of DS as a form of genetic Alzheimer's. And APOE4 homozygotes have up to 60% lifetime risk of AD dementia by age 65. And a group, Jenny et al., a paper in molecular psychiatry in 2011, proposed the concept of semidominance in AD, which is not a very common concept. I would like to stress that the NIA Alzheimer's Association criteria and the new Alzheimer's Association criteria consider AD a biological entity that can be diagnosed uniquely based on biomarkers. And the last piece of evidence that I want to call to your attention is that most biomarkers or most studies collapse APOE4 homozygotes and heterozygotes in one group because of sample size limitations. Sometimes you have, 200 people and you have 2-3% of APOE homozygotes. You have 3-4 APOE homozygotes. What do you do with them? We just collapse them into one APOE group. So this is a graph. You're very used to it. This is like the genetic architecture of Alzheimer's disease. And here details matter. First of all, I would like to take your attention that the axes are broken. And basically, they want to separate AD, and that's in the upper left corner. And that it seems that they're very, very rare. And they lead to AD dementia, whereas the rest of the genes do not are also the risk factors that can be very informative to investigate the pathophysiology of the disease, but do not lead to AD dementia. So first of all, I'd like you to join us in our fight to say that the elephant in the room is DSAD. This is just neglect that DSAD is far more frequent than and should be included in this. You could argue that APP duplications could encompass DSAD, but in that case, the broken x-axis would not apply because DS is not as rare. And what I'm going to try to propose is that APOE4 homozygotes can be incorporated to this family. So, as I said, you've seen this graph several times. The idea is that the natural history and, very importantly, this predictability. We published this paper 2 years ago, and in a meta-analysis by Florencia Iulita. And here, what we saw, thanks to a previous meta-analysis by Reimann et al. In neurology in 2014, we could compare the age of symptom onset both in DSAD and ADAD. And
they are both equally predictable. The variability about the predicted symptom onset is equally predictable in both. So you can say that there is variability, no doubt, but it's equally predictable. So I just want to emphasize that we use variability of predictability, but in both conditions to the same level. And this, of course, has important implications on how you should model the disease and the incorporation of the estimated years to symptom onset when analyzing biomarker changes in these conditions. So just jumping to the studies, it's a study that has been just accepted in Nature Medicine, so will be out in a few weeks. Basically, in order to do that, we had like two studies in one. So first of all, we had a pathological study analyzing the National Alzheimer Coordinating Center data with a pathological sample. And here, what I want to emphasize is the numbers. We have over 3,000 participants overall, and we could gather 273 APOE4 homozygotes. And here, this cohort is linked towards symptomatic AD and dementia, and that's a pathological cohort. That's the bias. And in the clinical cohorts, we had like 5 cohorts from the US and Spain, and we could gather over 10,000 individuals and 500 APOE4 homozygotes. That's more than the expected population because some of the preclinical cohorts, such as the Pascual-Maragall, the Wisconsin Registry, they have an overrepresentation of APOE4 carriers, but these cohorts are completely linked in the opposite way to healthy controls. So in order to be part of the A4 study, by definition, you had to be a healthy control. So here the bias is towards healthy controls. So let me first look at the pathology. So we divided the pathology. I'm looking at the top row about that's the Alzheimer's disease neuropathological changes, and you can see the difference between APOE4 homozygotes and APOE3 homozygotes. And you can see that with age, after age 60, basically all APOE4 homozygotes have AD pathology. And when we look at the biomarkers down, and you look at the amyloid biomarkers on the left, or the tau biomarkers on the right, nearly all individuals with APOE4 homozygotes, irrespective of symptoms, they have AD biology. So again, with the Alzheimer's Association criteria, they have AD, all of them, irrespective of symptoms, after age 60. What about the symptom onset? So this is well described. This is not us showing this data for this no new data. There is an acceleration of the age of onset, as you can see from green, the light data from green APOE3 homozygotes, heterozygotes, and homozygotes. There is an acceleration in the presentation of the disease only when there is AD dementia. The other 3 curves are when you don't have AD dementia. So APOE4 does not impact dementia if you don't have AD. So it has an effect on AD dementia, not other forms of AD. So as I said, in the top left panel, you can see the acceleration in the age of onset, in the symptom onset, MCI diagnosis, AD diagnosis, and age of death. So this is well known. But here what we wanted to replicate is the predictability of the disease around the symptom onset, which I have not said it, is 65 years in this cohort. And as you can see, the span, the 95 prediction interval for APOE4 homozygotes is equal to that described in DSAD and presenilin-1 mutation carriers, with having APOE3 heterozygotes with intermediate levels with respect to APOE3 homozygotes. I'm sorry, the slide has 10,000 points for some of the biomarkers, but here you can see the different trajectories. I think it's a beautiful gene dose effect on the AD biomarkers, whereas APOE4 homozygote suffer earlier and predictable sequence of biomarker changes as compared to APOE3 homozygotes. And when you do the models to compare it, I won't enter into the sequence, but basically it's an equal sequence to that described in CSF, for DSAD and ADAD. And another important point is that you have to consider, and this is well known, I'm looking now at the top right panel, the APOE3 homozygotes, and we had the same sample, the same results in the pathological samples. This is the clinical sample, and this was described in the solanezumab trial. If you don't do AD biomarkers, a proportion of APOE3 homozygotes will not have AD, even though they have an AD dementia diagnosis. And this is more the older the age. And this is important because if you don't take into consideration, you make comparison, you might find differences. But if I take the top row and only take the red part, which is the AD dementia with a positive amyloid, so I'm just selecting AD dementia, positive amyloid scan. And then I compare the biomarkers between APOE3 homozygotes, APOE3/4 and APOE4 homozygotes. The disease seems to be the same. And this is the message, is the same with autosomal dominant AD and DSAD. It's a hugely accelerated process in earlier ages, but once you have AD dementia, the process seems to be very, very similar in all these conditions. So I think I hope I convince you that we need to have the elephant in the room is DSAD, but now we really have a mammoth in the room. This is 2-3% of the population worldwide. This would be the most frequent Mendelian disease in humankind, and that's because it has no pressure, evolutionary pressure. When you develop dementia, usually you don't have children anymore. So that's what I propose, that we enlarge the circle, and we have this vector cycle that we used to have 3 AD-AD, DSAD, and sporadic AD, and now I propose we have APOE4 homozygotes within this circle. They will behave as autosomal recessive AD, if you will, but because APOE3 heterozygotes are in the middle, I think this concept of semidominance, that is not very frequent in genetic studies either, but I think it's appropriate to signify this intermediate risk for APOE3 heterozygotes. So to conclude, APOE4 carriers should be included in the growing family of genetically determined AD with near full biological, at least, penetrance. APOE3/4, so consistent intermediate effects, hence the concept of autosomal semidominance. And all genetically determined AD, so striking pathological and biomarker changes. This is not to say that certainly we need to really afterwards look at the differences that can give essential pathological, physiopathological avenues, but the similarities, let's not forget the similarities that are hugely striking between all forms of the disease. And I think that I really think that AD might be much easier to cure in these populations that are predictable and highly homogeneous from a genetic perspective than the more complex cognitive decline that can occur in sporadic AD. And with that, I'd like to thank all the team and all of you for listening. Thank you very much.
I'm not sure? No? Now. So thank you very much, Juan. You know how much I like this data set and line of thinking, so that's a great presentation. We will discuss that afterwards. And I also thank you for giving me this moderator role, because our next guest also needs no introduction. Next speaker needs no introduction. So, Raquel.
So, good morning. Thank you. I will present a work in progress. The work is not finished, but I will present the results we have so far about cortical asymmetry in individuals with autosomal dominant and Alzheimer's disease. So this is my disclosures. So you know that Alzheimer's disease is considered a symmetric disease, as most patients show symmetric atrophy at visual inspection. But in a previous study that we studied both Alzheimer's disease and frontotemporal dementia, we studied the cortical asymmetry. For that, we defined the cortical asymmetry index using a metric derived from the information therapy with cortical thickness measures. This is the math formula. The math formula has been done by Agnes in the front row here, if you have some questions for her, because don't ask me, please, about the math formula. So in that paper, we demonstrate that there was an increase in brain asymmetry, not only in frontotemporal dementia, but also in sporadic Alzheimer's disease. So the objective of this study was to evaluate brain asymmetry using the Cortical Asymmetry Index in a cohort of autosomal dominant Alzheimer's disease. This is we use the autosomal dominant Alzheimer's disease cohort from Barcelona, from the PicoGen study. The PicoGen study includes not only autosomal dominant Alzheimer's disease, but also genetic frontotemporal dementia and genetic prion diseases. But for this study, we only include autosomal dominant Alzheimer's disease. We include 25 controls, 20 asymptomatic mutation carriers, and 21 symptomatic mutation carriers. As expected, symptomatic mutation carriers were older than asymptomatic and controls. The asymptomatic mutation carriers were a mean distance of minus 13 years from symptom onset. The MMSE was lower in the symptomatic mutation carriers. The NFL was increased in symptomatic mutation carriers, and the plasma NFL also, and plasma GFAP were increased both in the symptomatic and asymptomatic mutation carriers. MRI images were processed using FreeSurfer to obtain the atlas-derived cortical summary measures. We evaluate this cortical asymmetry index using an in-house pipeline. We analyze difference at the cross-sectional level with permutation tests corrected by age, and then we explore the correlation of this index with general condition, biomarkers, and estimated years to symptom onset. At the cross-sectional level, we observe that this index, the cortical asymmetry index, shows significant difference between controls and symptomatic mutation carriers, but also with asymptomatic mutation carriers. There was asymmetric mutation carriers were more asymmetric than controls using this index. Regarding the correlations, we only observe significant correlations with the estimated years to onset in symptomatic mutation carriers. We don't know if that's a problem with the statistical power, but we only found this correlation in symptomatic mutation carriers. Also, we only found a significant correlation with MMSE that was expected only in symptomatic mutation carriers. And with plasma NFL, we found significant correlations in the whole cohort, both in asymptomatic mutation carriers and symptomatic mutation carriers, but the correlation was mostly driven by the symptomatic mutation carriers subgroup. So to conclude, autosomal dominant Alzheimer's disease individuals, both symptomatic and asymptomatic, present increased brain asymmetry compared to controls. In symptomatic mutation carriers, this index significantly correlates with measures of disease severity. And this study and previous research in sporadic Alzheimer's disease from our group underscores the asymmetry of brain loss within the AD spectrum. We think that these findings should be confirmed in longitudinal data. The analyses are ongoing and independent cohorts, so if someone here are interested in studying this measure in their cohort, please email us. And in the case we confirm these findings, I think this asymmetry should be taken into account in the results of other neuroimaging study in these cohorts. So thank you. This is our group, and thank you for the attention.
So our next speaker is Eric Rubenstein from Boston University, and he's going to present an incredible data set and very, very nice results. Eric, whenever you want.
Thank you, Juan, and thank you, Raquel, for both being my opening act. It's really an honor to have you open for me. That's a joke. I appreciate the invitation to present my data here, and I look forward to hearing all your thoughts. So that's my funding. So I am an epidemiologist. I sort of like to say in these types of audiences that I sort of study the forest, where many of you either study the tree cells or the tree leaves or even trees. So we're sort of taking a really big picture view of Down syndrome and Alzheimer's dementia here, which means that we don't have APOE measures, we don't have tau, we don't have those sort of MRI images, those really cool, neat scientific data, but we do have a lot of people. And there is strength in that, and I'm going to sort of talk about what we can glean from that information. So that sort of gets me to my position as an epidemiologist of Down syndrome, where we often think of epidemiology as COVID or infectious disease or HIV, where there is sort of importance to studying conditions like Down syndrome. So historically, the study of Down syndrome in public health and epidemiology has been focused on sort of cause and prevention. Sort of the big finding being that increased maternal age leads to increased risk of Down syndrome. And sort of the consensus generations ago was, what can we do with that to prevent the onset of Down syndrome? But as we've made advances in congenital heart defects, and the field has understood the value of people with Down syndrome, and there's been growing cohorts that have thrived, the field of sort of the idea of an epidemiologist of Down syndrome is shifting to how do we ensure optimal life course and outcomes and happiness and quality of life. So we're sort of shifting from what causes Down syndrome to how to ensure that people with Down syndrome live good lives. And part of that means we're now researching things like Alzheimer's dementia. But there are some major limitations to our study in terms of an epidemiological sense. A lot of the research is in convenience samples located near academic institutions that don't represent sort of the broader population with Down syndrome. Not to sort of shame anyone, but I like to point out that the Down Syndrome Connect NIH registry is about 3% African American. That's a US sample that should be about 14 to 15%. So we're not really capturing the full heterogeneity, variability in the demographics of the Down syndrome population in a lot of our clinical research. In a lot of those studies, it doesn't really make much of a difference depending on the research question, but things such as sort of the prevalence of Alzheimer's dementia, it does matter. So our position is that we need to understand health outcomes across the life course, including AD, so we can describe and attack disparity and help all adults with Down syndrome thrive. So my work is focused on the US healthcare system in Medicaid and Medicare. It is a headache for you Americans and non-Americans. It's really a pain, but it does have its strengths for studying a population like Down syndrome. The two big public health insurers in the US are Medicaid and Medicare. People within the US get confused by the two, so if you're unfamiliar, don't feel ashamed. Medicaid focuses on low-income adults and children and disabled adults who are also low income. Medicare is classically for older adults, 65 and older, without an income restriction. However, adults and children with disabilities can qualify for Medicare under the sort of disability exceptions and their parents' eligibility. So someone with Down syndrome could be in Medicaid, they could be in Medicare, or they could be in both. And we had a paper sort of describing how people move between the two programs. But what we find is that, sort of Medicaid serves a younger population, whereas Medicare serves a slightly older population, but not 65 and older in the Down syndrome world. The mean age is more like 40 in Medicare versus 35 in Medicaid. But what is sort of a benefit of using these data, but a minus in terms of the scope of the Down syndrome population, is that in the U.S. and most places in the world, people with Down syndrome do not have full-time employment. In the U.S., we estimate that it's about 3% full-time employment, and again, in the U.S., private insurance, which is oftentimes considered to be better, is reliant on full-time employment. Your employer pays part of your insurance. So people with Down syndrome are not on private insurance, they're on these public insurance systems. So we have leveraged these data to combine the Medicaid and Medicare data for all adults with Down syndrome from 2011 to 2019 in the US, which gives us a sample size of 135,000 adults with Down syndrome. And what's exciting about that number is that it really maps nicely to a simulation that DeGraff and Scacco did a few years ago, estimating the total population with Down syndrome. They did that in the US and Europe and kind of all over the world, but our 130,000 is almost exactly what they sort of simulated would be the adult population 18 and older in the US. So we are pretty confident in saying that we have almost all adults with Down syndrome in the US. There are a few that are fully employed. There's a few that probably have parents that pay for private insurance and don't use any of the public health system, but we are pretty confident that we have almost everyone. And our study is called DS to the Max, Down Syndromes Toward Optimal Trajectories and Health Equity Using Medicaid Analytic Extract, MAX. That's the name of the data source. So in terms of those 132,000 individuals, we have 820,000 person years. So on average, we have about 8 years of Medicaid or Medicare enrollment data for these folks. And those data include demographics, inpatient healthcare use, outpatient healthcare use, medications, and long-term care and services. So we don't have EHR, we don't have doctor's notes, but we do know every time that they were billed for any service or diagnosis. And with that, so we identify Down syndrome with ICD codes fairly easily. It's oftentimes a not too difficult thing to code for due to the phenotypic presentation. But Alzheimer's dementia, there is a large literature outside of the Down syndrome space in identifying AD in Medicare claims especially, but a little bit in Medicaid. So there's a whole list of ICD-9 and 10 codes that are part of an algorithm to identify cases in these claim systems. The sensitivities and specificities of these algorithms vary widely, and they're usually not so great. We are sort of, this has been not validated in Down syndrome, but we're a little hopeful that it's better than in the non-Down syndrome world, just because there's more consistent enrollment in these programs, and sort of the Down syndrome dementia pathology is so well known. So what we did was any one claim for an Alzheimer's dementia that was part of this algorithm. We wanted to identify incident cases, meaning that we could tell that they didn't have dementia at the beginning of our data set, and then they developed it at some point. So we call that a washout period. An individual had to be in our claim for 1 year without any claims for dementia, and then we can sort of assume that that first claim is their first incident claim. That's a little shorter than the typical algorithm, and we were able to sort of shorten that length because, as I mentioned, people with Down syndrome are so consistently enrolled that we see them all the time. They average about 200 claims per year, which was 4 times more than the non-Down syndrome groups that we had. So we see them, we see their healthcare calendars. If they go a year without a dementia claim, we're pretty confident that they don't have identified dementia by a clinician. We also excluded individuals less than 35 or greater than 80 at study end. We wanted to sort of really focus on areas where we know that the diagnosis would be probable and not have too many extreme outlier ages. Even, there could be some misclassification in Down syndrome at that higher age range. So this is our prevalence data. So this is sort of just the percentage of people in the population, in the Down syndrome population, with any claim for dementia, Alzheimer's dementia during this time period. And we can sort of see that, in the 35 to 44 age group, we're seeing, about 5%, about 22 when you're 45 to 54, and then we're sort of exceeding 50% at 55 to 64 and 65 plus. So these age ranges are a little large in terms of, being 10 years. We'll present the data differently in a second, but sort of you can see that at any given time, a large proportion of the Down syndrome population has an identified Alzheimer's dementia diagnosis. As I mentioned, in the US, it's really important to look at racial disparities and sort of differences by race. These are not adjusted for age, which is actually a big factor because there are some meaningful age distribution differences by race ethnicity in the US. But sort of on a crude aggregate scale, there is more Alzheimer's dementia in the white population than in the non-white populations. What's really, I think, neat is that our age at Alzheimer's diagnosis for those with incident dementia diagnosis really maps on nicely to the meta-analysis done by Juan and his team. We're seeing a mean age of 54.5 years of initial diagnosis, and it's really kind of surprisingly neatly normal of a distribution. So this is, among 20,000 incident dementia cases, we're sort of seeing that 54.5 mean age. And then across race ethnicities, we don't see that big of a difference in this mean age of identification. So right, this is just people that have identified dementia. We're seeing these sort of the mean ages are around 55 among all groups, with plus or minus a year dependent on the race ethnicity. And again, sort of a year can make a big difference in terms of when this is identified, but from the population sort of qualitative view, things don't look too dissimilar by race and ethnicity. So this is our first survival curve. So this is time to incident dementia. So we've washed out people that enter our data with diagnoses, and we sort of split by these 10-ish years age brackets. And we sort of see that if someone in our study enters at 55 to 64, and we watch them for all 8 years, there's about a 50% probability that they will get a diagnosis of dementia over that time period. That might seem low, but again, we have a wide age bracket, and we're also sort of conditioning on people that have not yet had the diagnosis. So to be in that purple line, you have to enter our study at 55 and not have dementia, which is already sort of getting rid of probably 50% of people that were prevalent cases. When we look at it by age, so instead of using sort of time in our study as the x-axis, but sort of age, which we feel like we can do because we have such a sample that we see everybody for 8 years, we have a lot of data for each age point, we see that sort of if we follow someone, a hypothetical person from 35, if we can follow them to 75, we're at about 80% probability of dementia, conditioning on that they live long enough. And again, I want to stress this is clinician identified in a healthcare claim system, right? They could truly have dementia, but it could be unidentified. This is sort of the big difference between our work and a lot of the work presented so far, is that we don't have sort of the consistent evaluation for everyone that we would like. And I'll talk more about that in a bit. So we also looked by race ethnicity for this sort of time to ADRD, and we see that sort of the steepness of the curve is or the curve is steeper for white groups compared to other race ethnicities. So then we took those that we knew had incident, actually we could do this for all people in our study, even if they weren't incident. We looked at age at death, so at what age did they die with Alzheimer's dementia. We didn't sort of tie it one-to-one as the cause of death, but we can sort of safely assume that it played some role in the death. And we're looking at, again, a nicely normal distribution with a mean age of about 60 years. In our data, those that did not die with dementia died at about 50.7 years, which makes sense that they were sort of dying before they could get a dementia diagnosis of something other than dementia. Sort of our time to death, so this is a survival curve conditional on being an incident case in our data. So if you had your first dementia claim in our data, then we followed you to death. And if you were in that 55 to 64 group, if you were survived 8 years, or by 8 years of time, 80% had died. And again, I think that these age cutoffs are a bit broad. So if we look at it this way, in terms of by age as the x-axis, if we're almost sort of certainly going to die by 75 if you get dementia. And then we see some differences by race ethnicity, but mainly seeing sort of a survival advantage for the Asian group. We also sort of were able to explore mosaicism. So in the first half of our data, we had ICD-9 codes, which were not able to identify mosaic Down syndrome all that we weren't able to identify it. ICD-10, which started in 2015, had a code for mosaic Down syndrome and translocation. So we started with data in 2016, which was the first year that fully used the ICD-10 code, and we looked at age and incident dementia by DS type, and we saw pretty much no difference between mosaicism, translocation, and triplication, a difference of a year sooner for mosaicism. And then when we looked at time to Alzheimer's dementia by type, we saw sort of against expectation that the mosaic group and the translocation group, which the translocation we're not going to read too much into, had sort of a steeper curve. There was more quicker Alzheimer's dementia than was expected. We sort of hypothesized that because of the amount of the triplicated 21st chromosome, there would be less or less risk or a slower rate in the mosaic Down syndrome group, but we did not see that. So I think that I'm trying to show that we can use these sorts of claims systems to identify dementia in Down syndrome. This is an American healthcare system. I think we can do this for other countries that rely, that maybe even have more efficient healthcare data systems. And I think that there's a lot of promise for passive outcome ascertainment doing it this way. So I've got a grant under review with Joaquin Espinosa in Colorado to link these to the Trisome Explorer project. So we can take people's data from that and then follow them over time. So one point in time, biomarker, biospecimen collection, and then we can watch for outcomes passively, sort of reduce the burden of study participation on the participant and their families. It's promising that our results were in line with a lot of the clinical work and the meta-analysis of the clinical work, sort of mean ages of 54.5 with death within 5 years. And we were sort of also surprised to see little racial ethnic differences, given that in the US there are usually racial disparities for most bad outcomes, with minoritized groups facing the brunt of these healthcare issues. But we think that there might be a survival effect. It's well established that the infant mortality rate and the child mortality rate is higher in black children in the US compared to white children. This is with Down syndrome. So it's possible that we're seeing some sort of survival paradox where kind of weaker, quote unquote, white children are surviving into adulthood, where sort of those equivalent minoritized groups are not making it through childhood, sort of not making it past the congenital heart defect stage. Therefore, when they're adults, the marginalized minoritized group is, hardier, quote unquote. And then there also could be conflicting effects. So in the general AD literature, Hispanic groups and black groups get identified and diagnosed earlier, maybe due to the environmental exposures that they face. We don't see that here, but it could be in this context, in the Down syndrome context, that early diagnosis is a sign of optimal healthcare, right? Going to the Down syndrome clinic, getting a specialist, going to a place, like Pittsburgh or Barcelona or Madison, Wisconsin, and having an expert that can use the right tool to identify, whereas if you're maybe living in a rural area or going to a social safety net hospital, your clinician may not know the best approach for identifying dementia and Down syndrome. Therefore, the white folks are getting diagnosed earlier than they should, the black folks are getting diagnosed later than they should, and it ends up equaling out in the end. That will need some more further, sociological study. So the probability of Alzheimer's disease, sort of comparing to the literature, RAND put out an estimate that was about 65%. The literature goes closer to 90. We were at about 65% at 65 with a ceiling of 80%. I think we can agree that there is a group of people that will not develop symptomatic Alzheimer's dementia. It's just what is the range of that group. Our data sort of showed more of those folks, but again, we're conditioning on clinician-identified dementia. So it is very likely that some of these people that go through our study as no dementia are just not identified properly. But there is still a subset out there that are not presenting at that older age. So that's just what I said. And sort of some large prospective cohorts can help us understand and identify who's in that subset and who is just not being identified correctly. So there are limitations with this work, as you probably have all thought to yourselves and picked them all out in your head. We're dependent on healthcare use and access. So if someone with Down syndrome only goes to a doctor once a year, they are less likely to appear in our data in some of these ways than someone that's a high healthcare user. There's just less opportunity, and that is sort of an indictment on the US healthcare system, where some people just don't have the access that they need. We don't have claims validated for Alzheimer's disease. If anyone wants to partner with me on that, I would be really excited to sort of identify ways that we can improve our identification of AD in this type of data. You know, calculating sensitivity, specificity, then we as epidemiologists have the tools to account for imperfect sensitivity and specificity. The timing of all of this is fuzzy. Unlike a lot of the studies you all do, we don't know when people are getting, actually we do know when people are getting imaged and screened through claims, but we don't know from when they develop symptoms to when they actually go to the doctor. So if it takes a year for somebody to get their AD eval, we don't know that their caregiver was noticing symptoms a year prior. We only know the date of the billing. And we had to, we sort of assumed that we kind of had a steady flow of the full population over time, and that we just kind of took a cut out of 9 years. But if there were some cohort effects, if there were differences between people in 2010 versus 2020, there might have been some bias in our survival curves. So in conclusion, I think there's value in this type of work for Down syndrome and dementia. And as we sort of advance in our ability to use healthcare data and administrative records, I think we can actually dive deeper as, sort of we do this in EHR, where there might be some more clinician notes. And I do really think that longitudinal passive outcome assessment is promising. As we talk about cohort and trial retainment and participation, I think it's important to reduce the burden on participants. So more ways we can passively follow up, the better. Thank you.
So, our next speaker is Lucia Maure from the memory unit of the Hospital San Pau, who's going to talk about the epilepsy in Down syndrome. Lucia.
Hello, everyone. Thank you, Juan, and everyone for inviting me today. I am going to talk about the occurrence and description of epilepsy in adults with Down syndrome, and you may ask why epilepsy in this population. So the first and largest paper that I could find comes back to 1974. It is written by Dr. Bell, and it is one of the largest cohorts of patients with Down syndrome. It is 1,654 patients, and they evaluate the prevalence of epilepsy amongst them. And they already state that there is an advanced prevalence of epilepsy with aging. You can see in the table. They identify a peak at 30 to 34 years old, which seems fairly consistent in the different hospitals that they were studying. And they don't have a clear hypothesis as to why this is happening. Bear in mind that this is before even the amyloid cascade was proposed and long before DSAD was considered a genetic form of AD. But they do state that given the analysis of brain tissue, the possible connection with Alzheimer's disease is discussed. So what have we learned since this paper was published? This is what I'm going to talk about briefly. So we do know now that the overall prevalence of epilepsy in population with Down syndrome is greater than would it be expected in general population, and that it shows a bimodal distribution, the first peak being in the early childhood, and the second around the 4th to 5th decade, which goes in parallel to diagnosis of symptomatic AD. So regarding the first peak, this is it could overlap with other intellectual disabilities. This type of seizures that are most seen in early childhood and infancy are febrile seizures, general epilepsy, both motor and non-motor, and infantile spasms, including West syndrome. There are several mechanisms that could explain this higher prevalence of epilepsy in childhood, including frontal and temporal lobe hypoplasia, dyskinesia of dendrites, abnormal neural lamination, decreased neural density, and Also, especially complications derive from hypoxia due to a higher prevalence of congenital heart disease and surgeries among Down syndrome patients at younger ages. But the second peak, which is the one that we will mostly be discussing, occurs above the age of 40 to 45 years old. The types of epilepsy that are most prevalent in this group are generalized or bilateral tonic-clonic seizures and myoclonic seizures, often coinciding, both of them. They have a morning predominance at awakening, and when EEG is performed, it can show diffuse slowing of background activity and generalized intercritical or critical paroxysms of spike wave or polyspike wave. Now, the reason why this is interesting is because it has been seen that this is closely related to symptomatic ID in this population, and this specific syndrome has been called late-onset myoclonic epilepsy in Down syndrome. The treatment, the seizure freedom is usually easily obtained with monotherapy or B-therapy, but nevertheless, the development of these epileptic seizures mark a more rapid cognitive and functional decline. The epilepsy is considered a risk factor for more frequent hospital admissions and an independent risk factor for mortality in adults with Down syndrome. So the relationship between epilepsy and Alzheimer's disease is a very studied one, and that is currently into research, not only in the DS population, but also in the general population and in the autosomal dominant AD, with prevalences being higher than the general population without AD. So there are some proposed mechanisms. One of them is the higher burden of amyloid pathology, tauopathy, or the more frequent petechial hemorrhages due to cerebral amyloid angiopathy. And how this could work in mouse models, it has been seen that the high levels of amyloid interfere with the reuptake of glutamate, and the being of extracellular accumulation of amyloid beta plaques induce synaptic degeneration, circuit remodeling, and an abnormal synchronization that could lead into epileptogenesis. Moreover, tau protein has been considered a necessary mediator of the epileptogenic effects, increasing significantly extracellular glutamate and inducing dysfunction of the NMDA receptors. But what is more interesting is that this relation is considered to be bidirectional, so not only does AD pathology higher the prevalence of epilepsy, but it has seen that the presence of epileptic seizures, both clinical and intercritical epileptiform activity, favors this amyloid beta deposition. So I will now discuss the study that we are ongoing and some preliminary data. So the aim of the study was to describe the distribution of epilepsy and different seizure types among our cohort of the DAs patients here in the Barcelona clinic unit. For that, we included patients evaluated between February 2013 and December 2021, and all patients were evaluated by a neurologist and our neuropsychologist on a 6-monthly to yearly basis, collecting intellectual disability, cognitive status, asymptomatic, prodromal, or people with dementia due to AD. And we did a detailed medical history in relation to epilepsy and its risk factors. The diagnosis of epilepsy was made according to the international criteria for epilepsy, being at least 2 untriggered seizures separated by 24 hours, or 1 untriggered seizure with either abnormalities seen at EEG or a medical condition increasing the risk of seizure by more than 60% within the next 2 years. And this is to bear in mind that the presence of Alzheimer's disease in Down syndrome per se is considered a medical condition that increases the risk because it has a risk of 75% of recurrence. So this is the initial data that we have. The total N is of 906 patients. The median of age is of 46. We see that there is statistically different mean of age depending on the cognitive status, which aligns with what we know about Alzheimer's disease progression in this population. There is no difference in sex, with 54% being male. And we also divided by intellectual disability, and we found that there was also statistically different, being that there were less profound intellectual disability in the cognitive stable, and also less mild intellectual disability in the demented stage. This is not something we had accounted for, and we will look further into it. Regarding APOE status, we found there is no statistical difference in the types of APOE, the most prevalent being 3-3, being 70 patients, followed by 3-4 and 2-4. And regarding the past history of risk factors for epilepsy, they were not more prevalent than the comparable in the general population. At least 2.2 had a first-degree family history of epilepsy, 1.1 had either meningitis or other nervous system infections, less than 1% had either brain surgery or a traumatic brain injury, and about 1.9% had febrile seizures, which is lower than in the general population. So regarding the incidence of epilepsy, here's a distribution of the age at first seizure that our patients had. So taking the overall diagnosis of epilepsy, 20.5 of the participants had a diagnosis of epilepsy, at least one throughout their lives. We can clearly see that there are two peaks, so one in the childhood and early childhood, but also adolescence, and another one bigger and after the age of 35 to 40 years old. So only 15.6% of the first epileptic not triggered seizures occurred before 18 years old, and 71% occurred after the age of 40. Regarding types of seizures, we saw that in the first group, the most prevalent were bilateral tonic-clonic, followed by absence, infantile spasms, and focal seizures, which is what is expected in this group. The second group, which had a lower prevalence of epilepsy, there were more focal seizures, absence seizures, and general tonic-clonic. And our last group was really only defined by myoclonic seizures and general tonic-clonic seizures, which is also what we had expected, given the Lometz syndrome that we defined. So, regarding prevalence of epilepsy, in order to study this, we disregarded those patients who had a seizure in infancy and were later not active after the age of 18 years old. So the total prevalence of epilepsy in adulthood was of 18.5 years old, but it 18.5%, sorry, but it increased significantly with age to more than 40% in the population around the 6th decade. So looking at this, we of course thought that the increase in age is associated with an increase in the epilepsy prevalence, but knowing what we know with increase in AD diagnosis among this population, we looked at as if this was driven by age or by the diagnosis of AD among this population. So we saw that 71.4% of the patients with epilepsy had already a previous diagnosis of either prodromal AD or AD with dementia at the moment of the first seizure. And when doing a regression, we saw that this significance was almost only driven by the diagnosis of AD and not the increase of age. Regarding APOE4 status, which has been described in the general population as a risk factors for more prevalence in epilepsy or earlier ages of appearance, we did see that there were more carriers than non-carriers in the prevalence of epilepsy, but this was not statistically different. And we also saw that the mean age of first seizure varied. It was 1 year before in APOE4 carriers than in APOE4 non-carriers, but this also didn't show statistically significant. Regarding treatment, as expected, most of the patients were treated with monotherapy or B therapy with the most common anti-seizure medicaments, levetiracetam or valproic acid. And now the next steps that we want to study are, first of all, the neurophysiological data. So what we know, all that I've shown is clinical epilepsy, but we think that there might be subclinical epileptiform activity appearing before the clinical epilepsy, and that is interesting to study. Also the correlation with other biomarkers, both AD biomarkers, neuroinflammation biomarkers, and neuroimaging, especially looking at the presence of cerebral angiomyopathy and superficial siderosis. And we, as Dr. Carmona will later explain, we're also very excited to be starting a clinical trial with an epileptic drug, and we are interested to see in the future what could anti-amyloid therapy do in regards to epilepsy in this population. We also are interested in looking at possible risk or protective factors that make the other 54% of DSAD patients not have epilepsy. And we are also interested in seeing in our cohort how the presence of epilepsy changes the years to death since the onset. Finally, we are very excited to be able to do future collaborations and expand our cohort with different cohorts around Europe and the rest of the world. So if any of you is interested, we would be happy to collaborate. And this is all. Thank you very much.
And our last speaker of the session will be Eric McDade. He pre-recorded his talk, and he will not be available for questions because it's 2 a.m. in St. Louis.
I'm Dr. Eric McDade from Washington University, and I appreciate the opportunity to participate in today's session period. I apologize that I was not able to be there in person. So I want to thank the organizers for, one, organizing this meeting, which I think is critically important given the ongoing efforts in both dominantly inherited Alzheimer's disease as well as Down syndrome, and thank them for the opportunity. So I'm going to be talking briefly about using natural history studies in dominantly inherited Alzheimer's disease for primary prevention studies. So a consideration of how we use those natural history studies. Here are my disclosures. So as many of the attendees will know, there are a number of challenges associated with performing primary prevention studies in neurodegenerative disorders. And what I'd like to highlight today is how we're using the autosomal dominant population to overcome some of these. So one of the critical aspects when we think about this is relative to other diseases like cardiovascular disease or cerebrovascular disease, when we think about the outcomes for primary prevention in neurodegenerative diseases, there's not quite as well identified or rather defined binary outcomes. So when we think about time to event approaches to things like identifying a stroke or myocardial infarction, those are much easier to operationalize versus identifying some of the subtle cognitive changes that occur very early in the disease and the differences between individuals related to that. There's also a long window of time from the identification of the pathologies that we're often targeting when we think about primary prevention approaches and how those are related to the clinical symptoms. And subsequently, this results in us having to potentially run studies for over 1 to 2 decades when we think about this. And likewise, there's a general uncertainty right now as to the surrogacy of any of the pre-symptomatic biomarkers with the eventual clinical outcomes. Many of us have assumptions about which one of these are more strongly related to clinical and cognitive outcomes, but actually demonstrating these in a causal way has not really truly been done up to this point. So we can approach this in one of the relatively well-established ways that we've started with genetically determined diseases, and we can use the x-axis to map out when we expect symptoms to happen. And then if we're targeting a specific pathology like tau, for instance, the slide here essentially just shows, using cross-sectional data, how we can essentially identify when the pathology starts and how we might want to target it. And not only that, but how the pathology might be related to other aspects of the disease, specifically amyloid beta pathology. So if you look here, you could target at the earliest stages starting a couple of decades before, or you can target at other stages where we begin to recognize neural dysfunction related to or measured by other biomarkers like FDG-PET or MRI, and then eventually getting to clinical symptoms and significant neurodegeneration in tau PET, which you see on the right. But one of the ways we've thought about approaching this, however, and we've sort of moved to when we think about a primary prevention approach with this, is actually trying to use multiple biomarkers. In many ways, how we use cognitive composites. So I think there's been a movement towards using cognitive composites that represent different cognitive domains and subsequently effects on these cognitive composites are likely or more likely to be associated with meaningful effects from the intervention that we're introducing. And I think we can do the same with biomarkers, especially when we think about approaching these from the primary prevention approach. So on the left, we have a number of different biomarkers that map out to when they become abnormal at different stages of the disease, with red representing the non-carriers, red representing mutation carriers and blue representing the non-carriers. And you can sort of map those out, either soluble phosphatide markers, microtubule binding markers, MRI measures of neurodegeneration, or NFL. And what you can do instead is not only mapping when these should be abnormal, but then looking at the probabilities of the abnormalities on the right is what you're looking at. And if we use the estimated years of onset and look at the probability of a biomarker being abnormal in a mutation carrier relative to a non-carrier, you can actually see there's a nice separation in when these start to develop. So if we combine these, we're essentially mapping different aspects of the disease within an individual that we are proposing to actually use as a way to track how the disease progresses. And one way of increasing the confidence that this is an important approach is looking at these biomarkers. So if we take these 6 biomarkers, for instance, and that's what we're representing here, you'll see down in the bottom 0 to 2 or 3 out of 6, that represents the number of abnormal biomarkers. So if you look at individuals that have only 2 of these biomarkers abnormal, some of the earliest ones that we see within these curves here, you notice that the likelihood of them having a change in the cognitive composite is quite low, and that's represented in the blue. However, once you cross the threshold from 2 of these to 3 of these, you start to identify actually a much higher probability that individuals will start to have a significant decline in their cognitive performance even before disease onset, and obviously maps to the point of the symptom onset beyond 0. But we're proposing actually to use multiple biomarkers together to try to map this in a better way. And another way of looking at this is actually look at biomarker profiles overall. So one of the ways that we are proposing to try to bridge the long period of time from when biomarkers become abnormal, starting here, about 20 years before symptoms onset, to here at 0 when we expect symptoms to develop, is actually look at what's the likelihood along this disease trajectory that these biomarker profiles begin to change. And so if we look on the left here, this is the non-carriers from the Diane observational study. And if you look here, in general, what you find is almost all non-carriers are a 0 on the biomarker composite. So this means that all of the biomarkers are abnormal. You have a small number of these individuals that get into these higher numbers, and some of these represent individuals who may actually, in fact, have AD pathology depending on their age. But a lot of these actually come up and then they bounce back down. So the likelihood of any mutation carrier or non-carrier going beyond a biomarker profile of a single biomarker is exceptionally low. However, if you look at the non-carrier or the mutation carriers, what you find here is that by the time individuals get between that 15 to 10 years before symptom onset, you see a much higher probability that they begin to increase to these higher profiles. So if we enroll individuals for primary prevention studies somewhere around 25 to 20, the goal here is now to actually keep them in these non-carrier profiles. And by doing that for longer periods of time, for maybe 10 years, so from minus 20 to minus 10, instead of minus 20 to 0, so a 2-decade study, which would be required to truly demonstrate that biomarker prevention of or targeting amyloid, for instance, would prevent clinical and cognitive decline. It allows you to actually begin to leverage the probabilities that keeping people in lower profiles actually keeps them in a disease sort of modified state. So in summary, disease progression models in genetic Alzheimer's disease provide an important roadmap for prevention trials, but I think we need to move obviously on these sort of simple trajectories that we've identified to actually thinking about how these trajectories can actually be used in a better way to demonstrate that we're preventing disease progression prior to clearly demonstrating clinical symptoms. And again, this is particularly important when we think about a prevention approach for amyloid. With amyloid pathology developing up to 2 decades beforehand, it's going to be critically important to run clinical trials that allow us to make decisions at a much earlier point, and also leverage ongoing trials at later stages of the disease and sort of map those back. And by linking multiple biomarkers, we think that this is one way to truly demonstrate a likely disease modification approach within these populations in a much shorter time period than the multiple decades that would otherwise be required. I think another important component here is understanding the similarities between genetically determined types of Alzheimer's disease and sporadic AD. Still requires a significant amount of work in order for us to leverage the studies that are ongoing and planned right now between these two different populations to leverage the ability to map the disease much better in genetically determined Alzheimer's disease with the outcomes of clinical trials that are much larger in sporadic Alzheimer's disease, where we don't have the same luxury in Down syndrome and autosomal dominant Alzheimer's disease. So I'm there and acknowledge the teams that make all of this work possible in the autosomal dominant Alzheimer's disease in the DIAN studies, the Knight family DIAN-TU. These are our DIAN-TU sites and our collaborators that have made this possible. Thank you.
Yes, we thank Eric, although he doesn't hear us. Wow, I think that was a fantastic session overall, and I'm sure you have many questions. If you don't, I have tons of questions, but I'm sure you have, and let's maybe start with the room. Brian.
So my question is actually for Lucia. So I find the association with epilepsy really interesting. So we know transgenic mice are very prone to epilepsy. Epilepsy is also something that's elevated in autosomal dominant, but to a much lesser degree. So do you think this plays in potentially to what we were talking about in the last session, where there's this greater medial temporal involvement, perhaps in Down syndrome, as we know a lot of the epileptic foci tend to be in medial temporal lobe, right? So do you think there's any sort of relationship there between this MTL and the epilepsy?
That's a very interesting question. I don't know the exact answer, but there are differences between also the types of seizures in ADAD and DSAD. What I've read, ADAD don't usually have so many myoclonic seizures, which are more cortical and have more focal seizures. So I think there has to be some focal differences in the distribution of the epileptogenic factor that make the seizures differ and the prevalence differ between them.
Maybe I can add that the intellectual disability as a whole is very heterogeneous, but one common feature is that it has usually increased epilepsy frequency, so it's closer to 8-10% rather than 1-2% in the general population. So I think that DS has both. No, probably it has intellectual disability. This is by definition abnormal wiring if you want to reduce it to the max. So maybe the same what you just said, Brian, is you have a cortex or a brain that is organized due to the mental disability, and that's more prone to epilepsy when you have amyloid. So we always say that this is a very nice stepwise increase in epilepsy frequency from sporadic AD that also increases both clinical and subclinical epilepsy, because the other thing is that we haven't talked about the subclinical epilepsy that's way higher than the clinical manifestation. And then autosomal dominant AD as intermediate, and we haven't shown the data, but the frequency of epilepsy after 4 years of diagnosis of dementia is like 60-80% of those that had developed dementia. So things that they die fast, but otherwise the frequency of clinical epilepsy in DSAD is huge.
Great talks. Something that was across all the talks I was very interested to see if you would be able to discuss is gender differences. So with regards to APOE4 or in the Medicare data or in your seizure detection, do you see differences by gender?
That's a really nice question. And the answer is no. And I think there is a publication bias, a huge publication bias toward positive results in gender. I know this is highly polemic, but in genetic forms of AD, I think this, we can safely say now that there isn't huge sex differences in autosomal dominant AD. In DSAD, we published a paper, just Alexander Bejanan here, published a paper there, he already mentioned it. That doesn't mean that there isn't any difference. So there is certainly an APOE by sex interaction, but the main effects were mainly negative. I know the data of Eric, but I'll let him talk on his data, and the APOE for homozygotes in this large data set did not see a gender difference in APOE for homozygotes. We did see differences in other haplotypes with worse cognition for men, not for women. So I think there is a lot to say about these gender studies. But I won't say anymore, not to enter into trouble.
I have a question for Eric Rubenstein. Healthcare utilization, is that data that you'd be able to look at in terms of hospitalization rates, acute care, subacute care, skilled nursing facility, expenditures? This is a wide open field, and I think in ALZNet we just capture a diagnosis of Down syndrome as one of the potential reasons for prescribing these new treatments for that type of analysis, but do you already have access to that, and would you be able to?
Yeah, so we have all of that. We've cleaned the healthcare utilization, the cost. We haven't looked specifically at DSAD. We have a publication that looks at Down syndrome broadly and mean and average cost, but we have all of that, and then just sort of as, you know, we're in year 3 of this project, and sort of our first big thing is, you know, service use and then conditions, and then we can just dig deeper and deeper to get to the, you know, individual provider level. It's just going to take a little time to clean this data.
And just to follow up, Mike, I think that what you this passive evaluation of cross-sectional analysis that can be done, I think has huge potential. I love it, and I think that it really nicely fits with what ALZNet wants to do, no? So I think this is fantastic opportunities.
Yeah, I think comparing those expenditures per capita to other forms of AD will help shed light on how severe the issue is for clinicians seeing adults with Down syndrome, and you know, whether they're on Medicare or Medicaid or neither, those expenditures are, and the copays and so on, are something that people don't think about, and it just raises that ethical imperative of bringing treatments to this population just from a financial aspect, not even thinking about quality of life. So I think those type of analyses are desperately needed to help shed light on the severity of the situation.
Thanks.
I had another question about the epidemiology. On your graphs on the incident dementia, you showed that the stratification by age 65 plus had a lower risk of incident dementia than the others. So I wonder if you could comment a little bit more about that, if you had looked at other stratifications beyond just 65 plus or maybe 75.
Yeah. So we think that the issue is that we're conditioning on age 65. So someone had to go all the way to age 65. And I think at that point we're getting a mix of a small percentage of people that are misclassified for Down syndrome. You know, we have a sample of 5 million. There's going to be a handful of people there, and then these low service users that maybe, you know, go to the doctor once a year, don't go to the doctor, they were picked up in the past for having Down syndrome, and then we just don't see them frequently enough to make the diagnosis. I think that sort of when we look the other way with the age as the x-axis, we do see sort of, you know, it picking up towards the end and people getting it in that older age group, but I think that there is a bit of a bias when we start conditioning on that old age. Those are either the ones that never get it or the ones that are missing sort of service use.
And if I could follow up for Juan, question on his nice work on E4 homozygotes. I like the concept. I was wondering if you think you could apply it to heterozygotes. Why not extend this idea to people who carry just one E4 allele rather than 2?
No, this is, I alluded to it, so I think that if APOE 4 heterozygotes did not exist, we would be talking about autosomal recessive AD. That would be what I propose. But the fact that APOE3 homozygotes are consistently in between APOE4 homozygotes and APOE3 homozygotes. They have intermediate age of onset, they have intermediate predictability, they have intermediate biomarker profiles, so they're just in between. And that's why, and it was a fantastic group of geneticists in 2011 in the molecular psychiatry paper that suggested this term of a semi-dominance to capture the full impact of APOE on AD. But I can tell you that that was the first approach I gave to the paper, and that wasn't going to go through with reviewers. So we just restricted this concept with APOE homozygotes. We made it clear that APOE3 heterozygotes were in between, and that some people had called that semi-dominance, and that went through.
I see.
So maybe just following up a little bit on that discussion. So question for you, Juan, and there's some emerging data that suggests that it's APOE, but actually it's more the ancestry or the background of the genetic ancestry that may drive that risk, and that's where we see some of the differential risk in different populations. So when you're thinking about the APOE homozygotes and just considering the cohorts that you looked at, have you thought about how to look at that context of genetic ancestry and how that may impact the model that you're looking at?
That's a wonderful question, and there is a very recent paper in JAMA Neurology looking into ancestry and certainly the impact of APOE. The established knowledge is that it's much higher in Asian population than in whites and much less in black people and in Latinos. I have some concerns how the data has been done. First of all, it's based on odds ratios, and this is something that you should, if you believe this is autosomal, is genetically determined, you should not do it. Sometimes I joke that if I have a gun in my head and I shoot myself, the odds ratio of dying is 1. I'm just going to die faster. So just in a genetic condition that you're bound to develop dementia, odds ratio should worry you, just as a starter. And but yes, certainly we are worried about that, and we are looking into that in the UK Biobank, because the problem here is that in order to assess this, you need huge numbers. And even in the data set, in this large data set that we had over 10,000 individuals in the clinical cohort, the number of minorities was horrible. That's in part due to bias in AD research in the US, as you well know, so it's not representative of the 15% population. So the numbers of minorities that we had, it did not allow us to look into we could look into the gender effects, that's in the paper, but we could not look into the racial effects with the biomarkers. But we are looking that in the UK Biobank. So certainly that's work in progress. We're working the UK Biobank data to answer.
Yeah, and I don't mean race or ethnicity. I mean like genetic ancestry, which is a little bit different.
Yeah, of course, but sometimes you don't have that, so you have to go with. I agree.
So I have a question for Eric. It's Andre Strydom up here at the back. So great work. It's very good to see that you're able to replicate what we've demonstrated in prospective studies. And as you know, we're also working on some of these clinical data sets in the UK, primary care data sets. One of the issues that's mentioned sometimes is how reliable they are, how representative and so on. And I think it's proof of principle if you can replicate some of the data that's already out there with regards to age of onset of Alzheimer's disease, for example, or age of diagnosis of Alzheimer's disease in people with Down syndrome, so it's great. I have a question about the mosaicism story. So do you think, how reliable do you think is the coding for the type of Down syndrome in your data set? And, you know, there's two possibilities. One is that maybe mosaicism is not well recorded, and the other is that the trisomy group might include people who look like they have Down syndrome but have not genetically been confirmed? Do you think those are possibilities?
Yeah, no, that's a terrific question, and I think that we were hopeful that the prevalence of mosaicism in our data is about in total it's about 2.1%. So it kind of lines up with the estimates that are out there. But we acknowledge that there is definitely a ton of under-identification, both in terms of if an adult comes in and doesn't have the karyotype to hand to the clinician, will the clinician order a genetic test? Probably not. And then does the clinician know to code for this new ICD-10 mosaicism? Possibly not. So we're sort of going to hopefully track this over time as sort of the genetic testing in terms of its incorporation into this type of data becomes more common, and this new ICD code, I think it's kind of just a start. But, I think that if there was a huge difference in mosaicism, we would see a little something more. So I think it's a little bit of evidence that maybe in this population, in terms of ID, Medicaid, Medicare, relying on the public health insurance system, we're not seeing much of a difference. And I don't think that the misclassification would push it all that much more, but it is something definitely that over time we hope that identification becomes better.
Maybe I can have a follow-up question to that, because this is obviously a very interesting piece of the data set. Just assuming that the questions that Andre rightfully raised are okay and that the coding is right, the few mosaicism cases that I've seen range from 20% mosaicism to about 60 to 80% trisomic cells, 20% trisomic cells up there. And now we sit here and say, okay, Alzheimer's and Down syndrome is largely a gene dose problem. Wouldn't the fact that the mosaicism seemed to perform poorer shake a little bit on that concept?
So my sense, not being a geneticist, is that they're probably, based on our data, is there's a threshold dose where these people are definitely phenotypically presenting as Down syndrome, being that they have intellectual disability, they're using these services, they are, I would assume, on the sort of higher threshold end of mosaicism. We don't have the percentage of mosaic cells in these data, which is something that is not feasible to get with this type of data, which is a limitation. And then we know we're missing those that don't present with intellectual disability. So we are, I think, looking at the mosaics that look the most like the non-mosaics, which sort of prevents us from really assessing the dose response in those that are presenting without or very, very mild intellectual disability.
If I can jump, the first thing I want to say is that we have a webinar in the DSAD-PIA. The last DSAD-PIA webinar that we did was monographically devoted to mosaicism. Eric was one of the two speakers, and the other one was Laura Chicota from Columbia University. And she also presented one interesting data that the percentage of mosaicism increased with age. So it seems that, and even longitudinal, so it seems that the older you get more mosaics than not, which is really intriguing and opens a lot of possibilities. We discussed several of them in the webinar, so if you're interested in that, I suggest you watch the recorded webinar.
Maybe I can take the privilege also to take the last question, because I think Raquel's data set is also extremely interesting, because in some way, very obvious that many of these diseases have to be asymmetrical. In the movement disorders world, that is very easy to study, and in some parts of dementia like logopenic variant, PPA, and so forth, it just also jumps in our face. But what would you think, Raquel, how much of this seemingly symmetry is kind of overlooked because we are not very good in assessing cognitive functions due to laterality, and we need to use biomarkers to look at asymmetry?
Yes, I think so. I mean, in fact, the project starts for the study of progranulin mutation carriers because this is a clear asymmetric disease, and our surprise was that the Alzheimer's disease population, the sporadic Alzheimer's disease population, were also asymmetric compared to control. So we start with studying that. But I think, it's clear that subtle difference is not a huge difference. But I think it's relevant because they can, first, because they could be a sensitive marker for changes. For me, it was a surprise to have difference at the asymptomatic mutation coverage level, but also because they can explain some difference in another type of studies that sometimes do get asymmetric results, and you don't really know why you find asymmetric results in the comparing groups in other type of studies, and this could be the cause of some asymmetric results we find in another type of cross-sectional studies. But of course, I think that even if we find that that these subjects are asymmetric, I think that it's difficult to think that this will impact the clinics. I think, of course, we don't have very sensitive measures for difference between the left and right hemisphere other than the typical ones, so to capture subtle difference in that. But we are not thinking that it's a huge impact in clinics. I think that's just from the biomarker point of view, from the neuroimaging point of view, but I will not expect a huge difference in the clinics based on this asymmetry we see in genetic Alzheimer's disease in autosomal dominant, because as was mentioned by Brian before, we don't see really this logopenic or asymmetric clinical presentation in autosomal dominant Alzheimer's disease compared to Alzheimer. But anyway, I think it's a sensitive measure and could explain another findings in other type of neuroimaging studies.
Great, thank you. I think with this we have earned ourselves a coffee break.
Thank you.
So before we start the next session, I was going to ask all of you that after this session and before the lunch, if you don't mind, we'd love to have a group photo of everyone. So as you go out for lunch is to the left, so we ask you to resist the temptation and just continue a bit further to the next building. There is a few stairs, and it's a really nice spot where we can make the group photo. So we'll try to make it just before the lunch. So please be there. Thank you.
So, ladies and gentlemen, welcome to the last session of the morning devoted to clinical trials in pre-symptomatic and at-risk individuals of genetic AD. And we'll start with world-renowned Michael Raffi, who will tell us everything about clinical trials in AD, DS with AD.
Thank you. Thanks for the kind introduction, and what a great meeting, Juan. 5 years ago, I would have never guessed that we'd be in this situation. My name is Mike Raffi. I'm a professor of neurology at USC, and I'm going to talk to you a little bit about some of the work that we've been doing in preparation for clinical trials for preventing Alzheimer's disease in people with Down syndrome. These are my disclosures. In 2018, we were funded by the NIH to develop a clinical trials network to conduct clinical trials specifically designed for people with Down syndrome. Currently, we have 20 sites, 14 in the United States and 6 in Europe, and we are funded by the INCLUDE initiative. The INCLUDE initiative is a trans-NIH initiative spanning all of the NIH institutes aimed at funding research to bring the latest therapies and understanding of comorbidities to this population that has been ignored for quite a long time. So our first project that was funded was a trial-ready cohort for Down syndrome. This is a deeply phenotyped population of people with Down syndrome who have self-identified as being interested in participating in clinical trials. Initially, we were funded to enroll 120 participants. We are now at approximately 235, going up to 250 participants. And these individuals receive MRI, amyloid PET, tau PET, plasma testing, cognitive assessments, very similar, in fact, nearly identical to the ABCDS protocol, which you've been seeing results of in the past day and a half. In fact, we allow for co-enrollment with the ABCDS protocol. The majority of people in TRACK-DS are, in fact, co-enrolled in ABCDS. The idea of the trial-ready cohort is to follow individuals who are now medically stable. In prior trials, we have found, at least in the United States, that people with Down syndrome may not always have identified all of their medical conditions, particularly hypothyroidism and other conditions that can interfere with participating in a randomized clinical trial. So in order to ensure that they are medically stable, we've enrolled them into a trial-ready cohort before matching them with a clinical trial. And the idea is that they would be offered one of several clinical trials that they might be eligible for, and then at the completion of those trials, they would return to this trial-ready cohort. We wrote a paper sort of proposing this idea over 10 years ago, and we initially estimated we want to have 1,000 individuals in such a trial-ready cohort, and our hope is in the future that we will achieve that. At the end of the trials, the individuals return back to the trial-ready cohort and continue on until the next clinical trial is available to them. As we think about clinical trials targeting Alzheimer's disease, I want to remind you that there are different strategies that one can take, certainly the treatment stage, but also secondary prevention and primary prevention. I work at the Alzheimer's Clinical Trials Consortium. This is the clinical trial arm of the NIA to conduct clinical trials to prevent Alzheimer's disease. We conducted the A4 study with solanezumab and are currently conducting the AHEAD study with lecanemab in people who are completely asymptomatic but have the presence of elevated brain amyloid. When targeting individuals for secondary prevention, we are looking at the preclinical AD stage of the disease, And these individuals clearly are asymptomatic. And now, as you've been hearing over the last day and a half, we can stage individuals using the ATN framework to help understand their expected rate of decline, as well as changes on other biomarkers. We have found over the past few months that the plasma p-tau217 is so accurate in the Down syndrome population that in TRACK-DS we've actually dropped the use of PET and are using plasma to pre-screen individuals into that cohort. As we think about these clinical trials, and we've been hearing a lot about this continuum of Alzheimer's disease, I want to remind us that these biomarkers have profound impacts on the design of our trials. So here on the x-axis are the different age ranges of individuals in the ABCDS cohort, and on the y-axis is the proportion of people who would be amyloid positive. Now, we've heard about 18 centiloids and 25 centiloids, and we've seen cases of individuals with Down syndrome who have 100 centiloids. What defines amyloid positivity? And currently, the three potential options are a threshold of 20 centiloids, 25 centiloids, and 30 centiloids. Greater confidence in amyloid PET positivity, or amyloid positivity with a higher threshold. But what you can see is at the age of 40 to 44, approximately half of the individuals, about 60%, are going to be amyloid PET positive if you use a threshold of 20. And it drops down to about 45% if you use an amyloid PET threshold of 30. So what you set as your PET positive threshold has a profound impact on your screen fail rates and the number of people that you can bring in. I also want to point out that below the age of 40, you see that there's only about 5% of individuals who are amyloid PET positive. So in our clinical trial designs, we consider pre-screening with plasma, as we do in these prevention trials that I mentioned, A4 and AHEAD, specifically with AHEAD, to reduce the number of screen fails based on amyloid PET. This graph, also coming from the ABCDS group, looks at the different age ranges on the x-axis and the prevalence of clinical diagnosis. And there are three diagnoses that are given by consensus in this cohort. Cognitively stable, which is the blue, MCI, which is orange, and dementia, which is gray. And this dashed vertical line is around age 54, which we've been hearing about now from epidemiological studies and papers. The first one was published by Andre Strijdom, looking at the average age of dementia diagnosis, and it seems to be somewhere around age 54. And what you can see here is that looking at the prevalence of individuals who are cognitively stable, around the age of 40 to 45, you start to see that the prevalence of being cognitively stable declines, such that by the age of 50, about half of the individuals are cognitively stable, and half are not. They are starting to develop either MCI or dementia. Now, I will remind you that those individuals who are on this cognitively stable line, who are then amyloid positive, those individuals are preclinical AD. Those are the individuals that we want to target for our prevention trials. So there are several therapeutic targets for Alzheimer's disease in people with Down syndrome. This graph just shows the extra copy of chromosome 21, the extra copy of the APP gene resulting in extra copy of APP protein, which is thought to lead to overproduction of A-beta monomers, dimers, oligomers, protofibrils, and finally plaques. And some of the targets include immunotherapy, as well as antisense oligonucleotides targeting that mRNA and reducing that abnormally elevated mRNA. Monoclonal antibodies have been tested now in over 7 or 8 trials, from bapineuzumab through aducanumab, and now we have lecanemab fully approved. Not a single person with Down syndrome has been in those trials, or as far as we know, treated with lecanemab, and donanemab, which is on the horizon to also receive full approval. In addition, vaccines represent another option for a therapeutic mechanism. And I'm going to talk a little bit about some of the work we've been doing in collaboration with AC Immune on active immunotherapy. AC Immune has developed a vaccine, ACI-24, that is a lipid bilayer that includes the first 15 amino acids of the A-beta peptide. That elicits an immune response, and as a vaccine that's given over several doses, eliciting an antibody response against A-beta. And we conducted a phase 1b trial, randomized, placebo-controlled, thinking that people with Down syndrome may actually be the ideal population for administration of vaccine as opposed to a monthly or even bi-monthly IV infusion. With the vaccine, we found no cases of ARIA, no evidence of CNS inflammation, and only about a third of the participants developed antibody titers. And these antibody titers in these individuals were not associated with any adverse findings. So the vaccine elicited a response, but not in as many participants as we had hoped. So AC Immune went back and redeveloped a reformulation of that vaccine that's essentially the same vaccine, but with an additional peptide, an adjuvant peptide, that elicits a bit more of a response, of an immune response. This is, again, another vaccine that has that first 15 amino acids of A-beta. It has additional coverage of pyroglutamate A-beta, which is a target for lecanemab and donanemab that is in the plaque species, and it allows for immunogenicity against beta stronger than that which was achieved with the original vaccine. And this vaccine has now been tested in preclinical models and, in fact, is in human testing. Now, the testing is currently a phase 1b, phase 2 trial. It's a multi-center, double-blind, randomized, placebo-controlled study that's looking at the safety, tolerability, immunogenicity, and pharmacodynamics of this new formulation of the ACI vaccine. But what's unique about this ABATE study is that the participants, some of the participants in the first phase of the study have prodromal AD in the general population, and then the second part are individuals with Down syndrome. We're recruiting 80 participants between the ages of 35 and 50, and as you have seen from the data in the past day and a half, that there seems to be a window, an ideal window, where you're developing AD pathology, you haven't fully developed dementia, and you haven't developed all of the ARIA and microhemorrhages that we see and neurodegeneration that we see in the later stages of the disease. For participants under the age of 40, there needs to be prior evidence of amyloid elevation. Otherwise, you have a 5% chance of being amyloid positive. The individuals will be receiving 6 IM injections over 74 weeks with a 26-week observational follow-up. And there are currently 14 sites, 7 in the United States and 7 in Europe, that are conducting this study, with 3 additional US sites under consideration. This study was launched last quarter of 2023 and is ongoing. The ABATE study will evaluate the effects both in sporadic AD as well as in individuals with Down syndrome. We will have an early assessment of safety in the sporadic population as we are now moving into the Down syndrome population with dose selection based on the appropriate readout on biomarkers. This idea of transitioning from a small trial in the sporadic population for dose finding and then transitioning into the Down syndrome population has a very appealing approach in that it really ensures safety and appropriate dose finding before we go into the Down syndrome population. So that was the vaccine. We have now plans for later this year to launch an anti-APP ASO, and further later in the year, an anti-amyloid monoclonal antibody. The information about those trials will be released in the near future, but we're very excited that we're going to be able to bring these new therapies to this population. So in summary, you've heard about just amazing advances that are being made in this field. And the biomarkers and understanding the natural history are letting us have a framework to design these clinical trials targeting the key elements of Alzheimer's disease. I also want to note that in the revised NIA-AA criteria, now the Alzheimer's Association work group on the criteria for the diagnosis and staging of AD, Down syndrome is now called out in this guideline. And the calling out is that individuals with autosomal dominant AD and equally those individuals with Down syndrome represent stage 0 of Alzheimer's disease. And stage 1, stage 2 being defined by the presence of elevated amyloid and other pathology is really where we'll be thinking about secondary prevention, but in fact we can now consider, just as in Diane to you, primary prevention in this population as well, based on that framework and a potential regulatory pathway towards approval. So 3 clinical trials of disease-modifying therapies are now underway or planned in people with Down syndrome, and we have engaged additional partners who are interested in working with us as this field is maturing to bring even more therapies to this population. Certainly it takes a large number of individuals to conduct these studies. Of course, all of the ABCDS sites are part of ACTCDS. We have a wonderful collaboration with them. We also have a wonderful collaboration with our European partners, many of whom are here today. We would not be able to do this unless all of us band together. It's such a small, vulnerable population with limited expertise that we really need to work together to accomplish our aims. Thank you very much. Our next speaker is Laurent Meijer, who's going to be talking about a phase 1 clinical trial of lucitanib, a DYRK1A kinase inhibitor drug, aiming at the correction of cognitive disorders in Down syndrome.
So you have already my first slide expressed, so I'm going to move to the next one. And in a few minutes, I will tell you about this drug candidate. It's a kinase inhibitor. I have been working for 45 years on kinases, so I'm heavily phosphorylated, P32, P33. Protein kinases are extremely worked team. There's one paper every 7 minutes, so it's difficult to sleep. There are 4 Nobel Prizes have been awarded in this field, which is just unusual, and it has become one of the major therapeutic targets in the pharma industry. And it seems to have been working since over 100 kinase inhibitors have reached the market, mostly in cancer, but it's starting to spread in other areas, and that's what we are hoping to contribute to. So among the 538 kinases, there is a subfamily, the dual specificity tyrosine phosphorylation activated kinases, DYRKs, and the one that is of interest to us is DYRK1A here. It's very closely, they are very closely related to one another and closely also to the CLKs. Things are always very complicated when you dig into even a single kinase. There are splice variants, different isoforms, and so on. But there is very strong and very nice genetic evidence showing that the overexpression of DYRK1A is sufficient to trigger cognitive disorders, difficulties to learn and to memorize. And this is shown by in various animal models. This is just a representation of a human chromosome 21 with the DYRK1A gene location. This is in the wild-type mice, you have the equivalent of 2 chromosome 21 with 2 copies of DYRK1A. And if you make transgenic mice which is trisomic only for DYRK1A, just one single copy of DYRK1A, and then you have cognition disorders which you can monitor by various methods. There are dozens of animal models of Down syndrome have been built, more or less complicated, and one of the most complete one was done by Viktor Tibilevich, the DP1 TIB mouse. It has a large section of the chromosome 21 equivalent and as a 3rd copy. Of course, it contains DYRK1A and it has cognition disorders. However, if you, with this, the very same mouse, you keep this trisomy, but you just correct DYRK1A, you correct the cognition disorders. So it's a very nice demonstration. You can either remove the gene or you can make a point mutation so that the kinase is present but kinase inactive. And then you have a full correction of the cognition disorders. I think it's a very nice demonstration. And this is why we selected this kinase a long time ago. It's overexpressed and overactive in Down syndrome because of the 3 copies of the gene. But in Alzheimer's disease, we believe it's overactive not because of overexpression, but due to the truncation by calpains, which leads to a low molecular weight form of DYRK1A, which is more stable and more active. Maybe it's a little more complex than this, but I think this is one of the explanations for the overactivation of DYRK1A. We got interested by this kinase about 20 years ago, and we started to screen a library of 50,000 compounds on this kinase, and we identified a few hits, about a dozen, and we selected this molecule, lucetamine B, which is a natural product made by this marine sponge from the Pacific. I have no idea why it's making this, but it's actually making a lot. A few percent of the weight of the sponge is made of lucetamine B. This is the structure of the molecule. And we started from this hit to make a library of analogs, which we call lecithins. Over 500 were synthesized. We selected one of them, lecithin L41, as a lead product and as to establish the proof of concept with animal models of Down syndrome or Alzheimer's. And we showed that if you treat these animals with the drug, you can have a nice correction of these memory deficits. However, this molecule is not perfect in terms of its pharmacology. The patent was getting a little old, and this is why we moved to a second generation of molecules, of analogs, lucitinibs, for which we synthesized over 670 analogs. We filed different patents more recently, and we selected gradually on a multiparametric basis, shortlist, and then lucetinib 21 as the clinical drug candidate. And we started with the regulatory preclinical studies. Just for the structures, this is lucetamine B, the lecithin L41, and this is the lucetinib 21 drug candidate. You see that we changed these two oxygen for nitrogen and sulfur. And we have this isomer, isolucetinib, where we just invert. I call them south and north, but I'm not a chemist. And this isomer is completely kinase inactive. It's a very nice negative control in biological experiment. And indeed, this molecule, this lucetinib 21 is able to induce or inhibit the endogenous DYRK1A activity in cells, and for example here, this HT22 cells, when they're exposed to increasing concentrations of lucetinib 21, you have a decrease of the kinase activity. If you use the kinase inactive isomer, isolucetinib 21, you have no effect. And the drug is orally available, so this is just pharmacokinetics carried out in rats at different doses, and you have nice uptake of the drug in the plasma rapidly, and it's quite nicely dose dependent. And the lecithins and lucetinibs have been tested to correct cognitive deficits in quite a large number of models of Down syndrome and Alzheimer's. I won't go over this. It's still ongoing. I want to build up proofs from different models, different labs, and we're still building on this gradually, and of course, depending on the budgets. The mechanism of action remains a little bit complicated, and we're working on that. What is important to know is that DYRK1A phosphorylates many substrates which are involved in the Alzheimer's disease and in the central nervous system, where actually it's mostly expressed. So the classical mechanism of action that we can propose, of course, is the fact that DYRK1A phosphorylates APP. It modifies also mRNA splicing for tau, and it phosphorylates threonine 212 on tau. So if you add an inhibitor, you will have an impact on these markers. And actually, plasma threonine 212 has been, as mentioned in one of the questions this morning, it's becoming a very nice plasma marker, very easy, and you can see quite large differences between the control and AD models. I hope this will be extended in DS and in AD with DS as well. So and of course, in CS, it's even better. We believe that actually the DRCONA phosphorylates threonine 212. It does not phosphorylate 217. However, we think that the low molecular weight form is able to phosphorylate both sites. So we're exploring this. I think it's kind of interesting to see the effect of this truncation on the specificity of the kinase. Another mechanism of action that we are proposing and studying is that DRCONA has many of its substrates are synaptic proteins. DRCONA is located at the pre- and post-synaptic sites. And by phosphorylating different substrates at this level, it certainly influences synaptogenesis, the plasticity, and the stability and the turnover of synapses. And this ends up in the neural connectivity difficulties or changes, which we are starting to monitor with MRI. And one last possibility that we're also exploring is the fact that DRCONA inhibitors have a strange effect on pancreatic beta cells. They induce the proliferation, to some extent, of beta cells, so they increase insulin production. And so maybe this is actually a very big black box, but maybe it has an effect on the brain insulin receptors and glycemia in the brain. Having chosen this drug candidate, we first had a non-GMP batch synthesized, 1 kilogram. This is the chemist who synthesized the 670 molecules. He's very happy. Of course, it's not every day that you hold 520,000 euros worth of stuff in your hands. So that's one of the reasons, probably. So we used this material to do the regulatory preclinical studies. We selected rats and mini pigs to define the non-adverse event level, 20 mg for the rats, 100 mg for the mini pigs. I should mention that in the animal models of Down syndrome and Alzheimer's, the drug is efficient around 0.3 to 0.5 mg per kilo. So we have a large window. Next, we had the drug formulated as oral dispersible or immediate release tablets, 60 mg. They're really small, actually. We designed them for children because we want to go in the phase 2 with children from 6 to 12. It's not entirely defined. So this is the formulation that was selected. Although I think this would be a better formulation for kids, probably less expensive. And so we started in January a phase 1 study with the cetinib. It's, of course, placebo-controlled, double-blind. It's a single site. We're specialized in the first-in-men trials of new drugs. So it's classical single ascending dose and food effect study, multiple ascending dose. And so that's 96 healthy volunteers, to whom we would like to add, or we're adding, a small cohort of adult with Down syndrome, 12 adults with Down syndrome, 12 patients with mild cognitive impairment, and I think probably another small cohort of people with Parkinson's disease. So they will receive the drug only once. The idea is to measure the pharmacokinetics of the drug and see if it's similar, identical, or very different from that seen in the healthy volunteers. So in total, it's 1,700 plasma samples, and we're in all the samples, in all the patients, we'll collect plasma to look at biomarkers, especially phosphoproteomic profiles. With the plasma samples, we can identify about 8,000 proteins and 6,000 phosphosites. That's a lot of data. And also, we look at the various plasma AD biomarkers. And in parallel to this phase 1 clinical trial, we are running an ancillary study with 30 trisomic kids and 30 disomic kids. So we're just collecting one blood sample and looking at the very same plasma phosphoproteomic profile and various AD biomarkers like threonine 212 and 217 and so on. So this is half of a picture. Actually, it's the very beginning of the PK. Maybe we started a bit low, so there was not very much at the first dose, 5 mg, but at 10 mg we're starting to see the beginning of a peak. But already we're reaching the concentration above the IC50 of the drug on DIRC1A, and we're still going to fill in with much higher doses. The nice, interesting thing about DIRC1A is it seems to be involved in many indications or areas. We're focusing, of course, on Down syndrome and Alzheimer's, but we have a strong interest in Parkinson's disease, some diabetes. There's some people working on otitis. In mice with trisomic mice develop very frequent otitis, and when DIRC1A is corrected, these otitis do not appear. So it's almost entirely dependent on DIRC1A overexpression. There's some people and companies working on arthritis, and we're interested also by myocardial infarction and maybe some cancers. So the 2 last points. The first one is lucitinib and isoleucitinib are available freely. If you want to use it as research reagents, just send me an email. There's no strings attached. I will just send you the product, and I hope you will tell me what happens. And then the second point is that if you want to become a legal drug dealer, please join, and you can participate to the fundraising, that campaign that we're starting with a crowdfunding company, which is located in Barcelona, actually, Capital Cell, and will be soon open. So if you want, please welcome and deal with drugs with me. And just I want to finish with the logo of our company is based on the baptismal fonts from the 12th century, which is slightly modified, and our slogan, "From seed to pharmacy," because of the molecule originating from a natural product. And I guess this is it. Well, we have a small team, but we have many collaborators. We work with CROs, usually very good and always very expensive. And we have lots of nice collaborators, lots of financial support, and some business angels. This is probably what you need for phase 1 or phase 2. And this is it, I guess. One last point. This is where Roscoff is located. But I want to thank you, Raquel and Juan, for this putting this very nice meeting together. And you see, Barcelona is not very far. If you want to run the next conference in Roscoff, I will help you to set it up. And this is my lab space. Thank you very much.
Thank you. Thank you, Laurent. Our next speaker is María Carmona-Iragui, a phase 3 randomized double-blind study of the efficacy and safety of levetiracetam to prevent seizures in symptomatic Alzheimer's disease in adults with Down syndrome. Maria.
So hello everyone. It's a great pleasure to be here. I'm honored to be part of this wonderful meeting with such a nice co-speakers in the table and such a high-level audience. So it's challenging to be here presenting a clinical trial, an academic clinical trial that we will try to develop in the following years in the unit. Well, Down syndrome is the main cause of genetic origin of intellectual disability, and it's a genetically determined form of Alzheimer's disease, and that's why we are all here today. And well, the diagnostic criteria already recognize this. And every adult with Down syndrome by the age of 40, they have the neuropathological hallmarks of Alzheimer's disease in their brains. And however, the clinical symptoms of the disease the prevalence of the symptoms start increasing from that age, exponentially increasing in prevalence and reaching more than the 90% in those older than 60 years old. And although with the maternal screening of Down syndrome, at the beginning it was thought that maybe the population of people with Down syndrome will decrease. In fact, it's increasing, maybe due to the maternal age, or mainly due to the improvement in the healthcare that people with Down syndrome are receiving now. And it's estimated that there are 6 million people with Down syndrome worldwide, and 1/3 of them, so around 2 million of them, are older than 40 years old. And we need to so far, at least in Europe, we don't have any treatment that is useful or can modify the course of Alzheimer's disease, so we have to identify new, well, not new, but other pathophysiological processes or other comorbidities that play a role on Alzheimer's disease, and have different approaches. For example, epilepsy and epileptiform activity. So the association in the general population between Alzheimer's disease and epilepsy is bidirectional. It's estimated that the diagnosis of dementia increases threefold the risk of developing epilepsy, and a diagnosis of epilepsy increases twice the risk of developing other forms of dementia or Alzheimer's disease. And epidemiological studies have described that between 10 to 22% of patients with sporadic AD have seizures, but this number increases and up to the 64% in cohorts that have been closely monitored, and of those, the seizures will become recurrent, so those patients will develop epilepsy. The type of seizures in people with sporadic Alzheimer's disease are mainly non-motor complex partial seizures, which can be sometimes difficult to differentiate from other symptoms of Alzheimer's disease, such as behavioral fluctuations or transient impairments of memory. And also they can present with myoclonus that have been found between the 7 to 10% of people with Alzheimer's disease, but in advanced stages of the disease can affect up to the 80%. Seizures occur at the beginning. It was thought that seizures could occur at later stages of the disease, but now we know that although they are more frequent with the disease duration, they also can occur in early stages, and they can hasten cognitive decline, and both myoclonus and other kind of seizures can reduce survival. And patients with Alzheimer's disease and seizures have a greater cognitive impairment, a faster progression of symptoms, and more severe neuronal loss at autopsy. And the EEG is a way to study the cortical hyperexcitability and the brain rhythms. If there's cortical hyperexcitability, we can have epileptiform activity that can manifest clinically or only be detectable by the EEG. And both of them, the clinical and subclinical epileptiform activity, can affect the cognition and the course of the disease. The most common finding on the EEG in patients with Alzheimer's disease are non-epileptiform abnormalities, such as a theta or delta slowing of the register, but also epileptiform activity is frequently found. Acutely, it can impair cognition, and chronically, it has been implicated in the pathogenesis of synaptic and cognitive impairment. So clinical epileptiform activity, which is the epileptiform discharges in patients without known clinical seizures, is variable in patients with AD. It has been described up to the 54% of them, and it increases 4 times. It is more frequently 4 times more frequently found in patients with Alzheimer's disease than in healthy controls. And of note, the 90% of this subclinical epileptiform activity is found during sleep. And also, over the years, this subclinical epileptiform activity has been associated to cognitive decline. Also, we can find interictal activity, which is the epileptiform discharges that are found between seizures. And this kind of activity is found in 80% of patients with Alzheimer's disease and seizures. And also, I wanted to mention the high-frequency oscillations. Usually, the frequency of the EEG recording falls below the frequency of 30 Hz, but there are HFO, high-frequency oscillations, which are fast ripples that fall beyond the frequency of 250, 500 Hz, and have been described at the beginning of the epileptic seizures. And in mouse models, they have also been found in a model of Down syndrome. So this biomarker, although needs further investigation, can be a new biomarker that might offer new information. And all of this information derived from the EEG probably is underestimated because of the limitations of the EEG, the scalp registration of the cortical activity. So we need longitudinal studies and other kind of, or also sleep studies, and other kind of techniques or approaches that help us to better describe the cortical hyperexcitability. And what happens in Down syndrome? My colleague Lucia very nicely presented some sessions ago that the seizures in Down syndrome have a bimodal distribution. The first peak is before the first years of age, and the second peak is over 40 years of age. And this second peak is closely linked to symptomatic Alzheimer's disease. In fact, the presentation of a clinical of a seizure in a person with Down syndrome from 45 years old is highly indicative of symptomatic Alzheimer's disease. And I want to briefly go through this nice paper published by Professor Stridham Group that described the comorbidities of people with Down syndrome across the lifespan in Down syndrome, in healthy controls, and in other intellectual disability. And they found that, of course, the main one was dementia with an incidence rate ratio of almost 95. And the third one, after hypothyroidism, was epilepsy or seizures. It has an incidence rate ratio of almost 10. And when we look into the incidence rate groupings and how they appear along lifespan, we can see in those graphs that they are closely linked. So epileptic seizures are more frequent in people with Down syndrome and Alzheimer's disease, much more frequent than in sporadic disease, and more even than in Alzheimer's, autosomal dominant Alzheimer's disease. And the characteristics of the features of this epilepsy in people with Down syndrome has led to a new syndrome named late onset myoclonic epilepsy associated to Down syndrome, the LOMEDS, with the LOMEDS term, that has been defined because it courses with two specific kind of seizures, which are myoclonus and bilateral tonic-clonic seizures. And the clinical course is similar to other progressive myoclonic epilepsies. At the end, or in with the progression of the disease, the myoclonus become resistant to treatment, and also there can be also tremor or cerebellar ataxia. And also they present with the bilateral tonic-clonic seizures. The correlate on EEG is inconstant at advanced stages of the disease. We don't find a correlation on EEG, meaning that the myoclonus could be of subcortical origin. LOMETS is associated with a faster cognitive and functional decline and a shorter survival of the patients. And it's an independent risk factor for hospital admissions and mortality. And the treatments that have more frequently used are valproate and levetiracetam that are effective in 80% of the patients. Only to mention this review that was published last year, who reviewed the cases of 46 patients with Down syndrome, and they describe mainly what I have told you. This is a paper published in Seizure, including 46 patients. So also, status epilepticus is the status epilepticus is, as you all know, is a seizure that lasts more than 5 minutes. That can be clinical seizure or electrographic seizure, or different seizures that occur without recovering between them. So it's a life-threatening condition, and it's important to detect it and treat it as soon as possible. So LOMETS can also occur with status epilepticus, although we will see it's not super frequent. This paper describes one patient and reviewed the literature and found 4 other more cases that presented with status epilepticus. The mean age at onset was 42 years. The 3 of them, they had a previous diagnosis of LOMETS, and it was a myoclonic status in 3 of them. Here we can see a piece of the EEG recording, in where we see some sharp spikes and waves diffuse, and also a slow in the rhythm in the background rhythm. So Lucia already explained the work that we are going to develop now about an observational study, the characterization of the epilepsy related findings in our cohort, and I will only dedicate this slide to that. We studied, or we included the data from 906 patients, and we can see that in our cohort we also see the bimodal peak of presentation of the epilepsy in Down syndrome. We can see that the prevalence of the seizures increased by AD stage, and also we can see that the prevalence of seizures increased significantly after the diagnosis of dementia. And also that, as expected, the most frequent type of seizures are bilateral tonic-clonic and myoclonic seizures. So the close relationship between Down syndrome and Alzheimer's disease, epilepsy, and cortical hyperexcitability lead to new therapeutic approaches. And anti-seizure medication can stabilize neuronal network and could be an approach for the treatment of Alzheimer's disease. All medications, such as phenobarbital or phenytoin, have different adverse effects, and also can affect cognition, so won't be a good option. But levetiracetam, which is a widely used anti-seizure drug, has been demonstrated to suppress epileptiform spikes and improve synaptic and cognitive function in mouse models. The main molecular mechanism of levetiracetam is that it binds the SV2A, the synaptic vesicle 2A, which function is still unknown, but it seems to stabilize the the synaptic vesicle. So levetiracetam enhances the GABA release in inhibitory synapses and downregulates the glutamate activity in excitatory synapses. Also, it can inhibit the N-type calcium channel. And what happens in the clinics? So this nice study published 3 years ago aimed to determine if the administration of levetiracetam in patients with Alzheimer's disease could improve cognition. So although the main results were negative, they didn't find an effect of levetiracetam on cognition in patients with sporadic Alzheimer's disease. They found that in those who at baseline presented epileptiform discharges, during the trial, those who received levetiracetam improved the spatial memory and the executive function. And also the drug was well tolerated and did not report any particular adverse effect. So in the last years we have been working on that, and finally we designed a phase 3 randomized double-blinded study of the efficacy and safety of levetiracetam to prevent seizures in symptomatic Alzheimer's disease in adults with Down syndrome, with the hypothesis that levetiracetam is safe and can prevent seizures in adults with Down syndrome and Alzheimer's disease, and secondarily it could delay the progression of neuronal damage in people with Down syndrome. So the primary objectives was the safety objectives, the safety objective, well, that it's well tolerated and safe, and the efficacy objective was the prevention of bilateral tonic-clonic epileptic seizures at 24 months of follow-up. The secondary objectives include to quantify the time to first bilateral tonic-clonic epileptic seizure, to evaluate the incidence of all-cause mortality and compare it between groups, and to study the potential changes from baseline on Alzheimer's disease biomarkers regarding functionality assessed by the CAMDEX, cognition assessed by the CAM-COG-DS and the modified Cure recall test, plasma biomarkers, brain structure, and epileptiform activity and power spectrum measures recorded by EEG. So we plan to include 120 participants with very general inclusion criteria. Mainly we will include adults with Down syndrome older than 18 years of age with mild or moderate intellectual disability, so they can undergo the neuropsychological assessment, and with the diagnosis of symptomatic Alzheimer's disease, both in the prodromal or in the dementia phase. The rest of the criteria are more or less the same as in other trials, and the exclusion criteria are cognitive changes that are due to other causes or severe or profound intellectual disability. A previous history of an epileptic seizure over 18 years of age would also be an exclusion criteria, and they can't be under other anti-epileptic drugs. So this is the schedule or the procedures that the participants would undergo. It's there are 3 main visits: the screening one, the 1-year visit, and the 2 years visit. And in between, there will be some other small visits, some of them by phone, to assess mainly safety. And we will do the clinical and neuropsychological assessment at the 3 time points, and also an MRI, plasma biomarkers, and EEG at the beginning and at the end of the study. We applied to a grant from the Spanish Ministry of Health, and we proposed to do this trial as a multi-center trial in collaboration with Diego Real de Asúa in Madrid, Eloy Rodríguez in Santander, Miren Altuna in Fundación Cita Alzheimer, and Joaquín Escobar in Granada. And fortunately, we got the grant last year, so now we are with all the paperwork trying to start to have the approvals and hopefully start the recruitment. And although our funding is only for the Spanish part, it would be very nice to have an increased sample size and well, to have more recruitment also from other countries, from other places, and if we could ensure a nice sample size, we could even think about maybe adding a third branch with some other anti-epileptic drug who might be even better than levetiracetam if it works. So thank you very much for your attention. Thank you, of course, to all the participants that agree to participate in our studies. Thank you for all the wonderful team that I'm lucky to work with, especially with Juan, whose perseverance and good ideas encourages our motivation every day, the funding agencies and the institutions. Thank you.
Thank you, Maria. Our next speaker is Beatrice Bosch, who's going to talk about autosomal dominant Alzheimer's disease, Barcelona cohort.
Very nice.
First of all, hello everyone. Thank you for this opportunity, and it's a pleasure to be here today. The Genetic Information and Counseling Program for Familial Dementia, the PICOGEN program, promotes diagnosis, genetic counseling, and research into hereditary forms of Alzheimer's disease. And ADAD provides a unique opportunity to investigate pathophysiological processes preceding symptoms onset. The ADAD provides, the ADAD Barcelona cohort of the Hospital Clinic of Barcelona aims to characterize clinically and biologically a group of individuals with symptomatic and asymptomatic ADAD, study particularities of ADAD in contrast with aging-related dementias, identify prognostic markers and determinants of the severity of the biological activity, as well as explore new therapeutic targets. The objectives of this talk are to provide an overview of the cohort, focusing on its purposes, participants, and significance in ADAD research, detail the various procedures involved in ADAD Barcelona cohort, and highlight some of the key findings and insights obtained from the ADAD Barcelona cohort over these 2 decades' existence. By addressing these objectives, the talk aims to provide a comprehensive understanding for the AD Barcelona cohort and its contribution to the Alzheimer's disease research. All symptomatic and asymptomatic mutation carriers visited within the PICOGEN program are invited for research participation, and participants enrolled in the PICOGEN observational study have baseline and optional follow-up visits every 2 years with cognitive and biomarkers assessments. Assessments include comprehensive evaluations as clinical assessment, neuropsychological battery, blood biomarkers, genetic testing, MRI, and as optional, CSF and amyloid PET imaging. Some of these patients have been recruited from the DIAN-TU pharmacological clinical trial, and DIAN-TU tests the safety and effectiveness of several experimental drugs, starting with gantenerumab, solanezumab, and atavestat, and currently they are testing E2814 tau therapy combined with open-label lecanemab treatment for all patients. Other branches of treatment are expected to be started to test new drugs in the near future. Moving to the results, PicoGen program evaluated a total of 84 mutation carriers from 50 families harboring 31% one mutation, 1% two mutations, and 6 APP mutations and duplications. And as Raquel shows you before, PicoGen observational study recruited a total of 61 participants, 20 asymptomatic mutation carriers, 19 symptomatics, and 22 non-carriers familial controls. The age of the symptomatic subject was higher than the age of the asymptomatic and control subjects. The estimated years to onset of the symptomatic subjects has lower than the estimated years of onset of the asymptomatic patients, and no statistical differences were found in sex. As expected, the hippocampal volume of the symptomatic subjects was lower than the hippocampal volume of the symptomatics and control subjects, and no statistical differences were found in the entorhinal cortical thickness. In line with expectations, the CSF markers were altered in symptomatic patients. And regarding the clinical trials, since 2014, 33 AD patients, 23 symptomatic mutation carriers, and 10 asymptomatic mutation carriers were enrolled in the DIAN-TU clinical trial. 8 additional symptomatic mutation carriers excluded due to an advanced disease stage, and 2 asymptomatic mutation carriers were recruited in the DIAN observational study. The trial that we joined since 2019. If we divide these numbers for each study, 10 subjects were included in the gantenerumab and solanezumab arms. Of the patients recruited were 5 symptomatic mutation carriers or 3 asymptomatic mutation carriers, 2 screening failures but due to MRI at the screening, and 6 participants were treated with gantenerumab and 2 with solanezumab. Only 3 of these subjects were able to participate in the DIAN open level. We recruited 8 patients more on atavesostat, but it was discontinued prematurely. And subsequently, 10 patients were included in the DIAN cognitive running. Currently, 10 patients recruited in the DIAN E2814, and 8 of them are still active. Just telling that of the 10 patients that we're recruiting now in the tau therapy, 4 were recruited previously from cognitive running and 1 in the atavesostat study. And finally, just highlight Fortea and calls from our side in 2010 found increased cortical thickness and caudate volume proceed atrophy in presenilin-1 mutation carriers. Sánchez-Valle in 2015 found white matter abnormalities track disease progression in presenilin-1 AD. And the same author in 2018 found serum neurofilaments correlates with severity measures and neurodegeneration markers in AD. And Ramos Campoy et al. 2022 found that lymphoblastoid cell lines might be appropriate for studying early immune system and inflammatory and some neural features in neurodegeneration dementias. As a conclusion, the AD Barcelona cohort represents a valuable platform for understanding the biological basis of AD continuum and developing new treatment strategies. The AD Barcelona cohort allows us to continue including and analyzing this data longitudinally, as has been presented in the conference with the Dr. Sánchez-Valle, Agnès Pérez-Millán, and Aina Comas, and collaboration with different studies and trials amazes our knowledge and approach to AD. In summary, the AD Barcelona cohort remains a pivotal resource for advancing our understanding of Alzheimer's disease, offering valuable insights into its pathophysiology, progression, and potential treatments. Thank you for your attention, and thank you for all team, and especially for the families who participate in this study.
Thank you. Our final speaker needs no introduction, Professor Andre Strijdom, who will be talking about the Horizon 21 network.
Thank you. Thanks, Mike, and thanks for the invitation as well. These kind of meetings are always great to share ideas. And it was indeed at a meeting like this, a one-off meeting that we organized some years ago with the support of the Balcom Trust at Cambridge, that we realized, many of us, or several of us in the audience here, realized that there are enormous missed opportunities for, particularly with regards to Alzheimer's disease and Alzheimer's disease treatment trials in Down syndrome. I mean, it's a large population with a clear rationale for amyloid targeting drugs in particular. But the population at that stage was overlooked, and it's great to see that it's quite a different landscape now. But at that time, we wrote a position paper to set out the opportunity, but also to highlight some of the challenges to conducting Alzheimer's disease trials on Down syndrome, which included needing a better understanding of the early stages of Alzheimer's disease, to define the age range for prevention trials, to have better outcome measures, and to have cohorts in many of the countries. And we also realized that it would require international efforts. So that gave rise to the Horizon 21 consortium, which we tried to put together in order to enable collaboration across Europe with harmonized procedures, translation of tools, etc., to establish cohorts in countries which did not yet have Down syndrome cohorts, and to ultimately enable clinical trials for potential treatments for Alzheimer's disease by designing better outcome measures and getting data on those as well as biomarker data. So we started out as 6 countries and 6 sites, but it's grown since to, I think, about 13 sites now. Soon the 13th site will join across a number of countries, I think more than 9 countries now across Europe. So one of our first efforts have been to collate existing data, legacy data, from different groups, longitudinal legacy data, and to use that to better understand differences in mean age of diagnosis. And there's always the question that we asked, is how reliable are the diagnoses of dementia in people with Down syndrome? And is it the same across different countries, different clinical systems? And so what we found was that the mean age of diagnosis is fairly consistent, ranging from 52 to 55 years, so suggesting that there isn't a huge difference in terms of clinical application of diagnostic criteria. However, the presence of certain co-occurring conditions, particularly mental health concerns, obstructive sleep apnea, and also the number of co-occurring conditions were associated with an earlier diagnosis, even when we adjusted for APOE status. And furthermore, we could see that rates of co-occurring conditions varied enormously between the countries, suggesting that surveillance for some of these conditions are inadequate, and it differed in terms of which co-occurring conditions were better diagnosed in different countries as well. So that suggests that there's an opportunity as well to target more definable conditions, which I'll mention a little bit more of later. And later on, at the same time, we collaborated with Jason Hassenstab's group to try and see across different cohorts, including some US cohorts here, to see whether we can identify the most sensitive cognitive potential cognitive outcome measures, and use that data to suggest a composite And so we looked at different cognitive domains, and even though people were doing applying different tests, we were able to compare by domain and identify a sort of ideal composite, which we could use to track cognitive change in people with Down syndrome before dementia diagnosis, so in the earlier stages. And that's what we came up with. It's very similar to what you would expect, I suppose, in sporadic Alzheimer's disease, except perhaps with the prominence of language and executive functioning, which seems to be something that comes up a bit earlier in people with Down syndrome. And so we used that information to redesign a cognitive outcome measure that was already in use in many clinics in Europe, the CAMCOG. You've heard about it here at this meeting. And in particular, we wanted it to be easily translated, so less focus on language, less culturally specific as well. Originally, it was designed in the UK. It was quite British in some ways. And to minimize floor and ceiling effects and make it quite easy to administer. And so it's more inclusive. So we can include the broadest range of ability levels of people with Down syndrome. And so we also incorporated some of the optimal elements from the Aschenbrenner paper and tried to improve scoring for some subtests. I think Bessie Beneham in the session later this afternoon will talk about this in a bit more detail, how we went about that. And then we set about designing a cohort study which had one of the aims to validate the CAMCOG DS2, which is now running in 12 sites in 9 countries across Europe, with a few others joining soon. It was quite an effort to get all the consortium agreements and MTAs, DTAs set up. It's really challenging working across different countries, but we managed, despite the challenges of COVID as well, and have now recruited more than 220 people in the adult age range, but making sure that we have enough people in the the 35 group so that we can track change with aging as well, doing annual assessments, and we're doing the second year follow-up at the moment. And so I will present some of the basic demographic details and some high-level findings from the CAMCOG DS quickly. So first of all, as you can see, here are some of the initial countries participating in the study. I think the standout thing to note is that some groups vary in terms of the inclusion of people with moderate to severe intellectual disability. And what we want is to be representative of the full range of people with Down syndrome, regardless of ability ultimately, for, to make any sort of trials representative in the future. And so I think it's important to consider that there might be a bias in the literature sometimes at the moment because of the nature of procedures and things that people need to have. There's probably a bias towards people with mild learning disability, which we need to keep in mind. But nonetheless, here we can see that the CAMCOG scores very nicely pick up the age-related decline in people with Down syndrome, regardless of dementia status. There's a huge drop-off in cognitive ability in people with Down syndrome as they get older, driven by Alzheimer's disease pathology, even before people have a diagnosis. And so it quite nicely picks that up. We can also see a significant effect, which we expected, of, so these are density plots, on scores of intellectual disability level. So you can see quite how different it is. People with severe, moderate to sort of mild, moderate, and severe learning disability or intellectual disability. And I think this shows why it's so challenging to develop threshold scores at cross-sectional administration for any cognitive measure in people with Down syndrome. Personally, I think it's probably impossible. And I think we need to use scores longitudinally to track change against the person's own baseline. Otherwise, it's really quite difficult. And just as a contrast, just to show what the density plots look like for computerized tests, a memory test called Cantab-PAL. Again, differences, and in particular, potentially a floor effect in people with severe learning disability, and similarly, also a similar sort of pattern in the MCRT, where there might also be flooring effects, I think, which was presented by others at other conferences. So it's just to highlight some of these issues with some of the cognitive measures and why we need to make an effort to be very inclusive and design our tools so that we can apply it also in people with more severe difficulties. Because as people develop dementia, of course, doing these assessments get more and more difficult, and therefore we do need tests that can be administered to a range of ability levels. The good news is that CAMCOG DS does pick up significant differences when we look at those with and without dementia diagnosis. So the difference in scores is about 25 to 30. The top score of the CAMCOG is just over 100. So it's quite a significant difference between the two patient groups. So I've just presented some very high-level data. The next steps that we are making or doing is to also get better data on clinical meaningfulness of CAMCOG DS, and in particular, we would like to develop minimally clinically important difference scores. I think that's an issue also in sporadic Alzheimer's disease research, and for the data on the MABs at the moment, the question is still whether how clinically meaningful that is, and we want to anticipate that issue by developing anchor-based as well as distribution-based MCIDs. And we have other ongoing work, so the longitudinal assessments will be completed later this year, which will then allow for longitudinal assessment of biomarkers against the cognitive measures that we've been doing. We, as part of the CAMDEX suite of tests or tools, we have revised the CAMDEX questionnaire, which is a diagnostic tool based on symptom reports by caregivers, and that's perhaps where we can develop diagnostic thresholds. So we're going to look into that. There is some work around genetic aspects, sleep that you heard yesterday. We're thinking about the MRI feasibility and support with the group with Johannes Levin in Munich, leading on that work. And ultimately, we would like, as a big next effort, to design a trial to target some of the modifiable factors for Alzheimer's disease and Down syndrome. So by adapting the finger approach to people with Down syndrome called Finger DS. And are making progress with that as well. And finally, supporting industry-sponsored trials. We have a community engagement program developing BPIE groups funded by JP&D. And already there's a wonderful video. I was hoping to show it today, but I'm always anxious about technology around videos and presentations, and in the interest of time as well. But please do have a look at the videos. People with Down syndrome themselves talking about how important it is for Alzheimer's disease to be tackled. And thank you, that's all the acknowledgements as well, and special thanks to our funder.
Thank you, Andre. We have about 5 minutes for questions, if there are any.
Great, thank you. So my question revolves around levetiracetam and clinical trials. I was wondering if you were considering using levetiracetam potentially in a secondary prevention trial. So it seems to me the prevalence of this epileptiform activity is so high in Down syndrome that it seems to be a very nice population to potentially test the hypothesis that suppressing that activity, whether it leads to seizures or not, would actually be disease modifying in this population, maybe starting around the age of 40 or somewhere between 40 and 50 before they actually start to develop cognitive symptoms. I just wonder if you and the panel maybe could comment on that.
Yeah, thank you for your question. Do you mean secondary prevention for seizures or epileptic form activity?
I actually mean for cognitive decline. So suppressing, looking at the very hard outcome of whether levetiracetam suppresses the epileptic form activity, but whether that actually leads to improved outcomes cognitively for people with Down syndrome.
Yeah, in fact it's for secondary prevention, as people will also have symptomatic Alzheimer's disease. They don't have a history of epileptic seizures, but they do have the diagnosis of Alzheimer's disease. So we give them levetiracetam or placebo, and we see if levetiracetam prevents from the development of bilateral tonic-clonic seizure, and secondarily, if the treated group has changes in cognition, functionality, biomarkers, EEG.
All of these patients will already have cognitive impairment, though, at the time you start. Now, I was wondering if you're going to think about starting earlier than that.
Yeah, it would be another approach to select those independently of their cognitive status, but those who have epileptic form activity, right? Yeah, it will be also another approach. Very interesting.
So just to add to that, I mean, I think, there's a rationale for trying that. But one would have to balance that as well with the risk of issues, side effects, and so on in a essentially healthy population or in people who don't yet have
very
dementia.
low, I would say, with levetiracetam. It's very well-tolerated medication. But in the Down syndrome, may be different because of the behavioral changes.
I'm thinking of, I'm a psychiatrist, and we often see behavioral issues associated with levetiracetam. But otherwise, it's fairly well tolerated, you're right. So it's just a balance that one would need to think about carefully if we were to take that kind of approach, but it might be worth. I mean, are you thinking that there might be additional cognitively supportive kind of effects of levetiracetam?
Right. I mean, just in its relationship to suppressing abnormal network activity.
Right.
Yeah.
Time for one last question. Everyone's hungry for lunch. Oh, Shahid.
Yeah, just a question about the drug. It must be really difficult designing a drug that's going to be specific and going to, especially when there's so many targets. How do you address that issue?
It's just impossible, actually. But you're right. All the kinase inhibitors, they have other targets, closely related kinases. And probably that's how they work, because they hit a small subset of kinases and not just a single one. And the only thing I can say is that the 100 kinase inhibitors which are on the market, none of them is selective just for a single kinase. So.
And is there a way around it, such as frequent dosing or some other ways?
There are some targets that you want to avoid, which are known, but there's no, unfortunately, there's no other methods.
Okay, with that, we're going to head to the group photo and then lunch. Thank you all very much.
Hola, sí? Hola? M'escolteu? Sorry?
Hola.
Hi, Angela, Erika, and Laurie. How are you?
How are you doing?
It's
good.
just we are testing the microphones because in last session we have a little problem with the microphone of a speaker, and it's just testing that we can hear you.
All right, we're going to go ahead and get started. Welcome back from lunch and the sunshine, but we have what I think will be a really interesting set of discussions in the next panel. And we are going to dive right into session 8, which is collaboration and networking opportunities for Alzheimer's research in individuals with Down syndrome and autosomal dominant Alzheimer's disease. So I'm Heather Snyder.
And Sebastián Videla.
And we'll be the moderators for this next session. And to help kick us off, we're going to have a video recording by Drs. Lori Ryan and Erica Tarver on NIH funding opportunities. And we are happy that they are here and will be with us for the discussion part. So let's go ahead and watch the recording.
You are ready. Hi, everyone. On behalf of myself and my colleague, Erica Tarver, we are very happy to talk to you today about the NIH Include project, which stands for Investigation of Co-occurring Conditions Across the Lifespan to Understand Down Syndrome. We are very sorry, though, that we were not able to be with you in person. So the Include project launched in June 2018 to address a U.S. congressional directive that called for a new NIH-wide research initiative on critical health and quality of life needs for individuals with Down syndrome. The focus is to investigate conditions that affect individuals with Down syndrome and the general population, such as, but not limited to, Alzheimer's disease, autism, cataracts, celiac disease, congenital heart disease, and diabetes. The focus is also to increase the number of investigators and trainees studying Down syndrome, as well as engaging with those with Down syndrome and their families from diverse backgrounds. This slide shows the Include project funding at a glance. So we have funded to date 330 projects. There have been 50 funding opportunities released, and that has involved 18 of the 27 institutes and centers from the NIH. 13 of those have been clinical trials. There's been 1 data coordination center funded, nearly 250 publications from Include data, and 13 Include hosted community engagement and outreach events. This slide shows what the funding has looked like from 2018 up to 2023. And you can see we started with about 60 million in Down syndrome funding in 2018, going up to about 130 million in 2023. The NIH has invested $348 million over the last 6 years for the Include project. So the Include project is divided into 3 components. Component 1 is focused on targeted, high-risk, high-reward basic science studies on chromosome 21. Component 2 is focused on building a large cohort of individuals with Down syndrome, and that is involving multiple studies, not a single cohort, but putting together multiple studies for comprehensive analyses and biomarker evaluation. And finally, and importantly, supporting clinical trials in individuals with Down syndrome. The awards to date, the majority have gone to support basic and translational research studies. However, the number of cohort studies and clinical trials supported by Include have increased every year. All right, and now I'm going to turn it over to my colleague, Erica Tarver, for the next slides.
Thank you so much, Lori. I appreciate it. So as Lori mentioned previously, one of the outputs from Include project has been the funding of the Include Data Coordinating Center, or as we refer to it as the DCC. The Include DCC really is an online resource that enables discovery. It has collaborative resources, and it allows researchers and the public to do data integration and mine data through open science practices. The Include DCC also supports an online data hub, and that data hub houses more than 74 terabytes of data from 65 harmonized clinical profiles, whole genome information, as well as other omics data. We do encourage the larger research community to not only utilize the DCC and the data hub for mining data, but also as an opportunity to perhaps post their data there. Although not funded through Include Project, but a major resource to support the Include Project is the DS Connect, or the Down Syndrome Registry. The DS Connect was launched in 2013, and to date, it has supported more than 5,900 registrants globally. It's a secure, online, and confidential research tool that collects basic information from individuals and families with individuals with Down syndrome. This online registry is utilized by more than 600 medical and science professionals, and it has led to the participant engagement and enrollment in more than 100 projects. This is an online tool that we continue to use as part of Include, and also we encourage you all to share this resource with your communities. A major aspect and interest to NIH and Include is ensuring that we engage with diverse populations that have been historically underrepresented in biomedical research. And so this is just highlighting some of our diversity, equity, inclusion, and accessibility efforts by Include. Please note it is not an exhaustive list, but it is really just to highlight our efforts to build trust and establish positive relationships between researchers and the Down syndrome community. And I would like to take a moment to just note that we are having several webinars on DEIA within the Down syndrome community and populations. And the next one is scheduled for May 30th, 2024. Information about this is on our Include website. So previously, Lori mentioned also that Include has resulted in more than 50 funding opportunity announcements. This is just a current listing of that. We do encourage those to go to our Include website to find out information about the specifics for each of these funding opportunities. And also, if you have questions, please go to the website and to the specific funding opportunities for a listing of the NIH contacts. We strongly encourage you to reach out to our NIH program staff prior to submitting an application. And with that, we'd like to say thank you. And if you have any questions or for more information, please visit the NIH Include project website, and here is a link to that. Thank you again for the opportunity to present.
Thank you.
May we carry on with the second speaker? The second speaker is Angela Bradshaw, who talks about the collaborative engagement with patients' organizations in UA-funded research. This one is one of the pre-recorded talks.
Hi, everyone. I'd like to start by thanking the conference organizers for the opportunity to participate in this fantastic meeting, which has collaboration at its heart. My name's Angie. I'm the Director for Research at Alzheimer Europe, and today I'm going to share some examples of collaborative engagement with patients, carers, and the organizations that represent them in EU-funded research projects. So I will start by giving you a quick introduction to Alzheimer Europe. So Alzheimer Europe is the umbrella organization of 41 national Alzheimer's associations across 37 countries in Europe. We're based in Luxembourg, and that's where I'm talking to you from today. You can see the country as a little blue dot on the map. And our members are indicated in green. So you can see the 41 associations from 37 countries marked there. The mission of Alzheimer Europe is to change policy, perceptions, and practice to improve the lives of people with dementia. Our core goals are listed on the slide, and they are to provide a voice to people with dementia and their carers, to work with national and EU policymakers to make dementia a European priority, to change perceptions and combat stigma, which can blight the daily lives of people who are affected by dementia, raise awareness of brain health and the importance and potential for dementia prevention, strengthen the European dementia movement through capacity building and collaborative actions, and to support dementia research. And today I'm going to mainly focus on the final part of our mission, supporting dementia research. However, I hope you'll see in the coming slides and presentation that our approach to supporting dementia research is very much integrated with and adds value to all the other elements of our work. So I've been following the conference online, and I was really struck by the opening speech from Katy Trias, who's the CEO of the Catalan Down Syndrome Foundation. And I'm just going to read a few of the words from her opening speech. She said that behind each data point and research objective lies a person with unique experiences and needs. We must remain grounded in their reality. Let us not lose sight of the humanity at the core of our research, ensuring that our efforts uphold the dignity and well-being of those we seek to help. So close collaboration with stakeholders has established itself as a key practice in research and innovation. Studies have shown that it increases relevance, acceptability, and credibility of outcomes, and ultimately leads to more effective and sustainable solutions. In health research projects, patients, caregivers, and patient organizations can play a crucial role as stakeholders. And through meaningful and early, timely involvement of these stakeholders, taking into account their first-hand experience of living with conditions or health issues, projects can achieve more patient-centered outcomes with greater credibility and acceptance, and also devise sustainable, scalable pathways to implementation and impact that are grounded in the real-world stakeholder experience. So as many of you may know, in recent years, the European Commission has actively been promoting the participation of patient groups and associations in research projects, recognizing the value of public and patient involvement as an important factor for achieving truly patient-centered outcomes and results. And those of you who pay close attention to funding calls like I do in my role will have seen that many calls now emphasize the value of involving and engaging end users, such as patients and caregivers, in research. And you'll have seen that funding bodies such as the JPND, the Joint Programme for Neurodegenerative Diseases, has taken this one step further, adding a section on patient and public involvement to their second stage proposals. So Alzheimer Europe partners in or supports EU-funded research projects in a number of different ways. And today I'm just going to talk you through some of those ways. So some of the projects we support range from enabling platforms for brain research, such as data and sample sharing platforms, projects that are developing AI-powered methods, tools, or pathways for enhanced detection, diagnosis, and care of dementia, as well as projects that are focused on risk reduction, brain health, treatments, and so on. And as an umbrella organization and a patient organization, we collaborate in these projects in a number of different ways, as indicated on this slide. A core contribution is the organization of public involvement activities and patient advisory boards, ensuring that research reflects the perspectives, needs, and values of people who are affected by dementia. We also leverage our networks and the regular meetings that we organize with our member associations, with policy, supporting this collaborative engagement of researchers with key societal, policy, research, and clinical stakeholders across Europe. In the last 5 years, we've also worked with researchers to identify, discuss, and address ethical, policy, and practice challenges that innovations might face in the community and in the real world. And finally, we leverage our own communication channels, as well as developing project-specific communications, really to help raise awareness and support wider engagement with the community of key audiences and stakeholders. So what does this look like in practice? I'm going to start by describing some of the public involvement work we do. 12 years ago, as some of you may know, Alzheimer Europe founded the European Working Group of People with Dementia. And this group is composed of people living with different types of dementia who are nominated by their national Alzheimer's associations. You can see their picture in the top right-hand corner. The group currently comprises 15 members from 13 different countries, and the chair, Chris Roberts, you can see on the right of the image, is also a member of the Alzheimer Europe board. A few years ago, in 2022, we launched the European Dementia Carers Working Group, which is composed of current or former caregivers for people with dementia, and you can see that group in the bottom left-hand corner. That group currently has 13 members from 13 different countries. So as part of our work with EU-funded research projects, we organise public involvement consultations with members of these groups, or we establish patient advisory boards that we create specially for projects. And we organise, moderate, report on public involvement consultations, informing those projects on the needs, views, and preferences of people who are affected by dementia. So the example I wanted to talk about was an event in November last year, where we hosted a collaborative event in Luxembourg. And that event involved 6 different research projects, which focus on a really wide range of different topics and aspects of dementia research, from dementia prevention to AI algorithms. I'll move my video so you can see a few of the other logos. There you go. The event was led by my colleagues on the public involvement team, and in particular Anna Diaz, who you can see in the image in the middle of the screen. And over the course of 2 days, we organised a series of consultations to provide feedback on and input on the design, implementation and outputs of those research projects. And I'm just going to show a short video which captures some perspectives of this event.
Hello, my name is Chris Roberts and I'm the current chair of the European Working Group of People with Dementia. And I've got a diagnosis of mixed dementia, which is vascular and Alzheimer's. And I come from lovely Wales in the UK. Patient involvement in research is very important, especially those with a lived experience. We bring a wealth of knowledge to the professionals, and it's definitely a case of nothing about us without all of us. We can contribute so much, and it's proven time and time again.
That was Chris Roberts, and I'll share one more video of a researcher showing her perspective on the event.
I see the advisory board and its members as our compass, that force that keeps us grounded. They remind us every day why we chose to do what we do.
And that was Mari from the Multi-Memo and EU Fingers project. I'll just resume the screen share to get back my presentation. So to finish, I'll talk a little bit about stakeholder engagement and communication. In the introduction, I mentioned some of our stakeholder groups and the importance of stakeholder engagement to pave the way for implementation and societal impact. Alzheimer Europe was founded over 30 years ago by a coalition of 9 national Alzheimer's associations. And they stated, and I quote, "Because we are all satisfied that we will benefit from European cooperation, and together can put more pressure on the European Council, Commission, Parliament and other national and supranational organisations, we've decided to form a European Alzheimer organisation." So in the three decades since the creation of Alzheimer Europe, the organisation has established a wide network of stakeholders, including national policymakers and composed of representatives from health, social affairs and other ministries, amongst others. And these representatives meet regularly as part of the European Group of Governmental Experts on Dementia. Alzheimer Europe also founded the European Alzheimer's Alliance, which is currently composed of 97 MEPs from 26 countries, all of whom have signed the Dementia Pledge. Central to our stakeholder group are our national members. So these are representatives from 41 national Alzheimer's associations from 37 countries. And they really represent a crucial touch point with society and societal realities that are faced by people who are affected by dementia and can really help advise on implementation of research projects and any barriers that could be encountered. We engage these members in most of our activities, including partnering on research projects, with regular meetings organised where we can bring researchers together with some of these stakeholders. And you can see on the right-hand side of the screen some of the meetings that we organise. So we organise regular meetings with the European Parliament or in the European Parliament, our European Parliament lunch debates. We also have public affairs meetings that happen more or less every 3 months with our members. We also organise an annual conference, which I would really warmly welcome you to this year, which is being held in Geneva. The call for abstracts is open and we welcome abstracts and intellectual disability and topics that are very key to some of the aspects that you've been talking about in the last 2 days. So I'll finish there with some acknowledgements. So I'd like to acknowledge all of my colleagues in the Alzheimer Europe team, who you can see here. The images that you can see across the panel for public involvement, ethical and policy reflections, communications and stakeholder engagement are some of the colleagues that are more strongly involved in EU-funded research projects, but we all work very closely together, and we couldn't do anything without the support of the Executive Director, Jean-Georges, as well as the team involved in finances, communications, meeting organisation and administration. And with that, I'd like to thank you for attention. And just a final call to action. We have recently launched a public call to action so that we can speak to our European policymakers, particularly now with the European elections just around the corner, and really demand that they make Alzheimer's disease and dementia a European priority. We need your support. So we would be hugely grateful if you could scan that QR code, sign our public call to action so that we can bring these voices and bring your joint call to action to the European Parliament in the coming years. Thank you very much for your attention.
Our third speaker is the Dr. Bessie Benejan, who talks about he worked in his hospital. And she will explain to us her experience with the DAMNI project and Horizon 21 project. Let's go.
Yeah, can you hear me? Yeah, okay. Good evening, everybody. Thank you for being here. I know it's the last day after lunch. It's a hard time. So I'm going to talk about DAMNI project and also a little bit about Horizon 21 projects, although Dr. Strijdom has already explained some points, but I'm going to add some information. Very briefly, now I'm going to focus on DAPNI first. Very briefly, I'm going to explain how DAPNI was born. In 2014, the Hospital Sant Pau and the Catalan Down Syndrome Foundation signed a collaboration agreement for the creation of the Alzheimer Down unit, a unit that is highly specialized, with highly specialized multidisciplinary unit composed by different professionals, including neurologists, neuropsychologists, nurses, and a social worker. This Alzheimer Down unit was created to provide medical health to people with Down syndrome, focusing especially on neurological diseases, neurological problems, and in particular Alzheimer's disease, because of the high prevalence of this disease in this population. Our center, in our unit, we offer to all adults with Down syndrome a health plan. It is with no cost. It's free, and we offered annual visits to all our patients around the Catalonia region, which include a visit with a neurologist. We also offer a complete neuropsychological assessment, and when necessary, also blood testing. In parallel to this health plan, we offer to all our patients the possibility to participate in research, in this research program called DAPNI. DAPNI comes from Down Alzheimer Barcelona Neuroimaging Initiative, and it's an intensive study of biomarkers of Alzheimer's disease in Down syndrome. DAPNI includes biomarkers in plasma, genetics, biomarkers in CSF, neuroimaging including MRI, PET. We also perform sleep studies with polysomnography. As yesterday explained Dr. Jimenez, sleep apnea is very frequent in this population, so we also have included sleep studies in our research project. And we have also brain banking. From 2014 till last month, that's 10 years, in the last 10 years, we have collected more than 1,700 blood samples in more than 700 patients. We have performed more than 300 lumbar punctures to have CSF, and we have obtained 360 samples. Some of the patients have also a longitudinal CSF sample. We have collected also MRI in more than 300 patients. We have done amyloid PET in 124 subjects, FDG-PET in 147 subjects, and tau PET in 60 patients. In tau is just basal tau because we don't have longitudinal follow-up because it's a more recent technique. About the sleep studies, we have included 295 subjects that have polysomnography, and in total 459 studies, including healthy controls. And we have also obtained 8 brains that were donated by their families, and we have already 14 registered for a future donation of the brain. Our unit is not only a research center, it is also a medical care center. We offer a personalized clinical follow-up to all our patients. Our neurologists also are in contact with the practitioner, the general practitioner of the patients. They can contact also to the medical staff from the nursing homes. We can activate intra-hospital protocols, like, for example, a psychiatric unit or rehabilitation for dysphagia. And we have also internal medicine specialized in Down syndrome. And to the patients, we also offer cognitive stimulation workshops that are performed in the Catalan Down Syndrome Foundation, which can be performed in person in the foundation or even online from their homes. And in relation to the caregiver, we, when they receive the diagnosis of Alzheimer's disease, we offer the family an orientation visit where we can talk about any issue that they want to talk about. We talk about disease, the diagnosis, the evolution. This visit is also done by the social worker to inform about economic resources, about social resources. All the caregivers are also offered support to participate in support groups. And since this year, we are also offering training to caregivers because we think that this training is very important because the knowledge that the caregivers have will have an impact on the quality of life of the patient. So we think it's very important to do this training with caregivers. And in relation to the Horizon 21, as you have heard in the last session, Horizon 21 was born from a collaboration from different experts in the field of intellectual disability, from different disciplines like geriatricians, neurologists, psychologists, neuropsychologists. And the aim of this consortium is to identify factors that can influence Alzheimer's disease, the development of Alzheimer's disease, and also develop clinical trials in order to prevent or delay the onset of Alzheimer's disease. Here you can see the map. Not all centers are here included. Recently, Greece, Madrid, and Rome has also been added. The interests of the consortium are focused on genetic markers to identify risk or protective factors of Alzheimer's disease. We are also interested in biological markers, including neurofilament light or other plasma biomarkers. And we are working hard on the development of cognitive evaluation tools. We have harmonized our cognitive batteries between all the countries. We want to identify sensitive measures to diagnose Alzheimer's disease in an early stage. And we are also working on defining common criteria to diagnose Alzheimer's disease in this population. Here you can see some of the papers that Dr. Stryden has already explained. And here are our ongoing studies. The first one is led by Sandra Jimenez. We are studying the impact that Alzheimer's disease has on sleep in adults with Down syndrome. From the group from Munich, they are studying the feasibility of carrying out magnetic resonance in people with Down syndrome from a qualitative and also quantitative point of view. We are involved in a multi-center study led by Laura Videla. She wants to obtain normative data in the modified Curricle test and the CAMCOG-DS, and also want to see the longitudinal changes prior to the progression of an Alzheimer's disease in this population. From Dublin, they are developing a framework to study how changes in lifestyle, cognitive training, physical activity, engagement in social and leisure activities can prevent or delay the onset of Alzheimer's disease, which is the FINGER-DS study. And the study that we have more advanced is the longitudinal early markers of Alzheimer's disease that Dr. Strijdom has presented today. In this study, we want to identify sensitive measures of early cognitive decline, and in this, as a secondary objective, we are validating the CAMCOG-DS2. The CAMCOG-DS2 is part of the CAMDEX-DS, which includes an interview and also neuropsychological test battery, which assesses 7 cognitive domains. We think we have improved the CAMCOG-DS1. We have changed many of the features because the features were a little bit old. We have updated them. We have removed those items that were not relevant to the progression of Alzheimer's disease. We have added new items. Some items were a little bit difficult for people with Down syndrome, so we have removed this for other items. We have added new tests, like the visual perceptual in the middle, visual perceptual test. We have also added prospective memory test and some measures of executive functioning. And on the right, you can see a cancellation task to assess more attentional problems. And we have also changed some scoring, the way that the drawings were scored before, that's also changed. Here you have a photograph of our in-person meetings. We meet twice a year in different countries. This last one was in Barcelona a few years ago. We also meet once each month through video conference. And as you can see, our consortium works very hard, but has also a lot of fun when we meet. Thank you.
Please sit here.
And our final speaker. Okay, perfect. Our final speaker is Jason Hassenstab from Washington University in St. Louis from the US, who's going to talk about the DIAN experience and multi-site international R01 in Down syndrome. So do you want to, where do you want to, you can stand there, you can.
I don't even have a presentation. I was just invited to be a discussant, so.
Perfect.
Let's discuss.
We'll discuss.
Let's discuss.
Fantastic.
So,
yes.
So maybe we start with Jason then to talk a little bit about the DIAN experience in bringing research teams together and working really across centers or across families. How can you share a little bit of insight into that?
Sure. I think one of the most successful aspects of the DIAN study, and also one of the most emotionally memorable one for us, was when we brought our families together across the world. So as many of you know, the autosomal dominant mutations are extraordinarily rare. It's way less than 1% of all Alzheimer's disease cases. And for many of these people, they've been treated in sort of isolated communities, maybe by one particular neurologist. And they kind of thought they were their own family. They had no one else to talk to, and many of them were given a lot of misinformation. A really memorable participant who's actually getting a PhD right now, her name is Jetska van de Schaar, who's very open about her mutation status. She told me that when she was treated by her neurologist in the Netherlands, 15 years ago or so, the neurologist told her that she should get a genetic test, and she did. And they said, well, it's just a risk factor that you have a mutation. We don't know when you'll get it. You may never get it. And there's nothing you should do, so you should just go home. And so she thought it was over. But then she found more information out by talking to other people that she found out about in the Netherlands who may have these mutations. And then she met Phil Sheltons, who actually was knowledgeable and told her what was going on. And it was life-changing for her. And then I think our first family meeting, which I think was sponsored by the Alzheimer's Association, was in 2015 or 2016. Or maybe it was in 2017.
2015 in Washington, D.C.
That's right, yeah. And it was one of the most emotional experiences I've ever been in, because these people from around the world came, we flew them in, and they had never met other people that had mutations. And so they could actually talk to them about their shared experiences with family. And this has been absolutely critical for a sense of belonging and follow-up and just providing a sense of community within our study. And I think that's been absolutely essential for keeping our study going as long as it has, and ensuring the dedication of our research participants, which is already really, really high. So that's been one of the most positive aspects of our study. And then the other challenges that we have with international studies, as you all know, are getting regulatory approval and getting your study set up to be approved by the FDA or the EMA or whatever regulatory bodies that will scrutinize every aspect of your trial. And this is not to be underestimated, as I'm sure many of you in this room know the amount of work that that takes. Just from a clinical measure standpoint, there's translations, there's validation of measures, there's making sure that you have certificates from vendors, there's all of these things that none of us as scientists really want to do, but I can't underestimate the importance of getting that stuff in line, from the beginning of whatever clinical trial you're doing. And I hope the logistics people in the room are nodding your heads, because this is one that I never wanted to do, but now I'm finding myself immersed in it totally. And as I start my own cohort of international cohort of Down syndrome, I'm hoping to bring all these sort of lessons learned from Diane and follow their exact model as we build this cohort now. So that's been really, really valuable for me.
Okay.
Yeah, anything else?
Maybe just one quick follow-up. Yeah, do you want?
Yeah, sure.
You go.
No, please.
One quick follow-up just on that is, what's probably the most valuable lesson learned from your experience with Diane that you are taking into your international, your multi-site international cohort in Down syndrome?
I would say making sure that the vision of the study is entirely clear to all of the investigators, and that flows down to the coordinators, and then that also flows down to the participants, because sometimes that gets lost. I really want to know. I read this amazing book a few years ago called Start With Why. Has anybody heard of this? It's like a Harvard Business School kind of thing. And it's been an amazing guiding principle that I think Randy Bateman follows really well. But it's really the idea of just involving everybody so that everybody understands why a certain decision is made. Yes, I know you administer the MMSE this way and you always have your entire life, but we have to do it this way now, and here's why. So I think that's been a really important principle that I'm trying to follow as our study starts.
Okay. Public? Is there any question on the public, please?
There's
in the back. Please.
Jason, could you maybe also share to us how it went within the NIH, this grant application process? Because I think the little insight I had, this was also, at least for me as a German researcher, quite unique, that you could reach out to the grants office and really get feedback directly without a closed curtain on some aspects, and I think this is, at least for me, unique.
Well, and maybe before you answer, is it possible to bring up the 3 online panelists as well? Because maybe we can hear from Jason, and then we can hear from the NIA team.
Well, just from my perspective, I'm really, really lucky because Dr. Lori Ryan happens to be my program officer, who is also the program officer for Diane. So I went immediately to her and said, I have this idea to build this cohort. And she immediately led me towards the Include funding. And I've told some of you this, I have to admit, I didn't think that our grant would get funded the first time. And so we were quite surprised when it actually did. And it was wonderful to have Lori's guidance on this also because so many of our sites are not in the US. And so this was like a big question, like, you know, how many international sites can we really involve here, you know, if we don't have the majority of our participants for our study will not come from the US. And this is just because of logistical reasons and just like the group of people that, you know, inspired me to do this, which included Johannes, Andre Stridum, and Juan, who really encouraged me to pursue this line of research. And so coordinating all of this with Lori was absolutely essential, and she's always steered me right. So I would love to hear her take on this too.
Wow, thank you. So hopefully you can hear me. Excuse me. It's a little early here, so the allergies are still the medicine kicked in for me over here in the U.S. But yeah, so you know we're very fortunate. There are some definite rules at NIH in terms of foreign components and foreign applicants. It's always best if you can work directly with a U.S. institution, like in the case with Jason, it's WashU. They are the grantee institution. And so there are obviously foreign components. There is no limit on the number of foreign components per se. You can have it has to be justified. But if you all were to come in as a foreign institution, the bar is actually higher because what you have to show there is that this really can't be done in the U.S. That's the level. But if you're working with the grantee, who is the foreign, you know, the U.S.-based institution, then that component goes away. So that's what we always try to direct people to do: really collaborate. And if the person who puts in the grants, you know, can still be a multi-PI grant, for example, if you want to, you can have more than one PI, and PIs can be at foreign institution. But the institution putting in the grant really needs to be in the U.S. That is the best route. But there's no prohibition against having foreign components for most things. I will say there's a caveat. There may be some funding opportunities out there. Now we're calling them NOFOs, Notice of Funding Opportunities. They say specifically no foreign components, no foreign institutions, and they'll say that. But so you need to read that very carefully. But for most of the general ones, the Include ones, you know, we allow foreign components, for example.
Thanks, Lori. Ben.
Bessie, can we hear more about leadership structure of Horizon 21? Like, with so many, how do you make decisions? or not? How do you not make decisions?
How we make decisions? We make decisions together. Yeah, I don't know if anyone from the Horizon 21 want to answer these questions. I invite you. No, I think we work very good together. No, especially because we have different disciplines. No, we have different points of view. No, it's very nice to have psychiatrists, geriatricians, psychologists together, neurologists, because all of them have different points of view, and all their points of view are very important. No?
So, I'd say that having no money sometimes helps. So what I mean by this is that because there is no common funding, I think that the European Union is lagging behind hugely in AD research in general, and even more so in DS research. So it's a pity because the money is, I mean, it's not such a poor continent, but investment in research is regrettably very low, and so there are very few opportunities for common funding at the European level. So research, we invest less in research than the US as a proportion of but it's very fragmented because we have European level, we have national level, regional level. So we have very limited common funding. So it's based on goodwill and trust. But so most of the things we do together, we do have some common funding. The Jerome Legend, for instance, has been generous and has supported to a certain extent. We've managed to get a few grants, but most of what we do together is funded from each group, which means that you need unanimity, basically, to do that. So when some projects we do all together, some projects is just 2-3 sites that want to participate there. So, I mean, it works because we really want to work together, because there is not like a structure that is funded and everything. We sometimes wish for it, but I'm sure that would also bring other problems, organizational, but this is literally built on goodwill, let's say. But maybe, Shahid?
No, I think you made a good point about no funding or very little funding. That seems to focus minds and agreement. I think that's important.
Thank you.
Thank you. Any question more?
So maybe while folks are thinking, just a question to you, Angie, in terms of, you had given a lot of great examples of the different work groups that your organization has brought together really across Europe and across your organizations. For those here in the audience, how would they work with you? How would they engage with you and with your care and your people with dementia work groups?
Thanks, Heather. So we, as I mentioned, we participate as partners, as subcontractors as well in EU-funded research projects. So if you are putting together a funding application for EU funding sources, whether it's Horizon Europe, IHI, JPND, other calls, then just send us an email, and we can, the earlier the better, because then we can really say what we could bring. We could pave a way to meaningful involvement of those groups. Beyond that, beyond the new proposals, we're also very open to kind of ad hoc approaches for specific topics. So we do interact with researchers in the public and in the private sectors to do sort of fairly discrete pieces of work. So, for example, we might consult with organizations on a particular topic. So, for example, if they try to develop a patient information sheet or an ICF or even a research approach, they might come and do some consultations with us just to see how that can be tailored to make this accessible and usable as possible. We've also worked with organizations to develop communications, videos, and other outreach materials. So, I mean, as Alzheimer Europe, we're very open to those types of collaborations because fundamentally we think that people who are affected by dementia should really be at the center and at the heart of a lot of research, just in terms of informing it, but also making sure that it's delivered in a way that is as accessible and inclusive as possible. So my short answer is get in touch, send us an email. And if not, come to our conference and meet us there. Again, we're really, really open to collaboration. And I think if you're not thinking about EU-level projects, if you've got a very concrete question, if you're looking at national resources within Europe, because I totally agree with the previous person who spoke that there is a degree of fragmentation in Europe. So you have individual funding streams within countries. Approach a national Alzheimer's association or patient association. A lot of the time, they may or may not have a working group, they may or may not have established processes. That's something that we do bring as Alzheimer Europe. However, we would be very happy to support them in engaging with you as national groups for research.
Thank you.
So I would just say be open and ask the questions.
Thank you. Questions in the room?
Bessie, one question. Can you clarify us if in the health plan, are you all individuals with Down syndrome assessed neuropsychological annually?
If we assess
in the clinical practice in health plan, not in research. It's a good question. Not all the patients are able to undergo a complete neuropsychological assessment. We don't have many tests to assess which are adapted to this population, unless to people with severe intellectual disability. In our case, we focus on those that are mild and moderate intellectual disability, because we have tried to assess people with more severe intellectual disabilities, but we have problems with the floor effects of the test. And if you have such floor effects, you cannot track changes over time. So at this moment, the assessment tools that we have are not good for this population. I think we have to work on adapting other kind of tools for less
easier, no, for these people. So what we do in our unit is just the follow-up is done by the neurologists. So.
Okay. Okay. Well, maybe just thinking of that as we think about kind of creating tools, and maybe this question's to Laurie and Erica. We heard, I think, from one of the speakers earlier today a little bit about DS Connect, and you both talked about it as well. And I know one of the comments earlier was really around the representation in DS Connect, especially as we're perhaps using that data and using that information, thinking about these tools and thinking about really trying to understand the biomarkers and other things in this population. You touched on this a little bit about some of the work that you're doing in terms of increasing representation, but could you maybe talk more specifically about like a timeline or what that looks like from your perspective as the research community is looking at using that data?
Sure, absolutely. I'll get started, and Laurie, please feel free to chime in as well. So, patient engagement is always or participant engagement, excuse me, is always a critical aspect within NIH. And so the timeline is, we're doing it now. And it's a continuous, I think, ongoing effort within NIH. We are hoping, we have many outreach activities where we're looking at other populations which have historically been underrepresented, reaching out to patient advocacy groups, trying to encourage engagement as well within DS Connect. So it's an ongoing effort, and we really, we're looking to increase the diversity and representation within DS Connect, understanding that sometimes it may not be reflective of the total population, but this is something that we're working to address.
Oh, great, thank you.
Okay, any question more?
I have one final question if nobody else does, because I think one of the things is we've talked a ton about a lot of data. We've talked about the DIAN data, we've talked about the DABNY data, and the work that's coming out of the Horizon 21, and a lot of the work that's funded or that Alzheimer's Europe team. And so if people want to collaborate, if people want to access that data, that information, and bring it in, what's that look like? Maybe we'll start with you, Jason.
Sure. Well, in DIAN, we have a data request process. So we have an observational study that's been collecting data since, I think, something like 2008. And then, of course, we have the recently completed double-blind trial, which was solanezumab and gantenerumab. And now that trial is finished, I believe that data is also requestable. It's a pretty easy process to get just get data only. Getting tissue is another matter because, obviously, from our participants, that's a very, very, very valuable resource. And so that has to be pretty well justified. But if you just want data from our observational study or from our trial, we have a pretty standard data request process that can, typically goes pretty fast. But if it's tissue or other things, that's a much more involved process. But we regularly share data as we're mandated to do by our funders. And that was always, I think, Randy Bateman and Eric McDade's vision as well.
Yeah, I'm not sure if I understood your question. You mean sharing our data or?
Yeah, so if a researcher that maybe isn't as familiar with it wants to share or work collaboratively, like what's that process look like?
No, in our case, you want to answer?
No, I can, because I think it was Joaquin.
As he has the microphone.
Joaquin Espinosa, the DCC has been mentioned. He made a very good point, and we actually started to work with our lawyers after talking to him. And when he was building the DCC, the problem is, he said, you have to consent properly, because our patients weren't consented in the proper way, because here they have to consent to many, many things, but it's sharing the information outside the European Union. But another specific thing they have to consent is that they have to be in a repository. So because one thing is to send the data to a researcher, and another thing is to consent to so that it's in a repository. So now we are reconsenting our subjects so that we can contribute with the data. But because, of course, in an NIH R01 with Jason, for instance, our data is, of course, by contract, we send it. But the more general data, if it's not properly consented, is more complicated. So I think that the point here is that for anyone that wants to share the data, the first thing they have to is to be able to do it with proper consent forms. And I think Joaquin Espinosa, in that sense, is a fantastic contact, because he's putting a lot of effort in the DCC to share the data.
Okay. Thanks, Juan.
I guess it's a good opportunity to mention that ABCDS also shares all of its data on the Loney website, and like Diane, we have a process as well to make the request, but are really happy to have other researchers look at our data and collaborate with us as well.
Great.
Okay.
Thank you.
Okay.
Yeah, I think we're at our time, and that's a
time. Okay.
yeah.
Finish the session.
Yeah, that's a good way to end. To share data, open to collaboration, open to networking, and now we'll go enjoy the sunshine. And let the Lori and Erica wake up a little bit more and on the East Coast. And thank you, Angie, for joining us as well. And we'll take a break and be back in 30 minutes. Right, Juan? Yeah.
Thank you, all the speakers.
Thank
30
you.
minutes.
Now we start. Yeah, hello? Okay, so please be seated. We're going to start now the last session of this conference. Yeah? Can you hear me? Yeah. So we're going to start now the last session of this conference. Thank you for joining us after such a long day, such a long 2 days. My name is Mircea Balasa. I'm a behavioral neurologist working here in Barcelona, and together with Matthew Janicki from the University of Illinois in Chicago, we're going to co-chair this session, this panel discussion on ethical considerations of Alzheimer's disease research in individuals on Down syndromes and autosomal dominant Alzheimer's disease in the new scenario open with the approval of new treatments for Alzheimer's. For this, we have prepared a panel for guests. Natalie Ryan from UCL Queen Square Institute of Neurology in London, Alberto Arelló, who is the head of the neurology department here at this hospital, the Hospital of St. Pau, Ann Cohen from the University of Pittsburgh in the United States, and Shahid Zaman from the University in Cambridge, also in the UK. So, Matthew, if you want to...
It's
something?
Yeah, a couple of things. One is that we're going to be kind of taking a different tact with this session. We're going to do a panel as opposed to presentations. And we've invited our panel to think about the ethical considerations of some of the things that you've been hearing over the past 2 days. Going back in the origin of this, as you may be familiar, there are now, I think, 3 countries in the world that have approved the use of these new disease-modifying treatments for Alzheimer's disease. Japan, China, and the US. And I think there are other countries have it pending before their boards at various levels. And Europe, I think, is still in the pending stage. And obviously, there's one medication that's now being used, lecanemab, and also another one that's going to be eventually approved, I hope this year, for use. The issue that we've kind of faced it in the States is that equal access in terms of people with Down syndrome. One of the problems is that we have a drug formulary process that each state of the Union of the United States that has to create the prescribing criteria for physicians and others to be able to order the medication to be used by individual patients, and they have to abide by various standards in terms of assessing the individuals, determining their eligibility because of the presence of Alzheimer's disease for the various levels, both in testing and biomarkers, et cetera. So it's a little complicated process, but it does involve also the fact that it's open to anyone in the population. There is an issue, though, because in any of the clinical trials that have been held for the medications, there's been no involvement of people with neuroatypical conditions, particularly Down syndrome. So one of the kind of ethical things that we've been addressing in the States is how do you promote access to the medication once and if the prescribers are comfortable with the safety of the medication. So there's this kind of dilemma. Do you move ahead or you don't move ahead? And that's one of the ethical considerations. We were anticipating that our panel might provide perspectives both from the prescriber element in terms of what it means if you're eventually, or even maybe now, doing something in that area, and from the kind of the consumer perspective, parent perspective, in terms of the risks involved, would you do it, and under what conditions. So what we thought we would do is just turn it over to our panelists, perhaps on that first statement about the access issues, what are the pros and cons, which direction to go, what are you thinking, what do we need to consider, to kind of just throw out your ideas, and then also engage you in the audience if you have some particular strong feelings about it as well. So I'm not going to point to anybody, but I want to kind of one of you to jump in if you want and start discussion.
Well,
I guess we're all looking at you.
I could start. Yeah, I mean, if I'm speaking as a clinician, so I work with people with intellectual disability, not just people with Down syndrome. When it comes to any kind of treatment, we've often used what's been known in the general population. For example, depression. So we'd try drugs that we know work in the general population. So I think in some ways, this new drug coming on board, one would probably take a similar approach. But the issue here is we know of the likely increase in the number of side effects, given that there's more amyloid angiopathy. So that makes it a lot more difficult and complicated. And I think in terms of whether I would, offer somebody some medication, I would be very hesitant. I would have a clear discussion with them saying, these are the possibilities, we don't know much about it. In a sense, you're testing the drug on that patient. And that's a very, very, very difficult choice. So I would have to have make it clear what the risks are for and against. So what that means is that perhaps what we do need is experience from places where they've accepted it and learn from that. And often new drugs are often, even the ones that have been approved, that's often how things are done. But the other problem is this drug has, because of the side effects, it's got a whole lot of other problems in terms of how much effort you need to put into to prescribe it, to monitor the side effects. And that's got cost implications. And, that's again, it's the NHS is sort of the National Health Service from the UK. They're sort of having discussions about that now. So I think, but the important thing here is that we've got an amazing opportunity to have a disease-modifying drug for this population, which I think is very likely to have some success, more so than perhaps in the general population. So I think we should be enthusiastic as possible and try and facilitate it by keeping these provisos of safety. I'll end that.
I mean, I think we need the trials, don't we? We've heard, it's been the theme of the last 2 days, there are clear commonalities between Down syndrome, Alzheimer's disease, the other genetic forms of Alzheimer's disease and sporadic Alzheimer's, but there are also key differences. And so without a trial in this specific population, it's really difficult. But it's also a wasted opportunity from a scientific perspective, isn't it? Because Yes, there is more CAA, but we had these same concerns before the DIAN-TU trials started in familial Alzheimer's disease. They also have a lot of CAA. But what's really key is that the severity varies, and that variability doesn't necessarily map to variability in clinical manifestations or in risk of microbleeds. So I think we need to, when we're talking about risk, we really need to be clear about what level of where we're talking about CAA, vascular amyloid deposition of vessels. Are we talking about neuropathological CAA, which we know affects up to 90% of everyone with Alzheimer's disease? Or are we talking about the microbleeds that occur in a far smaller subset? And we just don't know how these different conditions are going to respond to anti-amyloid therapies until we do the trials. And obviously in Down syndrome AD, like genetic FAD, we have the opportunity to go earlier when we would hope the risk would be lower, and there's certainly some evidence for that from DIAN-TU. And in fact, the rates of ARIA have been lower than in some of the sporadic AD trials.
So I can talk a little. I'm the only non-clinician on the panel, and I'm really bringing the family perspective to this in our work in ABCDS with outreach. And one of the things I did when I got invited to be on this panel was called a couple of families to ask their opinion on these things. And 2 things became very clear. The first one is they want the trials. They want the evidence in people with Down syndrome. The second thing that became very clear was that there's a huge range among people with Down syndrome, just like in the neurotypical population, with their willingness to accept the risk that might come with the trial or with the drugs. One mother said to me that, she knew that her daughter would take whatever risk necessary to maintain that independence. Another family said to me, we're not willing to try this until we see the trials in Down syndrome and in people of color with Down syndrome. You know, they want representation in the trials beyond just people with Down syndrome. And I think we're going to see a big range, just like we do in the neurotypical population. But it's like you said, we need the evidence to provide to these folks to give them data to make that risk-benefit decision.
Yeah, we really need the forums for the families to come together and discuss with scientists, but also with the pharmaceutical companies and the regulators. I mean, yes. Jason's comment in the last session about the value of the Diane family conferences was so spot on. So I've been involved in Diane since it started at UCL, and these opportunities where you bring together everybody who's affected, so whether that's from a lived experience perspective or from a developing new medications perspective or regulating them, those meetings aren't going to come naturally, so we need to create more opportunities to hear that diversity of perspectives, and also the diversity of perspectives within one group, because as you say, it will hugely vary, and it's not going to be achieved just through the odd focus group. It needs to be an ongoing dialogue.
And it's going to be a really highly individual decision, I think, between the provider and the family and the individual with Down syndrome. We talk a lot about what the families want, but we need to make sure that we've produced language for this information and for these risks that's accessible to people with Down syndrome as well.
Perhaps I want to share my experience. I totally agree with the need of data, really, in this population. I want to share also my experience as a clinician with lecanemab. Here we have a few subjects in the lecanemab trial, and also one patient who is taking lecanemab, but as part of the outside of the trial, as part of the special use. And also, as a clinician, our concern is safety with these drugs. This is the major concern, severe area. But the patient or family perspective is very different. They want to, for those who are been taking the drug, they want to keep maintaining the status independence for as long as possible. And I also agree with the individual decisions, because once the patient is outside of the trial, then it's part of the clinical care, and there are many decisions that are not, that need clinical judgment in each moment. So I think we need this perspective, at least in Europe, that we still don't have the drugs most approved yet. We need this perspective of this clinical management in communications with patients and families.
If I could add, I think one of the important things is educating people who may receive this treatment, educating them how to understand risk. Although, we only have limited information because it's in the non-Downs population, but I think that's a very difficult thing to understand for most people. If this was a drug for cancer, even though with side effects, and it only been tested in the non-Downs population, I'm sure we get a lot of people wanting to try it. So it's that perspective we need to understand. How serious is it for someone who's just getting mild symptoms? Maybe in 5 years' time they'll get the full diagnosis. How seriously are they taking it? Or are they just leaving it to chance? Or would they prefer to spend that $50,000 or whatever on something else and not get the treatment? So those are the things that we need to educate people, I think, a lot more, and ourselves as well, because it's even hard for us to really understand the risks.
That's something that one of the parents I spoke to and her daughter, they described that very frequently, it was difficult for them to identify the memory problems initially because of the way her daughter was describing them and the way she was describing the neurologic symptoms. And so I asked her about potential risk for side effects and how that, especially for a child who's living independently with minimal help, how would that work? And she said, you have to do better. You have to understand how people with Down syndrome communicate their level of pain or their discomfort or just things changing, because it may not be what we're used to. And I think probably in this room, everyone's very good at it. But then you get out into the wild to a clinician who maybe sees 1 or 2 patients with Down syndrome over their career, and it's going to be kind of our job to educate those providers on how to have that communication.
can I add another comment? So I think kind of related to that is what you're saying is more about when we're treating it. Are we treating the illness or the disease underlying pathology? And I think we have to keep that in mind. And there are many times when you have a treatment for a particular condition which has certain pathology, but you decide not to treat it because on balance it's not going to make any difference, or whatever choice you make. So I think these things need to be thought of very carefully. And as I said, education is important here.
You made a comment of comparing access to these particular new drugs to other conditions of treatment like cancer, heart disease, whatever else. And there's always, I guess, when a new medication comes out, that there's risk that may be unaware of, people are not aware of yet until you try it. To what degree is there a similarity in terms of our concerns over access to these drugs as opposed to concerns over access to other disease-treating drugs? Are we making a big difference here, or is it something that we should be thinking about like we do with the other medications?
I mean, there's certain drugs that come on the market which suddenly have unexpected side effects and they're withdrawn from circulation. But in this case, it's more specific, and that's probably why it's slightly different, I think. Yeah.
Well, I think in the case, once you're dealing with the first disease-modifying drug, I think we're facing with many challenges because we don't have even the language to really explain to patients what the benefit is. When we say, oh, it was a 30% reduction in progression or risk of progression to a dementia, most patients or families do not really have a clear understanding of what that means. If you go to cancer, I mean, survival time is much easier. So part of the discussion, I think, the community we're having is how to communicate easily. There is this time save, for example, which is easier to understand. So I think besides the adverse effects that these medications may have is that we need to create all this language around risks, but also the potential benefits, and individualized to that patient. So that's I think is still being is ongoing, and that's another complexity compared to other diseases that have a really established language about this. Yeah.
I think I can say so. Andre and I in the UK, we were trying to many years ago trying to get a sort of primary or secondary prevention trial going, and it was so difficult to firstly decide how many years back do you go, and then all the issues you're saying, highlighting, came up as well. You know, treating someone, side effects, what's the worth of that? And I think, I mean, even though things like treatment for hypertension has been well established and hyperlipidemia, I still don't know how that's happened. You know, it's just as abstract as saying, oh, you prevent stroke or you prevent heart attacks. So I think we need to sort of really understand or help, you know, the population understand what are we talking about here. You know.
And perhaps another point that I think is common to any of diseases with dementia is that families believe that the treatment is useful only as for a period of time, but once the disease is very advanced, it's probably not worth to really give any treatment. So that's also another issue that I think is difficult to discuss with the family or patient. So when to treat and when the family or patient they think it's worth really having a treatment that really slow progression.
So I guess here's a question I maybe wanted to ask is, like any special population, do you really want to define some specific metrics of success or safety, in terms, not necessarily in terms of cognitive measures, which are obviously different, but in terms of biomarker output or functional or safety issues? And if we really want to do this before triaging or before trying this treatment in this population, wouldn't that represent in real life a delayed access or lack of access? Because in the end, these are kind of trials that never ended up doing after post-approval, and you spend years without really giving access to that population of a new treatment based on the lack of evidence of the safety on this specific population. So this is a vicious circle that you cannot break it in the end. Mm-hmm. What do you think about this?
Sorry, I didn't quite understand.
In the sense that if we decide that we need that specific data in this specific population, and maybe this data never came, wouldn't that represent not giving access to a new treatment to this specific population, Down syndrome, in the sense Down syndrome with AD?
Yeah, so, I mean, that's why a lot of people want a trial. But I think it's just, you've got to look at the practicalities. Here we do have a drug that's potentially going to produce fantastic results. So, as I say, I go back to asking the individual, what their perception is. Are they willing to take a chance? Everybody has a different risk perception. Some people are more impulsive or risk takers than others. And I think the experience we get from people prescribing around the world will certainly help. But I would prefer to have a clinical trial in this population for this particular product.
I think that I think everyone in this room would say we would prefer a trial with the strong data. But then, on the other hand, when I think about who's going to have access to the trial and where they need to be in the world and location-wise, that's going to be, it's going to be a challenge regardless, trial or no trial, but it's going to be even more challenging to get access, to get folks access all around the world, even all around the United States, in a trial context than in a prescriber context. But it's kind of a catch-22, because then, anybody can prescribe it anywhere. How safe is that? Are we endangering folks? And so it really is, I think it's a big kind of reckoning that we're going to have to face with this.
Is there an ethical dilemma in terms of holding off access to the medication? If you look at waiting for a trial to occur, how many years is that going to take? First, get the trial mounted and then carry through, while the rest of the atypical population is getting the medication. So I guess I'm tossing that out as a balance issue. Any thoughts on it?
As we've been talking about this, I was thinking about what Juan has always said about that, we want DSAD to be on the same plane as ADAD. And then you look at the DIAN-TU, and now you're doing open label lecanemab and the anti-tau therapies. And so, if we hold that standard, then there is a dilemma there, because we're giving sort of open label access to these approved drugs to that group, but not to Down syndrome. And so I don't have the answer. I just think that's what's been playing through my mind as we've been talking.
But I think the DIAN-TU trial shows actually how quickly these things can gather momentum once you have the commitment of people to collaborate, and you have a platform trial where you bring in new arms, and you have the trial-ready cohort in Down syndrome, so it is ready. And I think thinking back when I started 16 years ago, for the families I was seeing, it was actually the same position as the Down syndrome families are now. There was literally no trial they could go into, because there was this arbitrary cutoff of 50 for most of the sporadic AD trials. And so we were seeing people in their 40s, and there was nothing. And it was crazy, because they are the best. If these anti-amyloid therapies are going to work in anyone, we felt it's going to work in these young, healthy people. But, at that point, although we were very hopeful that things were going to change, I could have never predicted that we'd be in this situation 15 years on. And, I think things can happen faster than it's just starting, isn't it? It's getting it started.
Can I ask something? How keen were the people wanting to get into trials? Because one of the difficulties we have is we always find it difficult to get people involved in trials.
Well, it's of course really variable, as you say, but there is enough people who are absolutely motivated to do everything they can, and in a very altruistic way, because with these initial trials before the open label extensions, they knew they might be receiving placebo, but they're contributing to learning how to treat the disease for their own children, for their siblings, and so they are the most highly motivated group of people you could ever want to work with. And I think that kind of getting that message across was really important. So when I started, there was an EMA meeting where the prospect of pre-symptomatic treatment trials for ADAD was going to be discussed, and I was told, you know, there are people who actually think this is never going to be possible, it's far too rare, people in there who are that young, who are healthy, aren't going to want to take a risky drug. And so we made a film where I interviewed a few people just talking about their families, their thoughts about research, and they played that at the meeting. And I wasn't there, but I was told it did have, it had an impact. And I think that's why we need the family members to be in the room, and they will come, and they're very vocal, aren't they? This is what they care about. And again, the Diane family conferences have brought those opportunities. So I know family members who've then gone to talk at companies to inspire the people who are working on getting these agents through the process as to why they need to get a move on. And we need to make those opportunities, and we need to make it possible for the Down syndrome community to have that voice, because they're a very active cohort. I was saying to some colleagues today, we have an engagement event in London that I wanted to invite myself to this year, and there was such a long waiting list of family members wanting to go that I couldn't go. But that in itself was just so positive. The families want to engage, don't they, and share their perspectives.
I want to add to that just that when one of the mothers I spoke to, she said to me, and I'll try to quote this as best as possible, she said, our children were the trailblazing cohort. They were the first fully included. We fought so hard to get them into classrooms and to live independently. And she said, now I think we're going to be the trailblazing cohort again. And that, that viewpoint is what I hope we can use to engage the Down syndrome community far and wide to really get this work done.
And from one comment about the health providers is the economic argument, how much cost it is to someone with Downs who has dementia. They need greater care costs compared with the cost of a drug. I think that's also worth keeping in mind.
Yeah, that was a point that Mike made earlier today about the Medicare and Medicaid data, that, looking at that economic, that the cost of the treatment might not seem that much once we really dig into how much the care costs.
So I really feel that working together can actually really add momentum to this, the perspective of advocacy. So we're really lucky to work with Young Timers, who are an amazing patient-led organisation in the US, set up by ADAD family members. And as Jason said, they've been so powerful in driving forwards the changes that have occurred, over the last 10 years. And if we sort of unite within genetically determined AD, I think there's even a stronger voice.
I think there's a comment there.
So on this topic of ethical considerations, I wonder if the panel could discuss a little bit about how the capacity to provide informed consent for individuals with Down syndrome plays into this. I imagine some of these patients are mildly impaired, so some of them are severely impaired, intellectual disability. And we typically have special treatment for populations that have limited ability to provide informed consent, for instance, children or prisoners. And so when we're talking about a treatment that has potentially severe side effects, how do you think about how that plays into the decision to treat these individuals with a drug like lecanemab?
Yeah, so we're lucky in the UK. We've got guidance from the Mental Capacity Act, which gives you a clear idea of operationalized way of assessing someone's capacity, which is to see if they can understand, weigh the pros and cons, and communicate whatever decision you're discussing. And it has to be done in a way that they can actually understand. You have to give them enough time. And if after all that they don't have capacity, you've decided they don't understand what's happening to them, what we're asking them to do, then what you do is what's called a best interest meeting, where you decide amongst people close to the person what they would want to do if they were in, because they know them best, what they would have decided. So we've got quite clear guidelines. So if the panel, the best interest panel decides that this is going to be in the best interest of the person and they would have wanted it, then you go ahead with the treatment. So in some ways we're fortunate in the UK. We've got very clear guidelines to help us with that.
I just want to respond to that. We have, for some of our trials, had discussions with the regulatory agencies and have an approved capacity assessment for people with Down syndrome prior to enrolling into our studies.
So I wanted to make two comments. First of all, in relation to several comments that have been discussed today, and first I'll start with Natalie's. I loved what she said about how the landscape changed in autosomal dominant AD. And I was thinking of the Beatriz Bosch talk this morning talking about the picohem experience. And I think it's amazing the work they've done in hospital clinic now with reaching out and really capturing most of the mutation carriers in Barcelona, doing amazing research. But it was even more impressive the proportion of people in the picohem project that were successfully included in trials. I mean, the level of commitment, the level of participation in trials was really impressive. And this is something that I want to link to a Jason comment. Jason Hasenstadt commented this book about why, no? And I haven't read the book, but I will certainly buy it, because we've had this conversation in our hospital, and saying that why don't we get the level of commitment or participation in trials as autosomal dominant AD? And certainly we're coming late. So we are, as you were saying, at least 15 years old. But maybe the first reason is us. If we are surrounded by doubts, it's very difficult that we have any action if we really don't offer a path for our participants. They're not gonna. I mean, it's amazing and absolutely necessary to have their voice, but you have to signal them the path. It's not them that is going to advance the science. It's you that you have to advance the science and discuss the risk and the opportunities, but we really have to set the path forward. So that's one thing. And so that's for my first comment. And the second comment is the risk of decoupling. And this is related to Mirza's comment, Dr. Balasa's. He mentioned the problem is that we are waiting for trials that might never come. So it's can be like waiting for Godot. And so maybe we all want data. We all want safety data. It's the first, and we've been writing editorials about the risk and everything. But I think decoupling from the autosomal dominant thing, setting the bar that we need absolutely, not to speak about efficacy, but even safety data for every drug that is approved in Alzheimer's disease could be a complete disaster, because we're not going to change the mind of regulatory agencies. They're not going to be sitting in the front row to change the policy every time we decide to change our mind. So if we set the standard real high, it could be, as Mirza was saying, that we're waiting, and my answer, and I think here I have strong opinions, doing nothing, waiting years and years and years to gather the evidence, that's taking that has, to me at least, a very important ethical dilemma. I would be suffering if I was in the US, deciding whether to treat or not people with Down syndrome. Treating my sporadic AD people and not treating AD, for me, it would cause me, literally as a physician, suffering not to be able to be prescribing these drugs. And I think that's also a consideration. That doesn't mean at all that we don't need safety data. That doesn't mean that, to the very least, I would put like a registry or whatever. And certainly the best scenario is to have a trial as fast as possible. But to consider that no medication in DS, that we prescribe in DS, has level 1 evidence. So as he was saying, the antidepressants, the insulin we're doing, a lot of things They don't have level 1 evidence to prescribe those drugs. And I think those are also important consideration. And last thing I'd say, as Natalie was also pointed out, the theoretical risk of CAA is the same in autosomal dominant as we've seen as in DS. It can be increased, but it did not materialize in autosomal dominant. And it's very clear that APOE for homozygotes, they have a much larger and increased risk, and there are debates of whether this should be prescribed or not, but they are not precluded from start from receiving this drug. It's only in DS that we are actively excluding them from this treatment, and I think that's a consideration that we should consider. And as I said, I summarize this with the risk of decoupling DSAD from ADAD. I think that we're safer if we go with the big brother, not in numbers, but in advances in the field, which is ADAD. So that's it.
I think there's a comment over there.
Can I just quickly follow up on the APOE point? I was wondering maybe if we were to, in this population, to restrict treatment to only those that were APOE3 homozygotes, because we know APOE4 increases risk for ARIA in a population that may already be at an increased risk, if that would be a potential consideration going forward. Just maybe the panel can comment on if, lecanemab were to be used in Down syndrome and it turned out to be a really bad experience, how that might color Alzheimer's disease therapies going forward in that community. I don't know. I'll have to hear comments on that.
Well, I think if you could identify any kind of risks, like the genetic risk to more bleeds, etc., I think is going to be helpful. But as I said at the beginning, I think it's a matter of us understanding what the risks are as much as the patients, and being able to make a decision based on that. Which means, I wouldn't stop myself from prescribing something if somebody was keen to do it and they were fully aware of, understood the risks. And you take whatever precautions you could, maybe start on a lower dose, do a bit more monitoring, that sort of thing.
I can jump in on that. So I think that what's disconnecting for me, and I agree with the idea that we need to take action, but that maybe we need to phrase this around equity versus these specific drugs, right? Because if we pitch these families on these drugs and then the drugs don't work, then we used all of our capital to get them in and we might have lost trust. Where it might be worth taking a step back and say, it's not about this drug, it's just about all drugs. It's not about consent for this drugs, it's about consent for all trials. And sort of decouple this specific one, which has a lot of hype, but also a lot of questions around it, that maybe we just have to phrase it around, this is about equity for all trials, whether it's this one or the one in 5 years or the one in 10 years. And that way we're not on the line, if this one doesn't work, that we lose trust, especially with these marginalized communities. This might be the one trial that they do and they're never going to do one again. And they're going to tell their friends it was a bad experience, it didn't work, and the scientists lied to them. And I'm just worried, and hopefully you can talk me out of it, that the hype is too strong for this one, that we don't want to let people down, like the previous question. So I just wanted to add to that.
I think it's a really good point that inclusion is something that we know this community will rally around, and so framing things from an inclusion standpoint and being very transparent that there's a lot we still don't know, and there's a lot we still don't know in the neurotypical population. So, we have to have that transparency, but you're exactly right that we say this is about inclusion of people with Down syndrome. This is not about a specific drug or a specific trial. This is about changing the game across the board.
Let me throw that into a question. Are we contributing to exclusion by creating the impression that Down syndrome as a label is exclusionary from access to the drug, as opposed to looking at what characteristics of individuals who may be diagnosed with Down syndrome would have a very low risk if they've got the drug?
Yeah. I think that's one of the parents asked me point blank. She said, Do you think if this was Joe's wife who lives down the street from me, that this would be the same conversation since she doesn't have Down syndrome? And that's the question that the community is asking, is why is Down syndrome treated differently than these other groups? And I mean, there are reasons, but I think we have to be better at framing it. That's not for the community to do.
So maybe I could come in here. I think many people in the audience know what my views are on this because I've been quite vocal about it. I think, well, I'm with Natalie on this. I think we do need evidence. The argument that you've just mentioned about potential discrimination, it's also a form of discrimination to say that we can give treatments to people without evidence. And if we go back to the cancer example, if there was a condition, a genetic condition that predisposed to a particular kind of cancer, then they would have done trials, I think, and would have done it in a context of a big trial network, or would have gathered some sort of evidence before rolling it out in terms of treatment. So I feel quite strongly that we need evidence, not necessarily fully randomized controlled trial evidence, but we do have an opportunity here in that these treatments are not going to be rolled out everywhere in the world at the same rate. So we have an opportunity to do the trials. Even if it takes years, it's going to take years for it to be approved in many countries, I think. So.
So maybe just
just
want to add one. Go ahead.
I was just going to say this is a vulnerable population, and I think that's the root of the conservative approach here. We have the two trials, Clarity AD and Trailblazer ALS 2, that were gold standard trials. 36% reduction in cognitive decline. Removal of amyloid is necessary. Gantenerumab, solanezumab did not remove amyloid, and they failed. So we know that we're on the right target. This population, we've been for the past 2 days talking about, they're deserving treatment. And I agree with Juan, we need to be more definitive about our belief in the clinical trial results, but also keep in the back of our mind that we can monitor them more closely. We can stratify who gets in initially into the studies. Just like the ACI-24 vaccine study, it underdosed in the first trial. Is a go low and go slow approach, and it may be the same with monoclonal, at least with monoclonal antibodies. Once we feel more confident, then we can increase the dose, up titrate, and be more aggressive with amyloid reduction, and weigh the risk of ARIA, which, by the way, 85% of the time is completely asymptomatic and only seen on imaging. So the concern that we have about some fatal occurrence of an adverse event needs to be tempered with the data that we currently have from ADAD, but also from the ongoing studies in preclinical AD. So I just wanted to second Juan's comment that we need to be confident in the process.
I think that's such a good point. And actually, engaging people who have had ARIA, talking to them about, for me, I learned so much from talking to a participant who developed ARIA in one of the Diane TU trials, and said, she would stay in it, and she would take the next anti-amyloid therapy that was offered to her, because actually, she, even having been through this side effect that we do fear, it wasn't bad enough that she wouldn't want to stay in it. And we're not hearing those voices.
And the risk-benefit question comes up currently in the AHEAD trial with patients who are on anticoagulants. If you're on anticoagulation, there's a cause for concern for increased ARIA and hemorrhage. And participants are signing on despite that. They have the conversation with the PI, but they decide, I'm going to take that risk, knowing that the alternative is what we've been talking about in terms of a decline in cognition, maybe 5 years, 10 years down the road. They still want to take that risk, and it's their choice. We need to provide safety around it, but it's their choice. And for us to make that decision for them is completely unethical.
Yeah.
This kind of reminds me of what we see when we're diagnosing conditions in the population of intellectual disability called diagnostic overshadowing. where you misattribute the presentation as being due to the actual intellectual disability or Down syndrome. And I think one could say that what we're seeing here perhaps is therapeutic overshadowing, where we've got an obvious case of a disease which we've well characterized. You've seen all the data. It looks very similar to autosomal dominant as well as sporadic in many cases. Why shouldn't, and we got trials showing positive results, why shouldn't we be doing it? So therapeutic overshadowing here, as an example, just a thought.
Yeah, I have a couple of thoughts. One is it's an interesting trial because we're asking people to join when they're asymptomatic, essentially. I've been in trials, I remember the trials in autism with risperidone, where it was available, but we still ran trials and were able to get families in the trials because it was a more careful monitoring and they wanted to contribute, and eventually we were able to get it specifically approved. And I think this is going to be the same way. We have so many families that are interested in this, and their adult children with Down syndrome are not symptomatic and may not be, for many years. But as Annie is saying, they're trailblazers. They want to do this, and what we're going to learn may not answer the question. I don't know whether 18 months on a monoclonal antibody is going to delay eventually, whether you have to go back on it for 6-month boosters. We have no idea. We have a lot to learn. So we're not promising anybody that this is necessarily going to be the answer, but it's the start. And I think we can do it in parallel for some families who are able to get practitioners to prescribe. That shouldn't get in the way. I would have to say for ABCDS, and I have so many families who've signed up to be in TRACK-DS that they would rather do it with us. I've had families who live 5 hours away, and I've said, well, we could connect you for a trial that's closer to home. And they've said, no, we know you. We want, if we're going to do a trial, we're driving, even if it's twice a month, to come and see you. So we have these relationships. So I'm very optimistic about it, and I'm not seeing a lot of ethical concerns to me.
I really think it boils down to true engagement and partnership with this community, because it's exactly what you just said. If you have a relationship and you've built trust and you're explaining that you're monitoring this closely, there's a lot we still don't know, but we always have you and your family's best interest at heart. That's going to be a very different scenario than if we're just going out and trying to give the drug out willy-nilly, which no one here is suggesting. But I really think that true partnership relationship is the only way we're going to get there, especially with this group of people.
And the uptake of the new medications like lecanemab, there are only about 3,000 people in the United States that are actively getting monthly infusions of lecanemab. And the vast majority of those individuals are being treated in accordance to the appropriate use criteria that have been published, so that if a clinician wants to prescribe it, they would have a roadmap of who to select, how many MRIs do they need to get in the first year? It's 5, and how far apart do they need to be? When do they treat through ARIA? When do they not? Those are all in the appropriate use criteria. I could see at the end of our trial that we would have appropriate use criteria for people with Down syndrome to at least give some comfort to those individuals who are prescribers who may not see people as they do in Pittsburgh or in St. Louis, but feel confident that they're following the best standard of care, standard of practice in bringing these new treatments to these individuals, knowing that at least there's one safety trial to make sure that the dosing is right, the dosing interval, titration, and so on is correct.
And when we have that, we've got to figure out how to really deploy it out into the wild, because that's something that we hear about all the time, especially from people who are far from St. Louis, far from Pittsburgh, that they're seeing a neurologist who says, oh yeah, you have dementia, and there's no workup, there's really nothing except for the diagnosis. And so, we've really got to do that, because that's the way it's going to get to everybody when we have the data.
I was just going to comment. You raise a very interesting point. I think that the audience here, anyway, represents a lot of different places in Europe, and you're at the cusp of potentially having medication approved, perhaps by the end of the year, for the general population. What can you do now, in terms of just looking at it, to prepare the families who have adults with Down syndrome and other conditions to anticipate how they might get involved in an advocacy movement, a better education movement, having more discussions with their primary care physician, things like this, to prepare for that decision as to whether to get involved or not get involved. I mean, it needs to have a leadership base, and some sector needs to take it over, or maybe cooperatively, whether it's the research sector, whether it's the advocacy sector, the parent sector, the dementia care sector that we had earlier from Alzheimer's Europe. Somewhere along the way, this is a time to move forward and try to establish some of the things you mentioned about, the medical procedures, the family decision-making, the risk factors, the education that goes into, preparing patients for potentially being involved with the medication. So I'm thrusting that out in terms of a discussion, we've got a head start, I think, in the States, but certainly Europe is going to be quickly behind us, if not probably surpass us at some point, because you always do. So I toss that out to you for some thinking and discussion, perhaps.
So I think there's so much we can be doing in terms of increasing public awareness and understanding of dementia in general, not just in the Downs population, but throughout the population in general. And this is one of the sort of really important benefits of the availability of a disease-modifying treatment is that you have to get it stimulates early diagnosis, it stimulates everybody getting considered, and so everybody getting access to treatment. And we've seen that in stroke, so the availability of thrombolysis means that anyone who might be having symptoms of a stroke gets treated urgently and considered. Most of them won't go on to receive the treatment, but they'll all get considered, and that sort of spans to just engagement of the community. The fact that in London we have posters on our buses saying, face, arm, oh God, what is it? Speech, think stroke. So, that wouldn't have been there. People wouldn't just left their stroke symptoms for days, didn't they, before we had urgent treatments. And it'll be the same, I hope, with dementia, that now if someone you love starts to get symptoms, you get a diagnosis, and we need a whole shift in culture to sort of actuate that now. We don't need to wait till we have these therapies approved to sort of start that side of the campaign.
I also agree that we have a golden time now in Europe to really prepare. I think education to general awareness, I think, is key. But also I want to say that the medical community, here we're all convinced that these are treatments that have a benefit, but they still have made many meetings with physicians and colleagues which have really concerns about this is not enough, or this is not the efficacy really is not high enough. So I think still there is a lot of work really in the medical community, because otherwise that will be also a barrier to prescribe these drugs. And also infrastructure, I think, is key. So we need to put in place an effective early diagnosis through blood biomarkers, and also infrastructures like infusion centers with a capacity enough to really give these treatments in the near future. And I think we have a golden time now to really work on all these issues with our regulators and our governments.
I agree with all that, and I think not only educate the Downs community, if you like, but also educate the general population about the Downs. I think that's also an important thing which will encourage the conversation and make people think, because we're all part of the same community in some ways, and that's one of the best ways to get the message across.
You make a good point about educating the general community, but are we perhaps sending them the wrong message when we talk about Downs being a risk factor because of the medication? Are we creating a negative aspect to access as opposed to a positive aspect to access?
I want to focus on the fact that there are treatments available, just like there are treatments for the general population, and this is a population that's probably possibly the most deserving because of the fact that it happens so young. Yeah. So that's what I'm trying to say.
Yeah, I have a question regarding the phase 2 trial with the gamma secretase modulator. How difficult do you think it would be to include individuals with Down syndrome? Is it like an exclusion criteria in the trial? And why not including individuals with Down syndrome in the trial? Is it ethical not to include them, not to propose them to be part of this trial?
I don't know who it is.
Is anyone involved in that trial?
Which trial? Gamma secretase inhibitor trial?
Modulator.
I'm not.
The Roche phase 2.
Maybe Mike knows more about it than I do.
Can we get a microphone over here to...
So the issue is that the outcome measures, how you power your study, your sample size estimates, all have to be done in Down syndrome. And for the past 5 years, Juan and the ABCDS group has been providing us with that information that we can finally do those types of analyses and pick the right outcome measures. And Horizon 21 is trying to pick the best outcome measure. And to just insert Down syndrome as an arm into these trials would be, I believe, a mistake. It would be premature because you wouldn't really have a valid trial at the end. Your sample size won't give you the right results. You may be putting them at additional risk. Gamma secretase modulators still are not without adverse events because there still is notch cleavage. And as the BMS story told us, that you can have a higher risk of basal cell carcinoma. And so that, that's a real signal. So for that reason, I don't see any ongoing studies just adding on a cohort of individuals with Down syndrome. It needs to be thoughtful in the design. There needs to be thought about stopping criteria and the duration of treatment and any open label extension to add additional evidence that you might need. For the prevention studies like the AHEAD study, what we're finding is that you need at least 3.5 years of treatment to discern a cognitive benefit on the PAC, which is a very sensitive cognitive measure in preclinical AD. We think we have one for Down syndrome. We're not sure yet. But then the question is, how long treatment do you need with disease-modifying treatment that would show you a signal on that outcome measure for the FDA to approve it? And if you go for accelerated approval, you may not need to hit that, but you need to have a key secondary that you hit, which would be a biomarker that's relevant. We're just getting that information now and quickly getting into the designs for these studies. But there's a lot of planning that needs to take place, sometimes months or years before you can launch a trial in a specific population. So it's a long answer to your question, but it needs to be designed specifically for that population.
Mike, can I ask you a follow-up question about that? Do you think that we are not doing enough, or that we should be doing more to try to crosswalk these measures between the non-Down syndrome and the Down syndrome population so that we can in the future have those arms?
We just had a poster accepted to AIC on an analysis that we did with AC Immune on ABCDS data, mapping all of the Down's cognitive measures onto all of the standard AD measures, including the ADAS-Cog and some of the standard CDR sum of boxes, and seeing how do those scales function in Down syndrome with the analogous scale in Down syndrome. And I can't go through the results, but it's very interesting. And even more interesting is that it's providing us with information about how much time do you need to be with drug exposure to expect a result. I bother Segan and Ben all the time for some of the cognitive results because we're desperate for how much treatment do we really need, what's the minimum number needed to treat to get that answer. And it's different than autosomal dominant AD. It's its own very unique set of outcome measures. And that's so critical to be getting that information from all these ongoing longitudinal studies. So the mapping is great, but it won't be enough to just, plug them in and say that it's equivalent.
Andre, you had...
Yeah, so I was just going back to the previous question, which is how do we prepare and how do we prepare the community? I think part of preparation is to have better data and clearer answers about the risk associated with these new treatments. I don't think we can have, it's very difficult to have conversations with our patients yet without that being available or very clear. I think it's also an issue in sporadic Alzheimer's disease. Many of my colleagues in the UK have concerns about the data at the moment and feel that it's not strong enough. Natalie will know many of them. They're very active on Twitter and so forth. But I think those are legitimate concerns, and I think we do need a little bit more information and data before we can have those kind of conversations. But in the meantime, it's also important to make sure that we have the infrastructure available, because eventually these kind of treatments some treatment will have the right risk-benefit ratio. And so we need to be building the infrastructure, the clinics, the scanning facilities and so on to be able to enable trials. One concern I have is about, particularly in the US where the treatment is available, would be indication creep. So, the drug's licensed for MCI early AD, but in people with Down syndrome, I think there's a real risk of indication creep where people would just give it to people on the basis of age, perhaps, and I don't think there's any evidence for that, and I think that would be a high-risk strategy, and maybe that's where we could do trials to beyond the indication, and we should be thinking of those kind of trials already.
I think we're sort of at the time. Been an excellent discussion. Thank you, everyone, from the panel and from the audience for joining in. We've actually wrestled with a few thoughts and dilemmas in terms of how we're going to deal with some things, and maybe we've arrived at some, directions to go in. Still a number of things to be looked at further. So thank you very much, and I'm going to turn this back over to our program chair for your closing address, right? Thank you.
Well, thank you so much. It's been a really amazing last 2 days, and it's been an absolute privilege to be a part of this discussion in this meeting. I think for those of you that I haven't met, I'm Heather Snyder from the Alzheimer's Association, and when Juan approached the professional interest area of iStart, Down syndrome and Alzheimer's group about this idea and about this meeting, and I know many of you are here or watching online, there was resounding support, and it was really that momentum and then through a funding mechanism at the Alzheimer's Association that initiated, or at least put the light in the fire, so to speak, or started the engine, and the rest of it is really history with Juan and Raquel and the entire group that really made all of this happen. Just maybe a note, because I know there's a lot of people behind the scenes that put all of this together. This doesn't happen just by those of us that are maybe sitting in this room. The agendas don't get made, the speaker confirmations don't get done, all of travel and all of those arrangements. And so maybe we could just take a moment to thank all of those people for their work and their incredible effort in bringing us together. Including the group in the back, the AV team that has really helped keep everything going. And maybe just the last thing I would say before I get off is should there be a decision or some feedback that this is a meeting and a discussion that really should continue to go forward, I'm happy to say that the Alzheimer's Association would be pleased to support that effort financially going forward. So. And I think with that, I'm passing it to Raquel.
So good afternoon. It has been a great pleasure for us to have you here during these 2 days. I have enjoyed the meeting very much. I hope you too. I will just want to thank again the people who made this possible. First, to the professional interest area in Down syndrome and the Alzheimer's Association. Also to the Pascual Maragall Foundation on behalf of the Barcelona Alzheimer Hub for matching the funding for the Alzheimer's Association. The Barcelona Alzheimer Hub is a joint initiative of the Center Working in Dementia in Barcelona. These are the Barcelona Beta Brain Research Center, the Hospital Sant Pau, Hospital Clínic de Barcelona, ACE, Hospital del Mar, and Vall d'Hebron, to promote the research, clinical care, and educational activities in Alzheimer's disease and other dementias. Thank you also to Ionis, AC Immune, Zambon, Lilly, and Bohaven for their support to this meeting. Secondly, I want to thank the scientific committee, the moderators and the speakers for their scientific contribution. Thank you also to Support Survey, Rosa Roda, and Mireia Cañadas, the person in charge of the technical secretariat, housekeeping, and all the organization details. And finally, I would like to say thank you to my co-chair, Juan Fortea. As I said in the opening session, the idea of this meeting was his idea. And I will say that in this case, due to new professional duty on my side, I will say that I should acknowledge that the hard work of the organization of this meeting has been on his side, so I will thank him for this. If you stay in Barcelona, enjoy the city. If you need some recommendation, please ask us. And have a safe trip back home. And again, thank you very much for coming to this meeting and to Barcelona.
So, thank you. I can say that it's been a real pleasure to have you all here. I think that we are delighted, and I think the feedback that we've been having these 2 days has been magnificent. I think the meeting has been a success. I really said at the beginning, I won't repeat the thank yous. We've divided the job, and I think that Raquel has been, but I just want to reiterate 2 thank yous. I said we were lucky to have Heather Snyder on the Alzheimer's Association helping us, and today she told me that the Alzheimer's Association was going to support such a meeting, because I think that one of the feedback that I've been having in this conference is whether we could maintain the momentum, because as we said, this is the only conference in which we can have this kind of debates and linking ADAD and DSAD. We get diluted in the big AD conference, starting with myself, most of my hat. I put my sporadic AD hat, and we don't have these kind of conversations in the big meetings. So I think it's absolutely necessary that we do that, and we can enter into a level of details and cross-fertilization that maybe in other meetings we cannot do. And there was an appetite for that. I think that given that we were funded in December, we announced this meeting in January. We had 150 attendees in person, 70 attendees online, 16 different countries. So a special thank for those that you flew over from different parts of the world and the US, long trips. So we're really grateful for that. I won't go over, but just again, thank you, because this costs money, and the funders and the organizers for supporting. And then the next meetings will probably be, a lot of us will be in the T21 Research Society in June in Rome, and of course the Alzheimer's Association, and we hope we see each other in those conferences. So with that, I wish you have safe travels back today, or enjoy Barcelona, as Raquel was saying, and so thank you very much.